morphologically clouds, dust and spear, and regression pattern of the vitreous seeds were observed after injection by doing examination under anesthesia and fundus photography on RADCAM. 38 eyes from 37 patients, out of which 51% were male and 48% female. Mean age of presentation was 27 and mean follow-up duration of 44 months. Treatment regime given a 71% received melphalan and topotecan only in 21% and melphalan in 7%. Number of injections that was required to control the tumor were 50% received 2 to 3 injections and 31% received more than 4 injections, maximum up to 6 injections to control the tumor, and 18% received 1 injection. So overall the glove salvage was 84%, and glove salvage in particular RB group, the lesser advanced disease such as group B and C had 100% glove salvage, and group D, which constituted the maximum number of eyes for the study, had 87% glove salvage and 75% in advanced disease like group B. Vision was also recorded in 57%, though taking vision in these children are very difficult. 57%, out of which 18% had light perception or counting finger, and 39% had visual acuity more than 660. The study concludes that 84% glove salvage rate with intravitreal chemotherapy, and it aids in preserving vision also, and 100% glove salvage with lesser advanced disease like group B and C. And long-term follow-up of the study suggests that it recommends the intravitreal injection in all the eyes with active vitreous cysts. Thank you. I would like to thank my my mentors and colleagues who have helped me to come up to this level and present here. Thank you so much.
Thank you, Dr. Padma Timlas. The next would be Namita Kumari, with the topic of plaque brachytherapy for refractory and advanced intraocular retinoblastoma in the Indian population.
Good morning, everyone. Thank you, ISO, for giving me this opportunity. So my title of presentation is the EPS paired Ruthenium 106 plaque brachytherapy for refractory and advanced retinoblastoma in the Indian population. So even in the era of chemotherapy, with lot of advancement in the form of intra-arterial chemotherapy, plaque brachytherapy still remains a valuable tool for secondary focal consolidation after primary chemo reduction. And various studies have supported for this. So the aim of a study is to evaluate the efficacy of this plaque brachytherapy as a secondary treatment for refractive and advanced retinoblastoma in the Indian population. So it's a retrospective case series, and over the last 4 years, all refractive and residual retinoblastoma patients having intraocular disease after chemo reduction with tumor height within range of within 8 mm were included in this study. All extraocular retinoblastoma patients were excluded. So the medical records of all patients who underwent these procedures were reviewed. The clinical details and also the tumor dimensions were noted. Coming to the outcome, so the outcome were measured in the tumor regression, tumor recurrence, and the final rest corrected visual acuity, treatment complications, eye salvage, and the metastasis. So this is the result. So 19 eyes of 18 patients underwent this procedure with mean follow-up of 24 months. And after this procedure, the 5 patients have good the rest corrected vision acuity within 6/9, and 8 patients have ambulatory visions. In 16 eyes, the tumors were regressed. 3 eyes underwent enucleations, 1 post-recurrence, and 2 having the residual disease. Unfortunately, 1 enucleation on the histopath examination shows a scleral breach, and patients subsequently developed systemic metastasis and succumbed to disease within 3 months. Coming to the complication of this procedure, 3 patients have milder form of cataract, not vision threatening. 9 patients have radiation retinopathy in the form of non-proliferative and proliferative changes, which were managed successively with the anti-VEGF injection in the cases of non-proliferative. 3 vitreous hemorrhage patients, 1 patient underwent vitrectomy under melphalan infusion, and 1 underwent enucleation, and 1 got treated with the anti-VEGFs. Coming to the discussion, our studies support the globe salvage rate of 84.21%, that is comparable to the other studies. Our study has reported a higher number of non-proliferative radiation retinopathy complications compared to proliferative one. However, successful management of radiation retinopathy with anti-VEGFs has improved the visual outcome in our 8 patients. So take-home message with my presentation is that the ruthenium-106 plaque brachytherapy is effective in globe salvage, especially in the advanced and refractory retinoblastoma, and successful treatment of the vision-threatening complication with the recent anti-VEGFs can improve the visual outcome. And at the end, what matters is their smiles. Thank you for your kind attention.
Thank you, Dr. Namita, for the impressive presentation. Seems that in this session we have a lot of topic with super selective intraarterial chemotherapy. So one of them will be taken by Dr. Rolika Bansal. Please, Dr. Rolika.
Good morning, everyone. So I'll be talking on triple drug super selective ophthalmic artery intraarterial chemotherapy outcomes in Asian Indian population. And we all know that the mortality rate has switched to a high survival rate in the past few decades. And the recent advances include intraarterial chemotherapy, which is basically given via the ophthalmic artery. And it makes it super selective because we hook onto the ostium and deliver the drugs. A very important paper that was written back in the days, and it was followed by multiple letters from the 3 important labs which changed the face of intraarterial chemotherapy, and came a splash of publications about the same, making it a very important part of our lives. So single drug, 2 drug, mixed drug, triple drug, various combinations have been followed by multiple centers, and we agree on that, and that's why we carried out a study to assess the efficacy and outcomes of triple drug super selective IAC in Asian population. So this was a retrospective analysis. We had 163 eyes of 157 patients. Study duration was of 10 years. And we included all the ones going for primary and secondary IAC with baseline metastasis, and loss to follow-up was excluded. The standard doses and drugs were given, terminologies we are well aware of. So we noticed that out of the active treatment patients, 9.5% patients were the ones who received IAC at our center. And the total number of IAC infusion, the mean number was 2.5, ranging from 1 to 3 only. So when we talk about unilateral and bilateral RB, we do have a difference in approach over here in developing countries. When we talk about giving IAC, which is an expensive modality, we give it preferably for unilateral patients. So definitely there's a selection bias here, and not for bilateral because we start with IVC. And these were the numbers that we had for primary and secondary IAC. We did have a major predisposition in group D and E. And as you can see that Group B responded well with 100% outcomes. Group D did well with 20% vision salvage, but otherwise life salvage and eye salvage had good numbers. Group E also we landed up doing a major salvage and eye salvage of 77%, which trust me is a high number. So it has been stated by Shields et al. That the word selectively has to be chosen very carefully, because you cannot just hop onto IAC. We should keep in mind the need for IVC in the patients. So when we talk about refractory cases, we had the second segment of secondary IACs given for refractory residual and tumor recurrences. The patients did extremely well, and these are certain cases with regress in 6 months had a saturation of IVC, and we just completed with IAC over here. Massive recurrence treated with IAC. Another one resistant to focal therapy did very well with IAC. Peripheral recurrence all gone with IAC. Optic nerve head recurrence all gone. And we did have even the patients with extremely tough tumors all gone with IAC. So we have seen extremely good responses. At the same time, there were cases with no resolution, and even with vitrecces, we prefer to proceed with enucleation, achieving a globe salvage of 54%. So out of the enucleated eyes, we saw the risk factors to be present in 29%, and they were treated with adjuvant chemotherapy. The review of literature has shown that what we tried to achieve here was a high long-term assessment, and we did have good salvage rates in group D and E. despite being the advanced cases. The interesting thing that we want to advocate is that the range of cycle is 1 to 3 only. So you're giving less number of infusions when you give the 3 drugs together, and we have a good follow-up right here. So we achieved the life salvage of 100%, eye salvage of 89 and 54, vision salvage of 25 and 60%, and this is not a small number. Just a brief thing about a project that we have that is I hope for the kids, and we are able to achieve a psychological balance, giving an encouragement aspect which has helped a lot of kids. And this is just,
What are these?
very happy, and this is how we treat the patients in Asian population. So we talk about incentivizing and
Are you happy?
making them more adherent to treatment. So I think I'm past time, so I would conclude with the following. Thank you so much.
Thank you, Dr. Rolika. Congratulations for your very impressive results. We will discuss about that later on at the end of the session. Now, we will invite Dr. Abhishek Das, which will be talk about also intraarterial chemotherapy. Please, Dr. Abhishek Das, sorry.
Good morning, everyone. So today I'll be presenting on intraarterial chemotherapy in our center, our experience for last 5 years. So we all know IAC is now as first line as well as a rescue treatment for RB, and there are established facts effective in unilateral as well as bilateral RBs, and commonly used drugs, everybody know melphalan, topotecan and carboplatin. So it was a retrospective study. We included 17 eyes of 17 patients, and all the comprehensive data was collected. We did all the patients' examination under anesthesia. Imaging was done with RETcam. We did MRI brain with Orbit. So coming to the results, we will start from the distance. So majority of our patients were from very far distance. They were from more than 250 kilometers. And you can see unilateral cases, almost 11 cases were unilateral and few were bilateral. And we divided into 2 groups, primary and secondary. So we did primary cases, almost 9 cases. So most of the patients, 53% came with leukocoria, followed by strabismus and red eye. And in the grouping, Group E was the majority in our series, followed by Group B, D, and last was C. So if you see the injection patterns, we start with double drugs, melphalan and topotecan. And you can see primary and secondary. The secondary group, they got 2 injections actually. The mean injections were 2. And with combined injections, we give 6 and 6 in each the group. And only 1 patient in each group received all the 3 drugs because of advanced disease. Coming to adverse effects, most common adverse effect we noticed is vitreous hemorrhage, and it was almost like 2 cycles. 2 patients had rhegmatogenous detachment with persistent relapse, and we had to enucleate these 2 patients. And we also observed choroidal ischemia, RP degeneration, subretinal blood, forehead pigmentation, third nerve palsy with complete ptosis and exotropia, which resolved over a few months. So this is the image. You can see the first image is complete ptosis, third nerve palsy. The second image shows exotropia. Third one shows forehead pigmentation. The fourth one is extensive RP degeneration after 2 cycles of intraarterial chemotherapy of melphalan and topotecan. And this was one of our patients which came with massive group D with massive seeds on the tumor, and after 1 cycle everything is gone and the entire tumor is calcified, and we did not give any other consolidation treatment also, and patient is doing very well. And Kaplan-Meier survival estimate, it also shows, IAC shows globe salvage rate is 93% till 5 years. So primary was done in 9 eyes with secondary, which was with adjuvant, intravitreal or systemic in 8 eyes. Mean age was 21 months. Mean interval between first symptom and presentation was 6.5 months, and each eye received 1.5 sessions of IAC. 6 patients had familial RB and 11 had sporadic occurrence. Globe salvage was achieved in 15 eyes, which is 88%, and mean follow-up was almost 29 months. So it was a retrospective study, a small cohort was there, but IOC was very effective in unilateral RBs without the need of any adjuvant therapy. And cost of IC in India is approx $500 to $1,300 US, whereas in intravenous chemotherapy, 1 cycle is approx $180. So there's a very big difference in the cost. but we found no statistical difference between the treatment modality between primary and secondary IC. And in our country, the private insurance, they don't cover any chemotherapy, but we encouraged our state government, and now recently our state government has included intra-arterial chemotherapy in certain schemes. So in Indian context, most of the unilateral group E RBs undergo enucleation, but we salvaged all our group E RBs. We have encountered adverse effects related to IAC and we have overcome it. Case selection is very important, and intravitreal chemo also plays an important role with active vitreous seeds along with the tumor. More studies are anticipated, especially from a developing nation like India, and overcome the various challenges we face every day. These are my references. Thank you so much.
Thank you, Dr. Abhishek Das. Now, we invite Dr. Kavita Punia. Dr. Kavita Punia, please come to the stage, which will deliver the topic of clinical radiological features and outcome of RB eyes with staphylomas.
Good morning, everyone. I'll be talking about clinical radiological features and outcomes of retinoblastoma eyes with staphyloma. Retinoblastoma is most common in primary intraocular malignancy of childhood. The staphyloma defined as outpouching of sclera with its curvature of radius being smaller than the curvature of surrounding eyeball. The staphyloma has been associated with various ocular conditions like myopia and stage glaucoma, trauma, but its occurrence in retinoblastoma is not documented. To date, no studies have specifically focused on clinical outcomes and treatment implications of staphyloma in RB patients. So we speculated that the presence of staphyloma might influence the prognosis and the likelihood of globe salvage. So our aim was to study clinical radiological features and outcomes of retinoblastoma eyes with staphyloma. So this is a retrospective case series of 13 patients from 2019 to 24 with ciliary staphyloma clinically or having scleral staphyloma on imaging. The demographic data, clinical and radiological features were analyzed from old records, and treatment outcomes were measured in the form of globe salvage, event-free survival and disease progression. We have divided the staphyloma in three categories: ciliary staphyloma, which is 5 mm from the limbus, pre-equatorial from 5 mm from the limbus up to equator, and posterior beyond equator. Results: total 13 patients were recruited with the mean age at presentation was 16.5 months and mean duration of symptom was 17.4 months. 9 eyes have group E RB and 4 had group D. In group E, out of 9, 1 eye had ciliary staphyloma and rest of the 8 had posterior staphyloma. While in group D, 1 eye had ciliary, 2 had pre-equatorial and 1 had posterior staphyloma. So the overall outcomes, the 3 eyes underwent primary enucleation, while 9 eyes underwent secondary enucleation, and 1 globe was salvaged with group D RB. This is the RADCAM image of group EI along with MRI image showing posterior staphyloma in group EI. In ciliary staphyloma, both eyes were enucleated and 1 eye had high-risk features on histopathology. And both patients had event-free survival after enucleation. In pre-equatorial staphyloma, 1 globe was salvaged and another one had event-free survival after enucleation. And this patient had no high-risk features on histopathology. In posterior staphyloma, out of the 9, 3 had high-risk features. 1 patient was died who had optic nerve involvement on histopathology, and 1 patient developed orbital recurrence 6 months after enucleation. This is the patient of group DI having orbital recurrence in inferior orbit 6 months after enucleation, having posterior staphyloma. In summary, posterior staphyloma were more common in group EIs, while pre-equatorial in group DI. High-risk features were more associated with posterior staphyloma as compared to ciliary and pre-equatorial. The pre-equatorial staphyloma had good prognosis and posterior had worse prognosis. In conclusion, in RB staphyloma discussion, in RB staphyloma could be because of tumor grows outward towards the sclera, which leads to stretching of the sclera. As our study was a retrospective study, so histopathological correlation is required. In our study, overall 0% globe salvage in group EI and 25% globe salvage in group DI. In conclusion, posterior staphyloma had more high-risk features on histopathology, more risk of local recurrence and metastasis. So they need more attention, and early diagnosis and treatment is pivotal for the RB treatment. Thank you.
Thank you, Dr. Kavita, for your very interesting results. Now is the time for the next speaker, Dr. Kanchan Sainani, with the topic of visual outcomes in RB survivors and factor predicting failure on vision salvage.
Doctor, could you switch to the other podium? Your presentation is on this side.
Good morning, everyone. Thank you, ISO, for the opportunity to present today. We have no financial disclosures. With improving survival rates and eye salvage rates in retinoblastoma, owing to the evolution of treatment, vision and visual outcomes has become more important. Poor vision-related quality of life has been reported, especially in bilateral retinoblastoma, further emphasizing the need for vision prognostication. Hence, the purpose of our study was to report the visual outcomes in retinoblastoma survivors. We reported outcomes in visual acuity of individual eyes, vision impairment in bilateral survivors, and we also discussed factors predicting poor vision outcomes. This was a retrospective single institute study, and we included patients who had a disease-free follow-up of at least 1 year. Foveal involvement was defined as tumor within 1.5 millimeter of the foveola. Descriptive statistics, chi-square test, and regression analysis were used for the results. A total of 222 children with retinoblastoma in 312 eyes were included. The number of eyes enucleated were 187, including 38 secondary enucleations. A total of 125 eyes were salvaged, of which 124 eyes had a vision follow-up with a mean visual acuity of 0.53 logmar. Only 28 eyes had visual acuity worse than 1 logmar. Age at diagnosis had a significant impact on eye salvage, but not on visual acuity of the salvaged eyes. With respect to disease severity, higher staging was associated with worse final visual acuity, and you can see that the mean visual acuity worsens as we move from stage A to E. The same was true for T categories of AJCC classification. Foveal involvement was independently associated with visual outcomes, and I'll explain this using a Sankey chart. Majority of the eyes with normal fovea resulted in visual acuity better than 0.3 logmar. The eyes with involved fovea had various visual outcomes, and when salvaged, had variable visual acuity ranging from 0.3 to 2.8 logmar. Most of the eyes with large tumor obscuring the fovea underwent enucleation, and of those that were salvaged had poor vision. Invariably, eyes with media opacity resulted in poor vision. We reported outcomes of bilateral cases separately. Age at diagnosis was positively associated with vision impairment in bilateral cases. When both the eyes were salvaged, none of our patients had severe vision impairment or blindness. Worse vision impairment was likely with a higher staging of the better eye in bilateral patients. With respect to the foveal diagnosis, Foveal status at diagnosis, I'll again use a Sankey diagram. Among the cohort with both eyes salvaged, there was no severe impairment or blindness. Mild to moderate impairment was found only when both foveae were involved. Patients with one eye enucleated, we looked at the fovea of the salvaged eye, and 76% of them had no vision impairment. When the fovea was involved, the visual outcomes were variable. Of course, there were outliers, patients who did better than expected and worse than expected in cases where there were treatments equally. To conclude, age at diagnosis significantly impacted eye salvage and impairment, but not visual acuity. Staging and fovea involvement were independently associated with visual outcomes, and in bilateral cases when both eyes were salvaged, we did not find any severe impairment or blindness. Thank you very much for your attention.
Thank you, Dr. Kanchan Sanani. So now, the time for Dr. Shanti to deliver the topic of tumor-associated blood eosinophilia, a prognostic portender of chemo response in RB children. Please, Dr. Shanti.
Is Dr. Shanti R in the hall? Dr. Shanti R.
Is Dr. Shanti here? Shanti R.
You can go on to the next speaker.
Okay, so Dr. Shanti R is not available yet. We're moving to Dr. Jessie Alberry. That's it. Oh, okay. Dr. Jessie Alberry will deliver the topic of liquid cool, a clinically validated molecular test for RB using an aqueous humor liquid biopsy. Dr. Berry, please.
Good morning, everyone, and thank you. These are my disclosures. I do not make any personal revenue from this clinical test. And today, I'm going to focus on that test. I think most of you know that in 2017, our laboratory was the first to introduce the use of the aqueous humor as a liquid biopsy for retinoblastoma, and it's now been well established and accepted that the aqueous humor is a source of tumor-derived cell-free DNA from our laboratory, but also laboratories around the world. But what you may not know is that for over a year now, we have had a CAP-CLIA clinically validated laboratory test using the aqueous humor, and it identifies tumor DNA both through low-pass whole genome sequencing as well as via a hybridization capture approach for SNVs. So let's focus on our results for the first 50 aqueous humor samples. We were able to have a feasibility of this clinical test of 96%. 48 of the samples had enough DNA for analysis. In terms of diagnosis of retinoblastoma, 21 aqueous humor samples were taken, and they all were positive for circulating tumor DNA in the aqueous. At the diagnosis of pseudoretinoblastoma, Coates, fever, PFV, no samples had DNA, so 9 of 9 were correct in a negative test. There's one false positive, which I will discuss. Our sensitivity thus is 100% and our specificity 95%. I'm not sure we will always do that well, but this was our first 50. So let's show you some cases. This is the aqueous humor in the right and left eye at diagnosis of a child with retinoblastoma. You can see that there are distinct profiles. The arrows show the differences. This is consistent with primary bilateral tumors. These tumors have different molecular features. We can also follow the aqueous for tumor response. Again, here's a patient, aqueous humor at diagnosis in the right and left eye. You can see nicely here, maybe not, 6p gain in the left eye, chromosome 6, that's high-level 6p gain. Child was treated with systemic chemotherapy. At the end of chemotherapy, aqueous was taken again. The right eye now shows a flat profile that's consistent with treatment effect. No further treatment was given and that eye is stable. However, In the left eye, the alterations persist, albeit at a lower level. This eye was still active and required significant intravitreal injections. We followed these injections until the eye normalized and stopped injecting only at that time. We can use the aqueous to identify MICAN amplification. You see that spike there. All three of these eyes required enucleation. This is a poor prognostic biomarker that you can now identify using the aqueous humor in a clinical test. A negative test also matters. This is a child who was referred for bilateral retinoblastoma, planned for enucleation. You can see an intraocular mass and a white lesion. The other eye, stalk, also a white lesion, somewhat atypical, but you can see aqueous humor, flat profiles. This is not consistent with a malignant process. This was fever. And here is our false positive, maybe, interesting case. Highly treated eye about 2.5 years after the last chemotherapy. You see, and this eye had been radiated, you see this development of a white fibrovascular mass. Avastin was given and aqueous was taken, and you see that there are alterations here, but they are not the common RB alterations that you see. That mass continued to grow despite Avastin. The aqueous was the same, exactly the same. And finally, 5 months later, there was now hemorrhaging, vitreous haze, and a growing white membrane. I didn't see obvious retinoblastoma, but I was not comfortable following this eye, specifically with repeated aqueous humor positivity, and thought maybe there was something under the calcium. Enucleation was done, and pathology did not show active retinoblastoma, which is why it's called a false positive. However, there was this prominent proliferative membrane showed metaplasia, large multinucleated basal cells with mitoses, and it is thought that it may be that the alterations we were seeing were coming from this. If you are interested, you can please take this QR code and you will see more about both the procedure that we use for the laboratory as well as clinical diagnostics. Thank you.
Thank you, Dr. Jessie. Now we will have a question and discussion.
Yeah, thanks. I thank all the speakers to also respect the timing. So now the papers are open for discussion. First, are there questions from the audience? Yeah, Mandeep.
Hi, can you hear me? Yeah, good. Jessie, thank you for that great talk. Really enjoyed it and great work that you're doing. Are we at the stage now where if you don't get a clear fundus view, so vitreous hemorrhage or cataract, can we now say that if this test is negative, we don't need to treat, we can just watch, or would you still be a little bit hesitant in that situation?
So we are using it clinically in the setting of cataract, often for safety before we remove a cataract, or if there's a period of time that we need to monitor to wait for safety, we do use the aqueous at that time. Is Prithvi here? Both Prithvi separately in his service and me in my service have had patients with blood in the eye and aqueous identified circulating tumor DNA consistent with retinoblastoma. Enucleation was done and was positive in both eyes. In Prithvi's case, it was planned for vitrectomy.
Okay. And then if you got to the point where the test is negative, would you carry on repeating it, or once it's negative, you leave it?
That's a good question. So we follow for negativity at the time of injections and often stop once it becomes negative. And that's a consolidative, right? Because we've injected, then the aqueous tells us it's negative. Unless there is a recurrence or something else, we wouldn't just automatically repeat it again. We need to have a clinical reason for the clinical test. And Carol has asked this question before. If you rush the test, it comes back in a week. The standard test is 2 weeks. I've heard from some people sending to our lab that it's taking a little longer. If that's true, please just reach out and we'll push them. Sometimes they don't know if we are going to make a clinical decision with the results or not, and so they hold it to make the runs cheaper. Thank you.
Thank you, Jessie. This is brilliant. Yeah, please.
Good morning. Thanks to all the speakers. We've heard a lot about intra-arterial chemotherapy. In our unit, we've noticed a spike in retinal detachments. And I noticed Dr. Das's presentation mentioned retinal detachment as a complication after intra-arterial. Our retinal surgeon has speculated that perhaps it's related to the fast shrinkage of tumour in IAC. And I just wondered whether Dr. Das or any of the other speakers have a comment on that. Thank you.
So your question is about retinal detachment following, right?
Yes,
Following
whether
IAC, right?
fast shrinkage related to IAC as compared to the
Yeah.
historical era of intravenous is a risk factor.
It's an interesting question, actually. We have observed, actually, that, in endophytic advanced disease, so group D with no retinal detachment at presentation, they tend to have more frequent regmatogenous detachment following upfront IAC compared to upfront IVC, so intravenous chemotherapy. I think Carol Shields has also made the same observation. So this is probably related to the dramatic and shrinkage of the tumor. There is no plasticity of the retina to follow at the edge of the calcification and the retina, and probably there are microholes. So this is something to consider, needs more attention in the future to see if we have in such cases there is better indication for bridge therapy with IVC first and then IAC. The good news is that even if there is a regmatogenous detachment, you can reattach this retina with an ab-external approach, what we use usually, and the other groups as well. It's adapted without subretinal drainage. We do a paracentesis, repeated paracentesis during the procedure, and so we can really tight the buccal and recover and reattach the retina in 8 out of 10 cases. And then you have the rest, the 2 that are not reattached, and some of them, require ab-internal approach. Yeah.
Yes, from the expert panelists, would you like to add comments?
Yeah, I just want to add to that to say that, there is an opportunity, at least with 2 of these presentations that I saw, and I think Rolika mentioned it as well in her presentation, that there is a bit of a selection bias because of how IAC is afforded and how IAC is not afforded. But I see that bias as an opportunity. Perhaps this is the time, most of the controls of, most of the studies that compared intravitreal to, intravenous to IAC were those that had historic controls. But I think you have the opportunity to actually have the same existing controls going forward. So I feel that that is an opportunity that will perhaps even tell us in this situation whether retinal detachment is truly more prevalent in IAC or if it's some other effect, because you have the ability to have those controls. So maybe just anecdotally, if I can ask Rolika, who's already at the mic, to comment on her experience with what she saw in her cohort and how that compared to intravenous chemo. And I didn't see that in the presentation, but perhaps you have something to add there.
Right. Thank you for that. As you have noticed that our patients were majority in the advanced retinoblastoma segment. That means group D and E. So we do have large tumors in our study. So none of our patients had retinal detachment. And our research group believes that that's because of giving a gentle and slow infusion, and you have to titrate the dose very well. If you're giving a higher dose and if you're pushing the drug faster, it can result into retinal detachment, as Dr. Monet as well mentioned. And with intravenous chemotherapy, we are doing a comparative analysis, as you have stated, because we have a cohort which is directly like the primary IAC, and then the similar cohort, which is IVC and then followed by IAC.
One
Thank you.
comment.
Yeah, we have time for two other questions. Yeah, please.
Yeah, so we have observed that, these detachments, if you're treating a peripheral lesion with extensive cryotherapy and then the patient is undergoing some chemo and there is sudden shrinkage, at the site of cryo we have seen the breaks, iatrogenic breaks, and it caused rhegmatogenous detachments.
That's for sure a risk factor. Yeah, thank you. Yeah, please, another question from the audience.
My question is for Dr. Kavita.
Yeah.
She talked about outcome in patients with retinoblastoma and staphyloma. Usually I'd consider staphyloma a high-risk feature for retinoblastoma, and yet I can see some of our patients went on to globe salvage, and I'm just wondering how you determined whether it was too high risk for globe salvage and which ones were for enucleation. Thank you.
Any?
Dr. Kapita?
Can you answer?
Yeah.
Yeah.
Please.
Good morning, everyone. Staphyloma is not stated as a high-risk feature in retinoblastoma. Usually, the optic nerve involvement or large choroidal involvement is used as high-risk feature, not staphyloma. Group DI with 6 cycles of IVC was recovered well after 6 cycles. To
Excellent. So, with this, we close actually the question part of this session, and I will announce the finalists for the best presentation. So we have the top 3 communications. Oh, it's over. So number 1, congratulations, Jesse, you are number 1. I also call to the podium Dr. Banzal for the triple drug super selective. Oh, okay. One after the other. Okay. Good. Dr. Eshier to come to the podium. You won the best 3rd presentation this morning. Congratulations.
session. Next, we have a special session by St. Jude Alliance Global and Regional Collaborations to diagnose and treat retinoblastoma. And for this, I invite Dr. Matthew Wilson and team to take the stage.
Can I have the slides, please? So good morning. It's a pleasure to be here, and I'd like to thank the organizers for giving us the opportunity to present our St. Jude Global Alliance, a strong partnership we have had with multiple foundations across the world. Today, I would like to highlight our global partners and the work that they have done across our regions. The history of St. Jude Global Pediatric Medicine arose out of the International Outreach Program, which I've been part of for my 25-year duration at St. Jude. In 2016, Carlos Rodriguez Galindo created the Department of Global Pediatric Medicine that suddenly morphed into St. Jude Global in the St. Jude Global Alliance. St. Jude Global is committed to the same core principles as the main hospital, that no child should die in the dawn of life. It is based on the core principles of capacity building, education, research, and advocacy. The St. Jude Global Alliance continues to get stronger across our 8 regional programs that parallel the WHO regions of the world. And I'm proud that retinoblastoma is one of the 11 transversal programs that transcends each area. The St. Jude Global Alliance consists of 336 institutions across 84 countries. We have 71 foundations we partner with. I am exceedingly privileged to work with the individuals on this stage and their supporters in the audience who cannot all be up here. I look forward to their presentations of how they have developed programs in low and middle income countries. Our first presenter will be Christiane Al-Haddad from the American University of Beirut in Lebanon.
Good morning. Thank you for inviting me. I will present retinoblastoma treatment at the Children's Cancer Center of Lebanon. I'm a pediatric ophthalmologist from the American University of Beirut. This is a brief timeline of our program. So in 2002, the Children's Cancer Institute was established at the American University of Beirut, and it took care of all children with cancers, including retinoblastomas. With increased referrals and in collaboration with the St. Jude Children's Research Hospital, our retinoblastoma program was established such that we receive patients receiving their IV chemotherapy at their local institutions and their focal treatments and eye treatments at our center. We acquired the RetCam, we optimized our focal treatments. In 2018, the ophthalmology department moved to a new facility with state-of-the-art equipment. And then in 2019, we added brachytherapy, and then ocular oncologists joined the group. 2020 was the year of the pandemic, and unfortunately, the Lebanese economic crisis, and the program survived. 5 years into the program, we reported our 5-year results and demonstrated feasibility of clinical coordination across borders. First column is before the program, second column after the program. As you see, there's an increase in the rate of regional referrals with now patients from Syria, from Iraq, and other neighboring countries. As far as outcomes, upfront enucleation decreased after the program, the use of radiation therapy decreased, and the percent of patients with bilateral vision increased. And this is 10 years now into the program until July 2022. And as you see, there was a consistent increase in the number of patients enrolled per year in the dark blue bar. This, however, dropped in 2020 due to the pandemic and the crisis. And we were interested to know whether this affected our outcomes. This was published just recently, November 2024. We reported our outcomes over a 10-year period and assessed the potential impact of the pandemic and the economic crisis. What we noted, globe salvage was maintained, 58% for bilaterals, 21% for unilateral cases. The percentage of bilateral vision actually increased despite the crisis. Disease group remained at a majority of groups D and E. Enucleation rate was 55% and mortality rate 1% over the 10-year period. And the first column is for the total 10 years. Second column is before the crisis, third column after the crisis. And of course, there was a shift now in the nationality of our enrolled patients being more Lebanese. However, there was no shift in age of diagnosis, no shift in laterality or gene testing. Program successes, standardized care with continuous coordination with oncologists, disease staging was centralized, common chemotherapy protocol was followed, challenging cases were discussed with the St. Jude team via teleconference, and importantly, we demonstrated sustained continuity in dire circumstances, of course with the needed support and collaborations. Continuing challenges are access to care, high rate of advanced disease, and financial constraints. I thank my team members and collaborators.
Our next presenter will be Yaqub Yusuf from the King Hussein Cancer Center in Amman, Jordan.
Good morning. Briefly, retinoblastoma in Jordan. The global retinoblastoma group showed clearly a huge discrepancy in survival between low and middle and high income countries based on the economy of each country. Jordan now the survival is 95%, while Jordan is low middle income country. But if we look what happened after 2003, before that the mortality was 40%, now it is 5%. So what happened in that time exactly? When we looked at Jordan, which is a small country, how to treat rare disease in a small country effectively, in a cost-effective way, we focused on two main concepts. Number one, centralization of care. If we can build the service in this small country for this rare disease in one center where all patients can be treated, by that we can build cost-effective capacity, and we can collect the experience for all the patients in one center, because again, it is rare disease. That's why we selected a pioneer center, which is King Hussein Cancer Center, to do this job. Second point, how to build the knowledge for such rare disease where the knowledge is really lacked. The best way that we selected at that time is using partnership and the twinning with St. Jude, Dr. Matt Wilson, to be a mentor for treatment for retinoblastoma. So what we have done, we started to introduce all diagnostic and therapeutic modalities for retinoblastoma in one center. We built the capacity over years, so that was not that expensive. And regarding how to treat patients, initially when we started, we had to consult Dr. Matt Wilson for every single case before starting a treatment, because we don't have the knowledge. By this mentorship and advice, we treated our patients. Now with years, the experience increased, the knowledge improved, so we became less dependent on consultations. The number of mandated consultations started to drop down, to an extent that actually in the past 5 or 7 years, we didn't consult for any case as a primary treatment. So we built capacity and we improved experience and knowledge. This was reflected in the outcome that we have published in 2021 in ophthalmology, outcome of treatment of around 500 patients with retinoblastoma, where we showed eye salvage rate stage by stage that is equal for the high income countries. This is very good success. Furthermore, if we look clearly at this curve, the mortality dropped significantly from 40% to 5%, and the overall eye salvage rate improved from almost 0 up to 65%. And the interesting thing in this curve, this improvement happened immediately. There was no lag period to get that excellent outcome. How that happened, this is described in this curve. You know, as a surgeon, if you are a cataract surgeon or VR surgeon, once you start your career, you need time to build experience. So the outcome in your early years is expected to be limited, and this outcome will improve over years while your experience is getting better. But this is dangerous if you are talking about life-threatening disease like retinoblastoma. But because we used twinning with telemedicine and mentorship, so we have an expert person who is oversighting every single case from day number 1, we guaranteed excellent outcome, mainly in survivor from day number 1. But over time, the experience started to improve, and that was not, the cost was not the outcome, because the outcome was better from day number 1. With Jude, we built experience without affecting the outcome for our patients. Furthermore, the benefit of building this service in this small country in the Middle East extended beyond the borders of Jordan. So far, we have treated around 530 patients with retinoblastoma. 2/3 of them are non-Jordanians. So actually, the benefit started for Jordanians, but then extended beyond the borders. Furthermore, we have established the retinoblastoma fellowship program, totally sponsored by the New York Eye Cancer Foundation. Thanks for Dr. Powell-Finger for that. And we have trained 7 international fellows from the region. So we benefit our patients, we benefit the patients in the region, and now we are educating people how to treat retinoblastoma. So in conclusion, this program at King Hussein Cancer Center in Jordan changed the natural history of retinoblastoma patients in the country and the region. Our results are comparable to the developed countries. Centralization of care for rare disease in a small country and the use of telemedicine and twinning saves time and effort through partnership that ensures the use of uniform treatment protocols for such rare diseases. And this benefit extended beyond the borders of Jordan. Thank you very much.
Our next presentation will be given by Tricia Alacasabas from Philippines General Hospital in Manila, Philippines.
Good morning, everybody. So in behalf of my colleagues who are in the room, Dr. Gary Mercado and Dr. May Dolendo, I will be presenting the state of retinoblastoma in the Philippines. So our country is in the map, is an archipelago, and Dr. Gary Mercado and I are in Manila, right, in the Orange Island, while Dr. May Dolendo is from Davao in the southern Philippines. So our country of 7,100 islands can be divided into 3 regions: Luzon, Visayas, the yellow one, and then Mindanao, the blue one, with a population of 105 million. So among the 33 million children below 15, retinoblastoma is the number 5 cancer in our population-based cancer registry. So we expect around 230 cases per year. Unfortunately, these children and their families face many gaps in their cancer care journey. Hence, only underdiagnosis, only 58 cases roughly are diagnosed per year. And then, if the median time to diagnosis is around 9 months. This is the IRSS distribution across the 3 regions, Luzon, Visayas, and Mindanao, and you can see that extraocular disease, that is IRSS stage 1, 2, 3, are actually about 10 to 40%. So, because of all of this, the survival rates nationally in our country is low. So looking back at the population-based cancer registry in terms of survival for the Luzon Island, Rizal, and Manila region, representing 12% of our population, the overall survival is only around 35%. Now this graph shows a national study of 11 centers nationwide looking at the outcome for IRSS stage 1, 2, 3, and 4. And you can see that abandonment of care in the purple bar ranges from around 10 to 40% as well. So currently, we have no referral pathway, but there are so many hospitals taking care of retinoblastoma. And in this study done by one of our colleagues, she looked at the capacity of these 61 hospitals and divided them into Tier 1, the low resource, Tier 2, and Tier 3. And in this table, you can see that I highlighted the limitations reported by Tier 3 hospitals in terms of access to MRI, even access to chemotherapy, in particular ocular prosthetics, radiation, and focal laser therapy. And for personnel, the shortage should be on radiation oncologists and geneticists. There are 65 pediatric oncologists treating retinoblastoma in the country and only 5 ocular oncologists. So what about governance and law? So we do have a national cancer control plan. We do have a universal healthcare law. Our country is the first focal country for the WHO GICC in the Western Pacific region, and we are working on a national cancer control plan. So in terms of UHC, the individual-based healthcare support is via our social health insurance PhilHealth, and these are the support values that they do have for each of the treatment phases of retinoblastoma. For example, for enucleation, the PhilHealth will provide $119 for the hospitalization for the OR fees and will pay the physician $148. But there is no package for examination under anesthesia or imaging that we do for surveillance of patients, and that is a gap. Now, in terms of national treatment protocols, we do not have that. Many centers do use the Retinoblastoma Metro Manila, which is patterned after the SIO-PODC retinoblastoma published by Dr. Shantada. And so for intraocular retinoblastoma, we do upfront enucleation for group D and E, followed by VEC for those with high-risk features. For orbital disease, VEC alternating with vincristine doxycycline, enucleation, then radiation, and so on. And so, but now we are now finalizing the Philippine Retinoblastoma Clinical Practice Guideline that was funded by the Pediatric Oncology Society, the Ophthalmology Society, our university, and then St. Jude Global. Now, in terms of early detection, our strategies included targeting the primary healthcare workers. We gave these posters. We lectured on the early warning signs of retinoblastoma. And now we have also incorporated the retinoblastoma screening on the National Health Examination form by these primary healthcare givers. So this is the form for 1 to 5, wherein if they detect on PE and on history a white pupil, strabismus, and bulging eye in the action, written down in the algorithm that they do need to refer to an ophthalmologist or a pediatric hospital. So our centers, Philippine General Hospital and Southern Philippines Medical Center, have a more than a decade-long collaboration with Dr. Matt Wilson, with Dr. Carlos Rodriguez Galindo, and St. Jude. And we are leading together the St. Jude Asia Pacific, together with the St. Jude Asia Pacific team, this monthly Southeast Asia Tumor Board, wherein 18 institutions in 7 countries regularly present their cases. And in 2023, there were 18 retinoblastoma cases presented, and questions were on pathology, diagnostic imaging, and radiation. We are also part of the cohort of the profile for retinoblastoma, and here is our scorecard. In terms of national context, personnel, service capacity, diagnostics, surgery, patient, and outcomes. And this will help us improve our center better. So, through this decades-long collaboration, our center, PGH and SPMC, have become the national retinoblastoma centers of excellence for the country. And although we have much to do, so for my center, our 3-year overall survival is 54%, ranging from stage 1 at 90.6%, abandonment-sensitive survival, to stage 3, 16%. And for Southern Philippines Medical Center, through the years, 2005 to 2023, we have shown in the red box a drop in the abandonment rate from 26% to 8%. As well as a drop in the refusal of treatment. So to conclude, there really are many gaps in the Philippine retinoblastoma service delivery in terms of early detection referral, in terms of treatment, equipment, and human resource. But there is hope. We have shown that public hospitals, through national, international collaborations, can improve their outcomes. And the goal is now how to spread it within the country, and hopefully, like Jordan, maybe spread it within the region. So we have done this through protocol-based treatment, MDTs, and patient navigation. And so together, we hope that we will achieve the goal of 60% survival for RB by 2030. And our plan now is to embark on a national retinoblastoma tumor board, much like a telemedicine, and make early detection and referral a priority. So I'd like to thank St. Jude Global, I'd like to thank Dr. Matt Wilson, Dr. Carlos Rodriguez Galindo, and my colleagues at the Philippine Society of Pediatric Oncology, PAO, and the Department of Health. Thank you.
Our last presentation for this session will be given by Dr. Jifa Ofori from the University of Ghana. She will be updating us on the progress in sub-Saharan Africa.
Thank you. Good morning. I'm presenting on behalf of my colleagues in sub-Saharan Africa, especially Nigeria, Ghana, and Kenya. Sub-Saharan Africa shares in a greater burden of retinoblastoma, characterized by limited awareness, lack of resources, late diagnosis, and then lack of treatment access, resulting in very low survival rates as depicted in the map below. However, over the past decade, many efforts have been made in the creation of awareness, early diagnosis, and treatment of retinoblastoma, with some modest achievements. A 7-year trend in presentation of retinoblastoma in Nigeria showed that late presentations like proptosis reduced from 55% in 2013 to 10% in 2019, whereas early signs such as leukocoria increased from 22% in 2013 to 82% in 2019. Similarly, in Kenya, delay in presentation reduced by 3 months. Presentation of extraocular disease also reduced from 37% to 17%, and the 3-year survival more than doubled, with increasing from 26% to almost 70%. In the past decade, treatment of retinoblastoma in sub-Saharan Africa has mostly been through enucleation and then giving of systemic chemotherapy. But currently, few countries in the sub-Saharan Africa can boast of the availability of almost all the treatments, medical and surgical treatments for retinoblastoma. Data from a comprehensive retinoblastoma treatment center in Ghana showed that prior to 2017, though enucleation was the main form of treatment for retinoblastoma, the number of eyes that were starting on sparing therapy increased to about 21%, and the number of eyes that were saved increased to 17% in 2003. Also, patients presenting with primary palliative treatment reduced from 25% to 4%. One of the importance of global collaboration is that it ensures a multi-stakeholder approach. And this has been achieved in sub-Saharan Africa. And this has been shown by increasing international expertise and funding, increase in capacity building, and then successful models that have been used in similar contexts, meaning that we don't have to reinvent the wheel. Emphasizing the need for a collective action in the treatment of retinoblastoma in sub-Saharan Africa. Another importance of the collaboration in sub-Saharan Africa is the fact that it strengthens regional efforts. Currently, there are many centers in sub-Saharan Africa that have regional retinoblastoma treatment centers, and there are training programs available for members of the multidisciplinary team. And also some of the hospitals have public-private partnerships, ensuring that patients are able to receive all kinds of treatments for retinoblastoma. Our vision for the future is to continue to enhance collaborations with our international and regional partners for our multidisciplinary team, and to improve and provide other modalities of treatment available for retinoblastoma that are currently not available in sub-Saharan Africa, like plaque brachytherapy, which is present only in South Africa, and also to give to our retinoblastoma survivors customized ocularis services and in future genetic services. I'd like to acknowledge our collaborators who are partnering with us and slowly turning the tide of retinoblastoma in sub-Saharan Africa, transforming lives and giving families hope where there was once despair. Together, we are proving that when the world unites for a common cause, vision is not only preserved, it is empowered. I'd like to thank my mentor, Dr. Veresuan, who has supported the fight of retinoblastoma in Ghana. Thank you all for your attention.
Audience, what has been the single greatest challenge in establishing your program?
So the challenge is multifaceted, but the main challenges were getting those patients in before advanced disease, the time to diagnosis, getting them to the right place, do their EUA, do the diagnosis, and start the treatment plan.
I think similarly to Ghana, too, the problem is really multifaceted. Mainly, the greatest problem is the creation of awareness and then the availability of treatment all over the country. And of course, funding, because treatment for retinoblastoma in Ghana is quite expensive. So funding is one of the greatest challenges that we have.
Now, in Jordan, I think there were two main challenges. Number one, to convince the high administration about the importance of treating rare disease. We have in Jordan, initially they started by 3 or 4 patients every year. So does it worth to buy a RitCam with the TTT, with the cryotherapy and these machines to pay that money as investment or not? This is number one. Number two, to convince the ophthalmologists and the other people to send all the patients to you. Because if you have Pioneer Center to treat the disease, it means there's some sort of legacy for that center. And that will be taken from the university hospitals, the military hospitals, the Ministry of Health. So sometimes it was difficult to convince people. But again, by personal correlations, everything could be done.
So, to repeat, right, the issue is the referral pathway. It is quite easy to build the capacity of the center. There is a formula, like what was presented earlier. It's having the manpower, it's having a multidisciplinary team, it's communication, it's protocol-based treatment, and it's telemedicine with international collaborator and partner. But the referral pathway at the national requires governance laws, as well as cooperation with primary.
All right. With that, we'll conclude our session. Quick comment, May?
Yes. So I agree with everybody that the problem is multifaceted. But I think the major problem is really having the a trained multidisciplinary team and infrastructure to treat retinoblastoma, because even if you see them early, if you have no place to send them to, they will progress. Thank you.
Right. Thank you for all our teams. Thank you for being here and sharing the journey with us.
Thank you so much, Dr. Wilson and team. Next, we have a paper session on retinoblastoma. And for that, I call upon Dr. Ashwin Reddy as chair, Dr. Dipankar Das as moderator, and our expert panelists, Dr. Christina Stathopoulos, Dr. Guy Negrete, and Dr. Usha Singh. Can I also quickly check if Dr. Reza Mirshahi is in the hall? Dr. Reza?
Right, welcome everyone. This is the retinoblastoma session. Paper 6, retinoblastoma 1. There'll be a short list of 3 winners at the end, and a gold medal will be given to the best paper. So thanks for attending. And without more ado, I just hand over to Dr. Das to introduce the first speaker.
Good morning, everybody. So I'll be inviting the first speaker, Dr. Reza Mirshahi, to present her paper on innovative large language model for retinoblastoma chatbot.
Dr. Das, I think Dr. Reza is going to take a minute. He's coming from another hall. We can go on to the next speaker.
Okay. So the next speaker is Dr. Bijita. She'll be speaking on artificial intelligence on machine learning in ocular oncology retinoblastoma, experience with a multifocal cohort. Dr. Bijita.
Yeah. Good morning, everyone. I'll be talking about artificial intelligence in RB, our experience in a multiracial cohort. I don't have any financial interest to disclose, and these are the abbreviations I've used in the presentation. Sorry about the glitch. Yep. So most of you are actually co-authors on this paper, which is very beautiful and talks about how far it is for a child with RB to reach the nearest treatment center. It sounds unbelievable, but the maximum distance was 10,000 miles. That's what it looks like, which is almost a year of running. Nearly 2 months of road travel or 20 hours of air travel. But AI and technology can bridge this gap in seconds, and that's how we started off our work on AI in RB with the intent of developing a screening tool that we can to detect RB at an early stage. So 2 years back, Dr. Kaliki showed that we could train an AI model to detect and classify RB in an Asian Indian cohort, and that's where we left off. We were at sensitivities of 56 and 82% respectively for Group A and Group B RBs. There was definite scope for improvement because we were looking at it in terms of developing it as a screening tool. That's when we decided to collaborate with the Ocular Oncology Service at the Wills-Eye Hospital in order to get a broader spectrum of tumors so that we are able to look at more of Group A and Group E ICRB tumors. But we also knew there was more in store for us because the eyes were not going to look the same way given the background fundus pigmentation. So this was a collaborative study and patients awaiting ocular oncology services at the Wills-Eye Hospital from July 2022 to June 2023 were recruited. We took the date for seeing fundus images, and we also made note of the parent-reported race. So we used multi-label classification model of deep learning and computer vision techniques to look at the optic disc, blood vessels, tumor, and other features. When we ran the model that worked with Asian Indian eyes, we saw that it was not great. So we did a bit of tweaking with the optic disc detection, blood vessel detection, tumor detection, and hemorrhage detection. And the rest of it was more or less like the way we ran it before. That is, 2 ocular oncologists labeled it, and this labeled was matched against what the AI model said for a particular image, and finally that particular eye. I'll take you through how we encountered challenges when the model came across a differently colored fundus. So the group A and B tumors really blended in the Caucasian background, which is more reddish. So for that, we retrained, tested, and validated the model against multiracial data, ensuring that it saw good amounts of A, B, C, and D tumors. And it also could not distinguish against the red in the background of the fundus, the blood vessels, and the hemorrhages that it would see over tumor. So for this, we added a pre-processing step to perform color segmentation and enhancement so that it detects this red better and it sort of sees how we would see it as black and white. And then that went for final computing. With these two steps, we retrained the model. And then this is a little bit interesting challenge that we encountered. So all these that you see are images of the same eye as you would take from the red cam when you're examining a child. Now, the model identified these images of the same eye as group B because it saw a good amount of normal retina around it and no other features. But it also identified these images as E because there was not much of normal retina around the tumor. So it was like filling the eye. And we had initially taken that we were okay to overclassify tumors, but with the majority concept, a lot of B, C, and D started becoming group E, and that's not what we really wanted. So we added a two-step aggregation here and changed our threshold that we would take the majority of the within the labels above a threshold of 65%. And so here are the results after we made these modifications for the multiracial cohort. Over 2,000 images were analyzed. A majority were group B and of white race. These two grids show how the numbers matched against the ocular oncologist's label of the image and the eye against the group label assigned by the model. And we can see that all of them are, most of them are clustered around the diagonal, which is what we wanted. And where we left off, so we did see a definite improvement once we added more information to the model and made adjustments. The sensitivity went up from 56 to 74%, and in group A, and from 75 to 88% in group B. The rest of them remain more or less the same because it was already relatively good at those. So here are examples. What you see as green is how it's identifying the optic disc, and the blue bounding box is what we call, that's how it's picking up the tumor in that image. So this is how it's picked up a group A tumor, which is quite small, in white, African American, and Hispanic races. And those are examples of group B tumors in different races, group C, group D, and E tumors. Although this was a relatively diverse database and it showed that the efficacy of the eye model varies for picking up retinoblastoma in different races, there was quite an unequal distribution. So it was predominantly a Caucasian data set with few African American, and a minority were Asian Indian and Asian Oriental. Also, we still could go higher up on the numbers of group A and B that we could train it with. In conclusion, AI is a powerful tool that can be trained to detect retinoblastoma in various races. Going forward, multi-centric collaborations and data sharing should definitely improve the accuracy in all kinds of tumors. I'm greatly appreciative of my mentors for this opportunity and the entire team who made this possible. For those interested, the paper is available online. Thank you very much.
Thank you, Dr. Bijita, for excellent presentation. Now I call upon Dr. Reza to present the first paper on an innovative large language model for retinoblastoma chatbot. Dr. Reza.
Good morning, dear professors and colleagues. It's an honor for me to be here and present this paper regarding an innovative large language model for retinoblastoma chatbot or assistant. First, I should thank my colleagues, especially those in Chashmiyar company that helped me to make this project possible. Throughout my slides, you can see these cute masterpieces from our retinoblastoma patients, and stay tuned that I have a surprise for you in the end. Here's the outline of my presentation, and you can see me here sitting wearing a ninja headband. So when I asked the ChatGPT to define large language model, it gave me this paragraph. As you all know, this is a very competitive field now, and many multinational corporations are working on them, and many models are available online. So I want to show you my stream of thoughts and how it led me to the point where I was persuaded and even obliged to use large language model in clinical practice. My first challenge was responding to parents' questions. So I first created a WhatsApp group so the parents could share their question with me and I would answer them. But naturally, I'm not available all the time. But ChatGPT is open 24/7. And when we assessed its responses to many RB-related questions, we found that many answers are valid, however, not very empathetic. So my next challenge was the documentations of EUAs. As you all know, it can be time-consuming. It's currently done by my residents in our center and under my supervision. However, sometimes errors happen. It's in human nature. And sometimes, every now and then, I have a challenging case a case like this that I should consult with my seniors. So to overcome these challenges, I thought, what if I could fine-tune an LLM? I developed this case and asked ChatGPT the best management for it before it reads an ocular oncology textbook and after it reads it. As you can see, before reading the textbook, the answer is more general and not very specific. But after reading an ocular oncology textbook, the answer is to the point and more specific and more detailed. So we decided to use retrieval augmented generation, which is a framework that integrates large language model with retrieval system. It means that instead of relying only on its pre-trained knowledge, the large language model can access external databases or knowledge sources to generate responses based on the most up-to-date and domain-specific information. And we use Meta's Llama's model for this matter. Here you can see the framework of our project. We feed different books and papers to the large language model. We used some codings to retrieve the patient's records, and with the help of an open source AI with the name of Whisper, we managed to enhance the speech recognition so we could retrieve a patient record and edit it and give it back to the database. So the advantages of a retinoblastoma chatbot is it helps ophthalmologists to read and edit medical records. It can aid in diagnosis of retinoblastomas. For example, it can support your grouping classification of the disease, and it can support treatment planning. So in future, we aim to stand on the shoulders of giants by gathering different cases of retinoblastoma managed by local and world experts and feed them to the model. So the model can think like an expert and give advice to us. And we aim to integrate a specific deep learning models such as these that can segment a tumor in the fundus photo. And in future, we think we can do real-time analysis of indirect ophthalmoscopy images, and the sky's the limit. So here is a handwriting of one of my patients that is practicing alphabet. He's a one-eyed patient, and the miracle is that he can see and write this beautifully with this fundus. And so I learned from him to never give up.
Thank you, Dr. Reza Mirashai, for that excellent innovative model on innovation. Now I call upon Dr. Matthew W. Wilson for his paper on the analysis on teleophthalmology through online mentorship over a 20-year period the importance of education and capacity building.
Always good to get more steps in. I'd like to thank the organizers for allowing us to present our data, which represents a 20-year history of teleophthalmology in partnership with Orbis CyberSight. I have no financial disclosures relative to this presentation. Telemedicine is widely used for diabetic retinopathy, retinopathy of prematurity, and other ophthalmic disease. We are a digital platform ripe for using. There is limited research, however, on the use of teleophthalmology in retinoblastoma. And we've heard prior presentations on AI just before myself. The goal of this study was to explore how Orbis CyberSight impacted the capacity of treatment and management in children with retinoblastoma through online mentorship, and to assess the efficacy of online mentoring through disease-specific knowledge change over time. For those unfamiliar, Orbis CyberSight is a platform online developed by Eugene Hedelston in partnership with Orbis International after a trip to Cuba in a desire to continue mentoring his mentees in pediatric ophthalmology and strabismus. The platform involves the mentee submitting a case to a designated mentor based on disease-specific diagnosis. Clinical history, family history can be uploaded, images transferred, reviewed, and treatment plan organized between mentor and mentee. We performed a retrospective review of Orbis CyberSight consults performed over a 20-year period. Each case was scored from 0 to 39 using points awarded across 6 categories: patient history, clinical findings, grouping, staging, diagnostic findings, treatment plans, patient and ocular outcomes. Data points were listed in the table and extracted as a binary outcome, present or not present. Data were analyzed in a linear regression model to identify changes over time. We identified 653 consults over 20 years from 38 mentees and showed significant improvement in total points from first consultation to last consultation, with points increasing from 17.7 to 19.8. When we look at specific categories, we showed significant gains in clinical history, grouping and staging, patient and ocular outcomes. Not surprisingly, there was a decline in patient history over time as consults and conversation between mentor and mentee evolved and became more targeted to problem-focused areas. Diagnostics and treatment plan remained stable over time across all mentees. This, we believe, is due to resources available in our mentees' institutions. We examined each mentee who had greater than 10 consults, of which there were 7. There was not a consistent decline or improvement across the mentees. However, each mentee showed improvement in at least one category. Specifically, I would draw attention to Mentee 4 and Mentee 5, which had the greatest number of consults. Mentee 4 reflecting an upper middle income country, and Mentee 5 reflecting a lower middle income country. And we see that the gains were greater in the lower middle income country as we were able to build capacity of that institution over a 20-year period. In conclusion, the 20-year mentoring experience has demonstrated that online mentorship via Orbis CyberSight can include retinoblastoma-specific knowledge as assessed by the mentee consultation scores. Teleeducation provides an impactful opportunity to advance disease-specific capacity, particularly in low and middle-income countries and low-resource settings. Our study has revealed the importance of utilizing communication, digital technologies, which are ripe for AI, and to increase capacity and improve retinoblastoma over time. Principal limitation of this study is the retrospective nature, and the platform was not designed for retinoblastoma. It was designed for pediatric ophthalmology and strabismus. Further research is needed in teleophthalmology and retinoblastoma, and as we've already seen, there are multiple opportunities and paths forward to build collaborations. It will be important to explore how specific programs can grow and improve outcomes when these resources are used to improve mentorship and leverage our collective global community to improve retinoblastoma outcomes. Thank you.
Thank you, Dr. Matthew. Now I'll call upon Dr. Dennis to present the AMCC program in sub-Saharan Africa to improve the management of retinoblastoma? Dr. Dennis.
Could you move on to the
Please,
other
you
podium?
can come to the other podium.
Okay, it's better. So the AMCC is a non-profit French organization dedicated to the care of retinoblastoma in sub-Saharan Africa, where there is a high number of retinoblastoma cases with usually extraocular presentation, which means to sometimes a high mortality. The first program of the AMCC started in 2011 with the aim to increase the survival rate by improving an early diagnosis for retinoblastoma, which means, in this context, an intraocular disease. For this, in the method, it was decided to train a multidisciplinary team, which mainly concerned ophthalmologists, but also oncologists and ocularists, and trained to perform enucleation, and in some dedicated cases, conservative management, and the association could also provide dedicated equipment. Of course, also as aim as the support for all the diagnosis campaign and data collection. The program started in Bamako, in Mali, and then progressively extended to other countries. And in 2018, the Bamako's team provided their results, and they proved that survival could improve from 50 to more than 80% in case of unilateral intraocular retinoblastoma treated. They also proved that local prosthetic rehabilitation is possible for all children after enucleation, and in some selected cases, conservative treatment was also possible. So it means that that's a proof of concept. It's possible to improve the care of retinoblastoma. But from this first program, lessons were learned, and one of the lessons was that you need a structured sequence if you want to try to improve the care. The first step is the training of the MDT in a central center and provide the equipment to this team. But the second step is to only after try to improve the geographical and financial accessibility to the center. And then only as a third step, try to improve early diagnosis and the referral pathway. So it means that only when a trained team is effective, but it's not so easy and it needs times. So then, since after the first program, a second program started in 2019 for 10 years with the aim of curing at least 60% of all children with retinoblastoma in dead centers in 2030, which is in line with the WHO GICC objectives. For this, Dr. Karim Hassani, a pet oncologist in Kinshasa, maybe you know him, joined the team as a full-time dedicated manager of the program. Indeed, he's the king of the program. And of course, there is also the huge work of Dr. Laurence Desjardins and Professor Pierre Bay, retired from Institut Curie. But all the work is done by all the involved MDTs around Africa, and I just joined the team 3 to 4 years ago. About the teams, in October 2024, there were 30 teams in 23 sub-Saharan countries that take part to the journey of AMCC. And, well, it can take more than hours to discuss about all the program. It's not the goal. And it's not also the goal to present selected results, because the results belong to the teams and not to AMCC. So I would like more to focus on the program and some of the aim. So one aim is the training of the MDT, mainly ophthalmologists, to be able to perform enucleation. And for this, through MCC, there are short-term training programs in some sub-Saharan African countries, and if required, in European countries. So through the program, an online retinoblastoma tumor board was created, and it takes part every 2 weeks on the online Arbinet platform, thanks to Dr. Fabian. And in that platform, it's able to discuss about diagnosis and to share experience of treatment and also follow-up of cases. Well, launching retinoblastoma conservative management is difficult. It works well in some countries, but it still needs on-site hands-on training in some countries, and we have to do it again in the future. Of course, the MDT is not only ophthalmologists and pet oncologists, it's also prosthetists, ocularists to improve the physical rehabilitation after enucleation. And it's also anesthesiologists. You have to train all the team. Meeting and workshop are essential because you can share experience, discuss with the team, listen them, and try to create a dedicated program for for each country, because there is not the same country in the continent. You have to have dedicated program, and here is some of the example of the meeting. Equipment is of course essential to provide, and it's the best way to reach, of course, the objective. Early diagnosis for retinoblastoma is essential, but it's difficult because it takes time. And we have the feeling that it's easier if you have the support of a local organization to help you. And there are many ways to do it. And maybe you know the GLOW, which is an association that can help you to provide pictures of children in your country in dedicated languages to try to target more precisely some part of the population. Advocacy, of course, it's essential, but it's also difficult. For example, to try to increase the access to the treatment or reduce the cost of enucleation. Through the program, we can add fundings for surgeries, but it's not so easy, and at one point you need to reach the Ministry of Health, and it's not so easy to reach Ministry of Health. Of course, data collection and publication are important, and maybe most of all, collaboration, because you have to learn from others, discussing, and I hope we have not forgotten too many collaborators, and sorry about that if we did, but you can't work alone. So part of the job has been done, but there is still a lot to do together. And well, there are just some of the aim for the next few years to try to increase awareness of early diagnosis of retinoblastoma. Also to try to increase the efficiency of the program by facilitating children access to care. And for this, we would like to create what we call secondary centers dedicated to diagnosis and enucleation. And the most advantageous has to be still referred to the University Central Center in the country. Of course, on-site support is important, and also publication. It's important for fundings to know where you are and where to go. Also for advocacy and collaboration with the big aim of sustainability around all the programs in the next few years. And I thank you for your attention.
Thank you, Dr. Dennis. Now our pleasure to call upon Dr. Didi Fabian to present his paper on availability of diagnostic and treatment modalities for retinoblastoma management in 2004, a global study. Dr. Didi.
Thank you. I compliment you, Dennis, and the AMCC team on really incredible work that you do in Africa. And thank you for the opportunity to present here. It's been 7 years since the first global RB investigation. In less than a month time, we're expecting to receive the presentation data from RB treatment centers across the world. We already have the list of available modalities in each center and country, and this is the focus of this talk. It's important, however, to remember that having the appropriate modality is crucial, but not enough on its own. This is taken from the 2020 outcomes study, and it shows a profound gap in survival outcome depending on the economic grouping. Now, since 2017, numerous interventions have been implemented, particularly in low and middle income countries, with the ultimate goal of improving RB outcomes. Here's one example, AMCC again, Laurence Desjardins introducing diode laser in Congo. Altogether, new cryo and laser machines were given by AMCC to centers in Mali, Senegal, Ivory Coast, Madagascar, and Yukon. The list is long. My hospital, Sheba Medical Center, was invited by Dupé de Molopopola, who I believe is here, to introduce the first IAC just last year in 2023 in Nigeria, a very populated country, and on the right you can see our interventional radiologists in a treating session, in a teaching session together with the local physician. ISO Africa, you saw in the last presentation, so this was in 2023 in Mombasa, an academic educational intervention, and there are so many more examples. In terms of the 2024 global study, we now have nearly 150 countries participating. Highlighted in blue are new participants, with overall 50 new countries in 2024 compared to 2017. In this presentation, this analysis, I'll include data from 142 countries. In terms of participating centers, we have significantly more compared to 2017. Back then we had 278. Now we have, from this morning, 441. This video was made about a month ago and it's not up to date. So nearly 1.6 times more than 2017. And how was that done? So in an effort to increase the capture rate, we focused on locating new treatment centers that had not participated previously, particularly in large, heavily populated countries. For example, India. In 2017, we had 18 centers, now 34. Now for the list of modalities and the comparison, 2017 to 2024. So MRI was available in 75% of the countries then, and now in 90% of the countries. Genetic testing was available in under 40% and now in over 50%. Bear in mind that some centers outsource this service. Enucleation, per definition, to participate in the study is done by all treatment centers. Pathology was available in 95% and now in 98%. I don't know if this will be a surprise for you, but intravenous chemotherapy was and still available in 94% of the countries. Other ways to deliver chemotherapy, so IAC was available in under 40 and now in 46%, and a significant increase in the number of countries using intravitreal chemotherapy from 52% to 69%. Focal therapy, cryo and laser therapy from 60 or 60+% in 2017 to about 76% in 2024. And finally, radiotherapy, so plaque from 30.7 to 35, and a decrease from 70 to 68 for teletherapy, external and protobeam radiotherapy, probably because those new countries that were added lacked this service. Here we compare 127 countries that participated in both 2017 and now. Diagnostic and treatment modalities are now more widely available, as you can see, with most improvements seen in low and middle income countries. So in the bottom left, for MRI, for example, so 5 low-income countries had MRI, and now it's 14. In high-income countries, the number did not change. For intra-arterial, there are no centers in low-income countries, but a significant increase in lower middle-income countries from 6 to 16, and the same trend for other modalities, so intravitreal, cryo, and laser. So in conclusion, diagnostic and treatment modalities are now more widely available, especially in low and middle income countries, together or combined with other interventions such as early diagnosis programs, education, involvement of stakeholders in all levels. Hopefully this will be associated with improved outcomes, and stay tuned for the global RB study results very, very soon. And I would like to thank all collaborators, you and many others who are not here, for participating in this study. Thank you.
Thank you, Dr. PD, for this global study. Now I'd like to invite Dr. Usha Kim for our paper on sequential strategy for rapid molecular prognosis of retinoblastoma.
Thank you for the opportunity. There are no financial disclosures to make. As you all know, it's the most common pediatric intraocular tumor and the first cancer to be described as a genetic disease. The inheritance patterns are 2 different types. One is the non-heritable, which is about 60%, and the heritable formulates about 40%, of which 20% is unilateral and 80% is bilateral. Though the treatment strategies have evolved, genetic studies have played a major role in understanding the disease pattern and planning the management. Multiple centers across the globe are offering the genetic testing services. The cost of the test varies from about $2,000 to $2,500. So the genetic testing can provide a sense of relief from uncertainty, helps people make informed decisions about managing the disease. A negative result can eliminate the need for unnecessary screening tests, and a positive result can direct a person towards available treatment options. So retinoblastoma is caused by retina-specific alteration of RB1. Inactivation of both alleles are necessary for the disease initiation. So we derived a multi-step process that involves Sanger sequencing and multiplex ligation-dependent probe amplification, which gave us results up to about 90% of the cases, and further epigenetic analysis of RB1 promoter by methylation-specific MLPA gave alterations in about a total of 95% of the cases. This apart, next generation sequencing methods such as targeted or whole exome sequencing detects all these alterations in a single step, but we need a lot of samples to do this. After a pedigree charting, DNA is isolated from the blood and the tumor samples using the suitable kits different for blood and tumor. The quantity and the quality of the isolated DNA is checked by the qubit fluorometer and the agarose gel electrophoresis. Sanger sequencing is used to detect the point mutations and multiplex ligation dependent probe amplification. That is used for deletions and duplications of the RB1 gene. Now this MSMLPA is done for detection of the promoter methylation in RB1 gene, which is done only in tumor sample, and the next generation sequencing methods for the 17 genes other than the RB1 are targeted, and if we need be the whole genome sequencing were employed to detect the single nucleotide variations, that is SNV and copy number variants. So we set up the lab, and genetic analysis was performed for 536 patients. This model can easily be replicated to any molecular biology lab with minimal resources. With all the methods and high throughput instruments in place, we can complete the analysis starting from sample collection to report generation in about 2 weeks. Genetic analysis and counseling benefited 536 patients and their families. Patients with mutations were about 343, without mutations were 193, families with mutations were about 41. Analysis indicate that 56% of cases are germline and 44% sporadic. Patients with mutations need a close monitoring and further follow-up with the treatment. Family members need to be screened to identify whether it's de novo or familial. Familial mutations are identified in 7% of the RB patients. If germline, their siblings and offsprings have to be checked clinically and genetically. No mutation in blood indicate that there will be no inheritance, and it is only sporadic. So more than 100 mutations covering a diverse spectrum such as nonsense, missense, frameshift, splice were identified by the analysis, 20 of which are novel, and these are being utilized for the pathogenic role that it's playing. In addition to genetic changes, there are some epigenetic factors that can cause RB1 inactivation. The technique of MSMLPA was optimized to detect the promoter methylation. Here is one case where unilateral RB without any family history was found to have a promoter methylated in both the alleles. The only thing is it need not be inherited to the next generation. So here is one example. Proband presented at 4 years with bilateral RB. Mother's right eye was enucleated. Genetic screening was done for mother and the proband, which showed similar mutation. Mother was pregnant, predicted for sibling and requested early investigation. 12-day-old sibling was brought to the clinic. Group B, RB both eyes, same mutation identified, life, globe and vision was salvaged in this patient. Two similar looking twins, twin A had squinting right eye with bilateral RB, twin B had a retinal scar, we were not sure if it was an RB. No mutation, there's no family history of RB and no mutation was found in parents' blood. Twin A had de novo germline mutation in blood. Twin B did not have any mutation in blood, so it did not require multiple investigations. Proband presented at 36 months with unilateral RB group E, no family history of RB, germline mutation identified in blood, so blood should be screened in unilateral patients as well. Proband presented at 26 months with right eye group E RB, germline mutation identified and closely monitored. Patient turned bilateral RB during the treatment period. Analysis of parents' blood showed the father as an unaffected carrier, predicted higher risk for the next sibling. Proband's wife, 2 months pregnant, familial RB with 4 affected members. Proband and mother had heterozygous deletions. Prenatal testing done by amniocentesis and same deletion was found in the fetal DNA. Left eye was enucleated at 6 months of age for this patient. No mutation was found in the patient's blood and predicted less than 1% chance of getting RB in her offspring. Followed up, a normal child was delivered. Left eye was enucleated at the age of 2 years, no family history of RB, no mutation identified in blood, no risk of developing secondary tumors. So in summary, genetics plays an important role in clinical management of retinoblastoma. We have made the genetic testing affordable and our model can be replicated in a resource-limited setting. Cost has been brought down from $1,800 to $150. Timeline from 10 weeks to 2 weeks for prenatal samples for known mutations, it's just 1 day. We have touched the lives of more than 536 families, 2,120 samples through genetic testing and counseling. Thank you very much.
Thank you, Dr. Thank you, Dr. Kim, for this wonderful molecular genetics study. Now I call upon Dr. Andrew Stacey for his paper on long-read sequencing in RB1 gene for rapid diagnosis of germline RB1 variants.
Thank you. I'll be talking about long-read sequencing and the parent of origin effect in retinoblastoma, a new signal and new data that I think will be relevant to all of us. The only disclosure we have is that there's a patent pending in the US for the data that we'll be talking about and the sequencing that we'll be talking about. Traditional short-read sequencing requires you to cut DNA up into small pieces, tag the DNA, and then run the DNA on a gel to figure out the sequence. Long-read DNA sequencing is a newer technique. It does not require you to break up the DNA. You keep the DNA long, and what you do is you tag one end of the protein with, or one end of the DNA with a motor protein. In our lab, we use the Oxford Nanopore MinION, which is a sequencer about the size of your palm that you can see there in the middle photo. After you've tagged the DNA with the motor protein, you put it on the flow cell, and the motor protein is attracted to nanopores on the sequencer. The nanopores pull the DNA through the nanopore and test the electrical signal of the DNA. Each nucleotide provides a little bit different electrical signal, and you can get your DNA sequence through simply the electrical signal pulling through. It's a very true multi-omic process because in a single run, we can obtain a long read of DNA, including large structural changes like insertions and deletions. And we can also obtain the haplotype or phase the DNA. When you cut DNA up, you don't know if you're looking at allele 1 or allele 2, but when you have the long reads, you can actually figure out if you're looking at allele 1 or allele 2. We can also obtain methylation signal in a single run because the methylation changes the electrical signal just slightly, so we can tell if the DNA is methylated or not. All three of these things are going to become important for what we're going to be looking at. We published the first case of using long-read DNA sequencing to identify a germline mutation in retinoblastoma last year. Let me just show you how we do this. So you can see on the gray lines here are our reads. Many of them are spanning 150 or 200 kilobases, nearly the entire gene. When you have such long reads, you can then break things up into alleles or haplotypes. And so you can see here that we can identify the alleles and we can identify the mutations. Over on the right, you can see the dark spots being the mutations. The mutations segregate to one of the alleles. We also get this methylation data, but I'm going to come back to that methylation in a minute. We've repeated this in our neonatal group. Whenever a new patient comes in, we do long-read sequencing on the patient and their family. We've done it on 15 or so families so far. We've corroborated a number of clinical genetic tests that have been done. We've identified some mosaic mutations. And we've also solved a previously unsolved case of a very large translocation, which was easier to see with long-read sequencing. But let's go back to the methylation. We know that there's methylation in the promoter region of RB1 and most genes. The methylation signal here is represented by the blue. And you can see on both haplotype 1 and haplotype 2, there is methylation signal. But what is going on there next to that? This is intron 2 of the RB1 gene. And interestingly, there is methylation in the paternal allele, but not the maternal allele. And what this actually means is that the translation, there's a different transcript being produced by the paternal allele rather than the maternal allele. In a way, this is an accessory promoter region that is different between your parent of origin. Now, most of us don't realize this, but the retinoblastoma gene is imprinted, and this is the mechanism of the imprinting. There's a different methylation signal in intron 2 of the paternal allele. It makes sense also because we know that there are populations within our familial cases that are different. Dr. Shields and her team in Philadelphia recently published a series showing that those children who come from a paternally derived familial retinoblastoma have worse outcomes. They present with larger tumors at a later stage, and they have a higher risk of enucleation. Well, our hypothesis is that this parent of origin effect is not simply in familial cases, but it is due to that intron 2 methylation, and it's true in de novo cases as well. So what we did is we looked at our patients, including the parent of origin effect for each of them, including the de novo patients. So let me show you how we did that. Here's one of our neonatal patients. We got the long reads so that we could phase them into allele 1 and allele 2. This is a de novo patient. We sequenced their parents. They have no germline mutation. We identified the methylation signal. There's the promoter region on the left, and there's intron 2 in the center, with the differential methylation being hypermethylated on the paternal allele. In other words, blue on the paternal allele. And we find our mutation over here on the right. We can segregate the mutation to the hypomethylated allele, or the maternal allele. So even though this patient has no family history of retinoblastoma, we know that they have a maternally derived mutation on the maternal allele. We did this for each of our patients. We identified the long reads, the alleles, we identified methylation, finding the promoter region, and the methylation of intron 2. We then segregated their mutations and found their parent of origin effect in each mutation. And we compared their outcomes. And this is what we think is really quite striking. The outcomes of de novo paternally derived mutations have worse prognosis than patients who have maternally derived mutations, even in the de novo situation. So here we see tumor stage at presentation. In blue are paternally derived mutations. They are presenting later than maternally derived mutations, very similar to the data we see from the Shields group in familial cases. We also look at globe salvage. We are looking here at eyes that have been enucleated or radiated. In our hands, radiation is used simply as a surrogate for enucleation in families who refuse the enucleation. In our study, none of the maternally derived eyes have been enucleated, whereas more than 50% of the paternally derived eyes have been enucleated. Now, this is a small study. I fully expect that many of our maternally derived eyes will be enucleated. In the Shields study, they had, I don't remember, 10 or 15% of the maternally derived eyes were enucleated. So these will equal a little bit more, but this is a statistically significant graph, and it will continue to be statistically significant because the biology of familial cases is the same as the biology of familial cases. In summary, long-read sequencing is fast, reliable. It provides us the germline mutation, even de novo cases, and provides a prognostic marker. Thank you.
Thank you, Dr. Andrew. Now I'll call upon next speaker, Dr. Petra Ketteler, for our paper on amplification of independent MYCN signature defines an aggressive subtype of retinoblastoma. Dr. Petra.
Thank you. Good morning, everybody. I'm going to speak about MYC-N in retinoblastoma. I have no disclosures. There are classic retinoblastoma, and these are initiated by RB1 inactivation biallelically. There is a very rare subtype described first by Brenda Gelly's group, which is RB1 proficient and carries a MYC-N amplification. Looking at the classic retinoblastoma, two subtypes have been described by multiple groups. Here we focused in our cohort on MYC-N. So we had 61 retinoblastoma where we performed whole exome sequencing, DNA methylation, and RNA sequencing. Our group contained 10 retinoblastoma with undetected RB1 variants and 2 extraocular relapses of retinoblastoma. Based on DNA methylation, we performed unsupervised clustering. And to increase the robustness of this clustering, we performed it more than 8,000 times and built a consensus clustering. We found 3 clusters. cluster A, B, and cluster C contained all MUC-N amplified tumors. Not only those that are RB1 proficient, but also 2 with B allelic RB1 inactivation. Note that we enriched our cohort by samples that were RB1 proficient, so the frequency is higher of the MUC-N amplified RB1 proficient tumors. And then we found 2 with without MUC-N amplification, but with downstream activation of the MUC-N pathway. We could show that cluster C retinoblastoma showed hypermethylation compared to A and B, and cluster B retinoblastoma showed hypermethylation of the differentially methylated regions. Comparing it to the classifier of the French group, we could show an overlap of cluster A tumors with subtype 1, and then cluster B and C overlapped with the subtype 2. Age of diagnosis was lowest in cluster A tumors and higher in cluster B and C tumors. With the exception of the RB1 proficient tumors, they showed the lowest age of diagnosis. Each cluster had specific copy number alterations that have all been described for retinoblastoma before. We found 6p gain in all of the cluster tumors, and we found chromosome 16q loss to be specific for cluster B tumors. Cluster C tumors showed the classic chromosome 2p gain, where MUC-N is located. Gene expression was compared between subtype 1 and 2, so A versus B and C, and we could validate the findings of other groups, and the most differentially expressed gene is TFF1. We also compared it with the previously published gene signatures for undifferentiated retinoblastoma, and we could show that they were higher expressed in B and C. To model this, we used cell lines, and there are several cell lines published and described, and some of them carry a MUC-N amplifications, others don't. And there are 2 cell lines from the Brenda Gelly lab that we could use that are RB1 proficient, which is the RB522 and RB3823. And we knocked down MUC-N in these cell lines, and we could show that proliferation was reduced. And the cell cycle showed a lower rate of cells in the S phase, and we could also show in the CAM model, which is grafting on chicken eggs, that the tumor growth was lower in those with reduced MUC-N. Most interestingly, I think, is that the gene expression actually changed from the subtype 2, more aggressive, undifferentiated retinoblastoma gene expression profile to the more differentiated photoreceptor-like gene expression after MUC-N knockdown. So we could see a transition from subtype 2 to subtype 1. We also defined a MUC-N-RB signature based on the cell line model, and when we transferred this to the primary tumors, we could show that this expression was highest in the cluster C tumors. To summarize, we could show or validate that there are 2 subtypes of retinoblastoma. But on top of this, we could show that there is a specific subtype driven by MUC-N, which includes the RB1 proficient and the RB1 wild-type tumors, RB1 mutated tumors, and that this cluster C, or maybe subtype 2 MUC-N, however you'd like to call it, has specific genetic characteristics, and that there might be a transition between at least reversing subtype 2 to subtype 1, but in the evolution, you might suggest that there's also a progression from subtype 1 to 2. I'd like to thank my collaborator, mostly Tatiana Rühl and Elena Afanasieva, who've done all the analysis that I'm presenting here. And thank you for your attention.
Thank you, Dr. Petra. Now I'll call upon Dr. Mamata Reddy Mupidi for her paper on human retinoblastoma cells are hyper-dependent on aurora kinase A and its association with MECAN oncoprotein. Dr. Mamta.
Good morning, everyone. Thank you for the opportunity. I do not have any disclosures. It's good to talk later in the session, so I don't have to give introduction to the disease or the genes that I would be talking about. So in retinoblastoma, in addition to RB1 mutations, dysregulation in terms of copy number gains, amplification, or gene expression, particularly of MECAN, plays an important role in RB tumorigenesis and progression. We have earlier shown, along with others, that MECAN regulates multiple tumor hallmark pathways in retinoblastoma. While we were working with MECAN-mediated dysregulation in RB, few structural biology studies showed that aurora kinases can stabilize MECAN by preventing its degradation via proteasomal pathways. So, what are aurora kinases? Aurora kinases are serine threonine kinases that play a critical role in cell cycle progression, and dysregulation of aurora kinases is observed in certain tumors, and their expression usually correlates with poor prognosis. So based on the structural association studies and their expression in various malignancies, we hypothesized that aurora kinases, either independently or through MECAN-mediated pathways, might play a crucial role in retinoblastoma. So there are 3 aurora kinase members in humans, aurora kinase A, B, and C. We have tested the expression of all 3 members in human retinoblastoma cell lines and a few patient specimens. And we observed only the expression of aurora kinases A and B. A couple of years back, we have shown the functional significance of aurora kinase B in human, and we have published this in IOBS. Today, I'll be talking about the functional significance of aurora kinase A in human retinoblastoma. First, we measured the expression of aurora kinase A in human retinoblastoma archived patient tissue specimens, and the expression of aurora kinase A was also correlated with the presence of histopathologic high-risk factors. So, we observed that the expression of aurora kinase A is significantly elevated in tumor specimens compared to the adjacent healthy retina, and its expression also correlated with histopathologic high-risk factor. So to understand the dependency of retinoblastoma cells on aurora kinase A, we performed genetic silencing, confirmed the knockdown efficiency, and measured the cell viability, apoptosis, and cell cycle distribution. The knockdown cells showed significantly less cell survival, increased apoptosis along with increased P53 levels, and cell cycle arrest. So this prompted us to test whether aurora kinase A can be inhibited pharmacologically. We have taken 3 inhibitors that were in clinical trials at that time, and showed that when we treated retinoblastoma cells, the cell viability was decreased, and we confirmed the specificity of aurora kinase A inhibition using phospho-aurora kinase A antibodies, and the pharmacological inhibition also showed elevated apoptosis along with increase in P53 levels, similar to the knockdown experiments. Since we started our hypothesis with the role of aurora kinase A in stabilization of MECAN, we measured the aurora A levels in MECAN knockdown and vice versa, because MECAN is a transcription factor and can regulate the expression of aurora kinase A. So we confirmed the association of aurora kinase A with MICN using immunoprecipitation experiments, and we also showed that MICN can bind on the promoter region of aurora kinase A using chromatin immunoprecipitation PCR experiments. We also tested the inhibition, pharmacological inhibition and aurora kinase A knockdown in chorioallantoic membrane xenograft model, and showed that inhibition of aurora kinase A can lead to decreased tumor parameters. In addition, we have shown that inhibition of aurora kinase A in patient specimens lead to decreased cell viability. So in summary, what we have shown was that in addition to RB1 loss and MICN dysregulation, aurora kinase A overexpression can contribute to RB progression. Aurora kinase A crosstalks with MICN to maintain the malignant state in retinoblastoma, and inhibition of aurora kinase A can be a novel therapeutic strategy to restrict retinoblastoma cell growth. So this work would not have been possible without the help of my team members. Special thanks to Dr. Devjyoti Tripathi, who is in the audience, Dr. Swati Kaliki, and special thanks to Nahidar Bora, my graduate student. And I'm fortunate to be funded by a grant from the Department of Biotechnology as Innovative Young Biotechnologist Award, and Hyderabad Eye Research Foundation for their help, and all other funding agencies. And I thank you for your attention.
Thank you, Dr. Mamta. Now it's our pleasure to call upon Dr. Helen Dimaras to present the paper on development of rare pediatric eye cancer biobank.
Thank you very much. Good morning, everyone. I have no financial interest to disclose. We all know, and we're all here because we do clinical research, particularly on retinoblastoma and other rare eye cancers, and to do that, we need high-quality research specimens and data. Of course, there are many challenges that come along with our research, and most notably things like representation. Most of our studies are conducted on Western populations. We study rare diseases, so there's not many specimens and cases to go around. We need to be following best practices so that our biospecimens retain their integrity. And we also have an issue of biohoarding, where we're not sharing our specimens in order to do really impactful collaborative studies. And I'd like to tell you a bit about our biobank at the Hospital for Sick Children, where we're trying to get around some of these challenges. So what is a biobank? A biobank is a systematic collection and storage of resources that utilize standard operating procedures to maintain specimen integrity. The collection of resources can be used for a wide variety of research. It usually means we get broad open consent from patient families to be able to do many different studies with what they offer the biobank. Resources can be shared with many people beyond just the institution that houses the biobank, and that's operated by a governance structure and oversight. And there's a plan for the future so that we can keep this resource going. It's very different than how we used to do research in the past, which were largely with investigator-led collection of resources that were usually linked to a specific research question that had various limitations on resource sharing, and usually only lasted until the research question is solved. And so at the Hospital for Sick Children in Toronto, we have a Kids Eye Biobank, and a main arm of it is a collection of rare pediatric eye cancer specimens, data, and images that is largely funded from a grant from the US Department of Defense. We collect and store resources from a wide variety of rare pediatric eye cancer, benign and malignant lesions. Most of them are retinoblastoma, as you'd imagine. It's the most common of the rare. And what we do is we operate in 4 stages. We enroll patients through an informed consent discussion. We collect not just specimens, but also images and longitudinal clinical data. We store these in secure liquid nitrogen facilities and secure servers, and we share them. We want them to be used in a wide variety of research. We have a kind of complicated governance structure, but the important thing to focus on here is that patients are embedded in external and internal oversight, and in particular in a patient advocate committee that helps us make patient-friendly practices to enroll and include more families in our research, and also to ensure we can inspire and catalyze impactful research that matters to patients. Biobank contributors are from Sick Kids and a number of sites across North America and Europe. So far, we've enrolled 276 patients, about an 89% enrollment rate, so people do want to participate. We have to collect additional consent to do two things: to make cell lines and organoids, and to share whole genome sequencing data in other studies. And for the most part, there's about 90% or 95% respectively compliance with that. We also need to ask families if they're happy with us to share their resources with for-profit companies. And there we see a little bit of a decline, both in the general research and in the cell lines and whole genome sequencing data. So we need to do a little bit more of a deep dive to understand why the decline in participation in those components. We're using our patient advocate committee to help make the consenting process more patient-friendly. So here's an example of a tool our survivors and family members are creating that our research coordinators can use to help families understand and navigate the different choices they make. What does for-profit research look like? What does it mean for a cell line or organoid to exist and be used in perpetuity? And so in summary, I've raced through this thinking 6 minutes was not enough, but we have a study of retinoblastoma and other rare pediatric eye cancers requires abundant high-quality specimens and data, and biobanking can help fill that need. Patient engagement in biobanking is important. It can help enhance our research participation and study quality. That means we can get diverse populations, more abundant resource collections, and aligned studies with patient priorities. And further examination of factors contributing to participant-informed consent preferences can help us understand and address facilitators and barriers to participation. And this is really important in an era of improved equity and diversity and inclusion in research, so that we ensure our research studies are actually going to be able to be used and beneficial to a broad patient base. If you're interested to collaborate, please let me know. Your center can join as a referral site to refer patients, and they can contribute resources or participate in governance of the biobank. You can also join as a partner biobank. If you have one of your own, we're operating some of our centers as federated models where we operate independently but align our resource collections so that we have similar protocols and we harmonize those protocols. Or if you're interested in doing research, you can request biospecimens, data, or images at thekidseyeBiobank.com. Thank you very much to my research team and my co-director, Dr. Malapadna.
Thank you, Dr. Damaris. I think we'll all agree there's been some excellent papers this morning. And in the first instance, for the questions, I'd like to ask our expert panel if they have any questions they'd like to ask. And if those of you in the audience would like to ask a question, you can go to the microphones now. Any questions? I think I'll start by asking the President first, whether what families feel about the chatbot, whether you've done an audit of their experience or okay, I was wondering if I could ask Reza what families think of the chatbot. If you want to go to the microphone.
Sorry. Start again. So, Reza, I was wondering whether you've audited outcomes with the chatbot and whether your families think it's a good thing or not.
If you go to the microphone, please. Just behind you. Thank you.
Thank you so much for your attention and question. As I told you, there was a very the answers to our retinoblastoma-related questions that are asked by parents are valid. However, they are not very sympathetic, and sometimes they make them worry. So we plan to fine-tune the large language model to give a more empathetic answer to questions. And now I think it's very important to communicate with a human instead of a chatbot, and chatbot can be only an assistant.
Okay, for the next question, if you'd like to introduce yourself, please.
Yes, hi, Christian Haddad from Lebanon. Yes. My question goes to Dr. Wilson. Thank you for the paper on teleophthalmology and your work with the Orbis Cybersite website. You said it's not tailored to retinoblastoma particularly. Do you have in mind having something tailored to retinoblastoma in lieu of answering massive emails, consults?
So, it's resource adaptive. So always we are creatures of adaptation to the technology we are given, as we've shown here. We have gone from what was basically a very primitive online platform for consultation to an era that is very tech-heavy with artificial intelligence. So clearly the bar to do better is greater. The platform as it exists has been adapted based on the consultations to correspond and mentor the mentees over time, extracting the information we need to be for the study. Is the best possible platform. It surely can be evolved with everything we have available now with AI.
Okay, thank you. Mandeep, please.
So thank you. I'd like to congratulate Andrew Stacey on the paper he presented. I think the rapidity of the technique and the implications are quite profound. And I wondered if this is now changing the way you treat, if you're getting the results quickly, if it's changing the way you treat the paternally inherited versus the maternal ones.
Thank you, Mandeep. Yeah, we get these results within a day or two of taking just 1 milliliter of blood during an exam under anesthesia. And yes, absolutely. I share this, we can, through our IRB, share this information with our patients. And so in de novo cases, we share the information with them. And we explain that there's a biological aspect that might make this tumor a little more challenging to treat. So yeah, we are using that. I will say there was a question on the chat for me about the ethical nature of sharing a parent of origin. And 6 minutes is not much, and so just getting through the technique and the results is a lot, but it's the ethical nature of this is something that we think about a lot. So when I'm sharing information with families, I'm sharing with them a parent of origin information, and there's an ethical dilemma there. The results we've presented today are under review for publication in a general journal, and we will use the term parent of origin because, for better or worse, that is the term that is used in the literature. However, moving forward, we are very open to changing that, and we're considering using the term the hypomethylated allele of origin or the hypermethylated allele of origin, so that we don't use anything like parent of origin.
Thank you. Manoj?
Thank you. Am I allowed more than one question?
Well, yeah, start with one.
Okay. Right. Congratulations, Andrew. Great work. Have you looked at the age of the parents in your study? And is there a correlation with the paternal age? Because, the old adage that sperm has no expiry date doesn't really ring true with retinoblastoma. We find that advanced paternal age does increase the risk of developing retinoblastoma mutations. I wonder what your findings.
Yeah, so we have talked about this, but our numbers are still small. We know that most de novo mutations will be on the paternal allele. That's true for all de novo mutations. And so I expect that age might play a role. There are other things that might play a role. Carol and her group showed differences in the location of tumors, which I think is probably a legitimate biological mechanism as well. So we'll look at all of these when we have more data.
Yeah, go for the second.
Am I allowed the second one? Thank you, Ashwin. This was for Dr. Kim. Congratulations, great work. Are you applying your technique to tumors that have been banked or indeed paraffin stored specimens, and how does it work?
Yeah, we've been trying to do with the paraffin embedded specimens as well. Initially we were not very successful, but now we've developed techniques to identify the... So I think the bank would really be helpful. The biobank is really extremely helpful in our case as well.
Incredible work. Congratulations.
Thank you.
Thank you. So I've got a question for Petra Kettler. It's regarding the MICA amplification. We found the age of onset not to be that different with RB minus, RB1 minus, RB1 minus. Did you find any, with your clusters, did you find any age of onset differences at all? Or did you not look at that?
We looked at it,
Okay.
and we saw that those that have B-allelic RB1 inactivation plus MICN amplification have the same age of onset as those other subtype 2 tumors, but those that are RB1 proficient, they are younger at diagnosis.
Yeah, thanks. Thanks for confirming that. Right, are there any other questions? Right, then I think we can close the session, but before we do that, we have to sadly have 3 winners because all the papers are excellent, and I will announce those. Okay, right. So, in reverse order, the third place goes to Dr. Mamta Reddy Wapidi from LVP. So, a round of applause, please. You come to the front. In second place, for our sequential strategy for rapid molecular diagnosis of retinoblastoma, was Dr. Usha Kim. Please come forward. And congratulations to Dr. Andrew Stacey for his long-read sequencing of RB1. So that closes the session. Thank you.
Thank you for the wonderful session. And then we move on next. May I now request Dr. Usha Kim onto the dais to chair the next session. And the moderator for this session would be Dr. Helen, and we have the expert panelists as well.
So we're back on retinoblastoma 2. So I request the moderator, Dr. Helen Damaris, to take over and start inviting.
We welcome
our expert panelist, Dr. Geeta. and Dr. Dube. Yeah, so over to you, Dr. Damaris.
Thank you. Should we invite? Okay, all right. Our first speaker will be Dr. Douglas Chigane, who will speak to us about safety evaluation of anterior chamber paracentesis for aqueous humor liquid biopsy.
Good morning, everyone. My name is Douglas Chigane. I'm International Fellow at Children's Hospital, Keck School of Medicine of USC, and I'm going to present our work, Safety Assessment of Aqueous Humor Liquid Biopsy in Retinoblastoma, a multi-center study of 1,203 procedures. This is the most updated number that we have so far. Our financial disclosures. And since our initial work in 2017, when we first demonstrated the potential of aqueous humor as a pseudo-grade tumor biopsy for retinoblastoma, many discoveries have been made showing diagnostic and prognostic biomarkers that could aid in the management of these patients. But one of the major questions that still had no answer is that, is it safe to perform this procedure for these patients? And that is the purpose of this multi-center retrospective observational case series, where we aim to evaluate the safety of the aqueous humor liquid biopsy for retinoblastoma patients through the anterior chamber paracentesis during evaluation under anesthesia of children in the OR. To perform this procedure, it's needed to make sure that we have a clear visualization of the ocular structures, that we have a deep anterior chamber, and with no signs of activity disease in the anterior chamber as well. Using an operating microscope, we performed this procedure with a 32 gauge needle syringe attached to a 1 milliliter, 32 gauge needle attached to a 1 milliliter syringe. We do the procedure temporarily through a clear cornea into the anterior chamber over the peripheral iris, making sure that the bevel of the needle is always facing up to do not touch any eye structures. The aim of this procedure is to obtain 100 microliters of aqueous humor. This procedure was performed by 15 different surgeons at 7 different centers. So our numbers, we have 1,203 samples from 484 eyes of 425 patients. The samples was collected on 5 US centers in Los Angeles, Philadelphia, Atlanta, Seattle, and Portland, in France, Paris, and Spain, Barcelona. Talking about our numbers, from the total of samples, 1,130 samples are from RB patients. The total of eyes, 411 RB eyes, and the total of patients, 325 RB patients. Most part of the patients were group D, and according to the AJCC staging, they most part are CT2B. However, how can we evaluate the complications related? So far, there isn't any standardized systems for the complications regarding the anterior chamber procedure. So we allocated our complications and we graduated into different levels. The mild ones, the ones that are self-limited complications that resolve with no need of intervention and without risk to ocular or visual health. The moderated ones that require intervention or additional monitoring but did not result in permanent vision loss. And the severe ones that could lead to permanent vision loss, loss of the eye, and life-threatening. So our complication rate, we had one mild complication that was one self-limited subconjugal hemorrhage, which represents 0.083% of all samples, or 0.088% of RBI samples. We did not have any moderate or severe complications, so our overall complication rate was 1 in 1,203, or 0.083%. So answering our first question, is it safe to perform this procedure for RB patients? Our answer is that yes. Aqueous humor liquid biopsy appears to be a safe and well-tolerated procedure for the pediatric population during evaluation under anesthesia when performed by trainee surgeons? Thank you very much.
Thank you. I'll call upon our next speaker, Dr. Christina Stathopoulos. She will be speaking to us about chromosome 6p gain in aqueous humor cell-free DNA does not necessarily correlate with poor eye preservation in retinoblastoma.
Good morning, everyone. Thank you for giving me the opportunity to present today. So, since the pioneering publication of Jesse Berry, who showed that in the aqueous humor we could find cell-free tumor DNA that can serve as a liquid biopsy for retinoblastoma, there are many papers who have been published suggesting 6p gain as a potential biomarker for poor ocular salvage. We wanted to investigate that further in a cohort of patients treated in Lausanne between 2017 and 2021, from whom aqueous humor was collected. And we compared a small copy number alteration from eyes that ended to be enucleated versus eyes that were salvaged. Only one sample per eye was included. If an eye had more than one samples, for the salvage groups, we choose the one at date first seen if available, and if not, the first sample from a series of intraocular chemotherapy. For the secondary enucleated eyes, we choose the sample at date of enucleation, and otherwise, if not available, the one at date first seen or at time of the first intraocular chemotherapy. After my words. When we took out the DNA from the aqueous humor, the amount, the quality, and was controlled with the fragment analyzer. We did whole genome sequencing for the somatic copy number alteration, whole exome sequencing for small variants, and methylation assay to see if there was any methylation of the RB1 promoter. CSCNAs were considered gains or loss if we had more than 0.5 deviation from baseline. Initially, 26 samples from 26 patients were included. 8 had to be excluded, 1 because we couldn't find any cell-free DNA in the samples, 3 failed sequencing, and 4 didn't have any copy number alteration. All those 4 were taken at time of secondary enucleation, and they didn't have any biallelic RB1 mutation. 12 of the samples were sampled at date first seen, so in treatment-naive eyes, 2 at time of secondary enucleation, and 4 during the conservative treatment. There was no difference in the mean age at retinoblastoma diagnosed between the two groups, the salvaged eyes and the enucleated ones, and all were advanced group D or E eyes. In this slide, you see the treatments that the eyes had, and the mean treatment-free follow-up for the salvage grouped eyes was 4 years. So we found the mutation in all 18 samples but 1 who had no RB mutation, no MECAN amplification, and no hypermethylation. And we think that there is another gene that may be involved, and we'll talk about that later. Here is the plotting of the presence of the copy number alteration between the two groups in their presence in percentage, and you see there was no difference in the 6p gain between the salvaged and the enucleated eyes. And when we looked to the amount of the amplification, there was also no difference between the two groups. So in conclusion, we couldn't say that 6p gain is a biomarker for poor ocular salvage in our study. We think that identification of prognostic biomarker necessitates prospective multicentric studies with wider cohorts. Now I take the opportunity to ask you in the audience if you have a similar case with a wild-type RB, no MECAN mutation and no promoter hypermethylation, if you would like to share the case with us to sequence it because we might have a hint for the third gene, so it would be interesting. Here is my contact in case, and I thank you very much for the kind attention.
Thank you, Dr. Stathopoulos. Our next speaker we'll call Dr. Venkata Yalapantula. The title of their talk is Clinical Implementation of Low-Pass Whole Genome Sequencing Using Aqueous Humor-Derived cfDNA for Retinoblastoma Diagnosis and Monitoring.
Today I'd like to talk about clinical utility of AH-derived, aqueous humor-derived cell-free DNA assays, especially in a diagnostic setting in retinoblastoma. But first I'd like to thank the organizing committee for giving me this opportunity to present our work today. In 2022, we developed and clinically validated a liquid biopsy test that is capable of detecting genome-wide copy number alterations using low-pass whole genome sequencing assays. This test uses 3 analyte types shown on the plot, namely aqueous humor for cancers of the eye, including retinoblastoma, CSF, cerebrospinal fluid for brain and CNS tumors, and blood plasma in all of the solid tumors. Additionally, we are now in the process of clinically validating the targeted panel for mutation detection. This effort builds on Dr. Jesse Berry's pioneering work demonstrating the utility of aqueous humor in identifying genomic alterations in retinoblastoma. For this study, we had a total of 21 samples collected at diagnosis from 16 patients, 5 of whom were bilateral cases. Each sample was characterized by both low-pass whole genome sequencing and targeted sequencing approaches and followed for anywhere from 7 to 24 months. Shown on the oncoplot here are recurrent genomic alterations identified in this cohort. Shown on the y-axis is the alteration, and x-axis represents the sample in which the alteration was identified in. So if you look at the first column, we see for this particular sample, we have an alteration shown by the colored block in 6P, 1Q, 2P, 16Q, 16P, but also a mutation below in RB1 and BCOR. Similarly, if you look at the last sample, in this particular sample, we only found a germline mutation in RB1. The colors of the blocks correspond to the type of alteration shown on the right. So we have deletion shown by blue, gains are shown in red, focal amplifications in the deeper shade of red, so on and so forth. In all, we observed the highest frequency of alterations in 6P, 1Q, and 2P, which are altered in 71%, 62% and 43% respectively. We also found 57% of the samples with RB1 mutation, but also other mutations in BCOR, MSH6, and ERID1A. So previous reports have shown that high amplitude of 6P is a defining feature of high-risk disease, and as shown by this red curve in this plot. This high amplitude can be attributed to either high circulating tumor fraction or having more than 1 copy gain of 6P, that is having 4 or more copies of 6P. On the contrary, low amplitude is suggestive of a subclonal 6P status. So we set forth to further delineate which of these features is indicative of high-risk disease. We use the ICOR CNAR package to identify tumor fraction and simultaneously infer a number of copies in each chromosome. Across the 3 analyte types that we tested using our liquid biopsy test, aqueous humor had a very high tumor fraction with a median of 85% across all samples compared to just 10% in blood plasma and 6% in cerebrospinal fluid. This suggests that aqueous humor could be used as a tumor surrogate, and which makes it possible to identify all somatic alterations de novo with high sensitivity at diagnosis and for disease monitoring. With this information, we grouped samples into good and poor responders. On the left, we have good responders shown by the green bar on the top. On the right, we have poor responders shown by the brown bar on the top. Poor responders are cases responding very slowly to therapy that have relapsed or who have eyes that were enucleated. The plot also shows tumor fraction values as a percentage and whether the sample has 4 or more copies of each amplification, shown by a deeper shade of red block of the colored blocks. We found that with the exception of one case, all samples that had 4 or more copies of 6p or the McN amplification were all poor responders. Overall, 67% of the eyes in poor responders had 4 or more copies of 6p compared to just 11% in good responders. Though the sample size is small to make definitive conclusions, 2 samples that had enucleations also had 4 or more copies in both 6p and the 1p. In the 5 bilateral cases, one eye had a poor response to therapy, also had 4 copies, more than 4 copies of 6p, and the other eye, which relapsed, had McN amplification. The patient which relapsed initially presented with IIRC stage B disease in both the eyes at diagnosis. This example demonstrates the utility of aqueous humor for examining inter-eye differences in bilateral cases. So in summary, high tumor fraction in aqueous humor enables sensitive and comprehensive genomic characterization of retinoblastoma. 4 or more copies of 6p portended poorer prognosis, and in bilateral cases, aqueous humor reveals inter-eye differences which can inform disease management decisions. So thank you for all my collaborators and funders. Thank you for listening.
Our next speaker is Dr. Timothy Corson. The title of Dr. Corson's talk is Aqueous VEGF-A Levels as a Liquid Biopsy Biomarker of Retinoblastoma Vitreous Seed Response to Therapy.
Thank you and good morning, everybody. I'd like to thank ISO for the opportunity to present here today. This is a collaborative study between my group and the group of Jesse Berry and the former group of Anthony Daniels. I'd also like to acknowledge our funding sources at the bottom of the screen. Here are my disclosures. As we're all aware, vitreous seeds are a unique and clinically challenging feature of retinoblastoma that have been categorized into 3 different classes: dust, spheres, and clouds, as shown on the left of the screen. They present not just treatment challenges, but also diagnostic challenges. New seeds may not be visible until they're well established in the eye, and the cloud phenotype in particular may be non-viable, but quite slow to clear. So it would be excellent if we had some kind of predictive biomarker that could go alongside imaging to tell us how these seeds were behaving and responding to treatment. As we've heard extensively at this meeting, aqueous humor is becoming a rich source of potential biopsies, and it is, of course, routinely removed during intravitreal chemotherapy. It's been known for decades that retinoblastoma is a highly vascularized tumor. As you see in this histological image, the viable retinoblastoma cells grow as cuffs around blood vessels, as shown here. You can see the small blood vessel with the viable tumor cells growing around it in areas of necrosis further away from that blood vessel. Vitreous seeds kind of flip this paradigm on its head. The vitreous seeds are floating in the vitreous, and the viable tumor is around the outside of the seed with a necrotic core. So this growth phenotype caused us to hypothesize and wonder how are these vitreous seeds surviving in the hypoxic vitreous in the eyes with retinoblastoma where they don't have ready access to blood vessels. So we hypothesized that the vitreous seeds might be elaborating pro-angiogenic growth factors that could correlate with seed growth and therapeutic response. So to explore this question, we turn to a rabbit xenograft model. These are immunosuppressed New Zealand white rabbits that have been intravitreally injected with wary RB1, retinoblastoma cell line. After initial establishment of the tumor, in this experiment, the vitreous seeds that were growing in these eyes were treated with one of 3 different chemotherapies: melphalan, topotecan, widely clinically used, and the experimental HDAC inhibitor, belinostat. So they received weekly therapy and an aqueous humor sample over a 4-week period, and we assessed all these samples by multiplex ELISA. In this initial study, we focused on some known pro-angiogenic growth factors that we expected to find in the aqueous. And the patterns of these growth factors over the course of therapy were examined, and the one I'm going to focus on today is VEGF-A. So VEGF-A, as we're all well aware, is the vascular endothelial growth factor, a major pro-angiogenic mediator. And the VEGF-A production pattern that we saw over the course of therapy was really quite striking. So if I draw your attention to the blue bars here, these are the eyes that received no therapy, so they were injected with a vehicle control. And as you can see, the VEGF levels increased alongside the growth of the tumor over the time course of the experiment. Conversely, if you look at the red bars, these are the eyes that received chemotherapy, and you can see that the VEGF levels compared with baseline, which is 2 weeks after the start of inoculation, the VEGF levels dropped quite dramatically over the course of therapy, suggesting that VEGF-A production is tracking with seed growth. To explore this more closely, we turn to RNA-scope, which is a technique that allows us to look at the RNA production within cells. This is particularly useful for figuring out the cells that are actually producing the VEGF-A. So here are some example vitreous seeds. The human VEGF-A mRNA shows up as pink or red in these images, and the endogenous rabbit VEGF-A is in light blue. So you can see that these human retinoblastoma cells are elaborating a large amount of VEGF-A. There is some endogenous rabbit VEGF-A being produced in the retina, as you would expect, but the majority of the VEGF-A, at least at the mRNA level, is coming from these vitreous seeds. We wanted to look at this in the human context as well, so we looked at examples of human vitreous seeds and saw a very similar pattern with large amounts of VEGF production in the vitreous seed around the periphery where the most viable cells are, and this was a very specific and unique feature of these vitreous seeds. So based on this human data, we wanted to explore this more closely. So we validated the study with human samples. These are eyes that received intravitreal melphalan, and these were eyes in which the seeds had were still growing, but the primary tumor was eradicated, and they had received intravitreal melphalan as needed. And here we focused just on VEGF in an ELISA analysis. And some examples of the growth patterns that we saw are shown here. So here is an eye in which there was regression of tumor over 2 different samplings of aqueous humor, and we saw a similar decrease in VEGF levels. Here is an eye with stable disease in which the VEGF remained constant. And here is an eye in which there was initial regression, but then stable disease, followed by further regression. The VEGF increased at the stable point and then decreased with further regression. So we've shown that retinoblastoma vitreous seeds produce VEGF-A, and that VEGF-A levels correlate with vitreous seed therapeutic response in rabbits and humans. Seeds are the major source of VEGF-A. And since reducing intravitreal chemotherapy helps preserve retinal function, especially with melphalan therapy, knowing when to stop or restart treatment has value. So we hope to expand this study to more samples and see whether VEGF-A in the aqueous can be a response biomarker to therapy. Thank you.
Next, we'll call to the stage Dr. Dan Gombos, who will be speaking on liquid biopsy analysis of the aqueous humor in a xenograft orthotopic rabbit model of retinoblastoma treated with IAC.
Thank you. It's a long title, I know. I wanted to acknowledge my many co-authors, but in particular Dr. Stephen Chen, who is our interventional neuroradiologist in our center and will be presenting later today on a correlate to this study. and most importantly, my colleague, Dr. Professor Chavez Barrios at the Houston Methodist Hospital, who did these analyses in her laboratory. I would like to point out my disclosures, particularly adopt the scientist who funded these experimental models. I have otherwise no financial incentive here. We all know at this meeting the increasing importance and relevance of aqueous humor, not just in retinoblastoma, but potentially in other diseases. And there's a significant interest in the use, not only as a prognosticator, but as an assessment of response. These are mostly DNA-based, and there's increasing interest in the potential for proteomics, not just in RB, but also in other diseases, as we heard yesterday, in melanoma. But there is really a limited body of work of aqueous in an RB rabbit model. In last 2 years ago, we presented in Leiden our xenographic rabbit model using intraarterial chemotherapy in rabbits that have been engrafted with Y79 cells. This is actually different than the model you just heard about. The Y79 cell line particularly shows a very robust and aggressive animal model, and if left untreated, these cells progress out of the eye into the optic nerve and potentially into the chiasm. And they really mimic a very aggressive form of retinoblastoma in the child. And so our goal here was to assess potentially proteomics and to see from a pilot perspective, could we replicate what is already known clinically for cell-free DNA. We had 12 New Zealand white rabbits which were immunocompromised. And what we do in all of these experiments is we inject one eye with the cell line and then they have the other eye as an internal control. So for each of these rabbits, there is only one eye that is progressive with the disease and the other eye is an internal control. And the majority of these eyes, we did treat them with intraarterial chemotherapy, although not all. And you'll hear later this morning the treatments that were provided, but they were not uniform in their therapies. All of the eyes were harvested and euthanized at the end of the experiments, but we also had unique time points where we could access the aqueous in both eyes when we were doing MRI imaging and intraarterial chemotherapy. And so the aqueous samples were then collected and divided and assessed for protein analysis as well as molecular cell-free DNA. We did mass spectrometry for protein analysis. We used Z-score and fold changes, and we identified significant differential expression using peptide spectral matches. And so what did we find? So as proof of principle, cell-free DNA actually does mimic what we see in the child. So we successfully extracted cell-free DNA in most of the RBIs, and as you might expect, the controls had negligible amounts of cell-free DNA. We collected and were able to identify cell-free DNA in the eyes that harbored RB. But there was one particularly interesting case that I want to point out, and this was the exception. So we had one eye that did not receive any intraarterial chemotherapy and had very advanced progressive disease involving the chiasm. And when we looked, we found cell-free DNA in the untreated eye that did not have RB. So in the eye that you would normally think is normal, we identified cell-free DNA, which is an interesting thought because we don't really even know what goes on in those eyes. We never sample those eyes clinically. From a proteomics perspective, we identified 639 proteins in total and identified 26 proteins that were differentially expressed. The one that was really a standout protein in differential expression was retinol binding protein 3. But again, the findings were not what one would have normally expected because it was the control eye, the eye that was not injected with retinoblastoma, that had high levels of RPB3 protein expression. The eyes with the Y79 tumors had almost undetectable levels of RPB3. So what is RPB3 and why is it significant in ophthalmology? Well, it's known in ophthalmology in the setting of various ocular disorders, but particularly diabetic retinopathy. and it has been sampled in the aqueous of eyes with diabetes. The interesting thing is that RPB3 is generally identified in the aqueous of eyes that have no retinal damage in the setting of diabetic retinopathy, and is generally not identified in the aqueous of eyes that have proliferative retinopathy. So people have speculated that this is involved with a protective event against neovascularization. And uniquely among cell lines, Y79 has negligible production of retinol binding protein. So this is not coming from the RB cells. So in conclusion, this is a pilot study looking at a xenographic rabbit model, looking at eyes treated with intraarterial chemotherapy. It does replicate and does suggest that we can use this model for assessing cell-free DNA and proteomics. But there are findings in the contralateral eye, the eye that does not have RB, that are not intuitive, and it makes you wonder what's happening in our children that are getting unilateral intraarterial chemotherapy. In one case, we found cell-free DNA. In another case, and in the majority of cases, we have differential expression of RPB3. And whether that has a protective effect or the effect on the eye that does not have disease is still unclear, but it's something we'll investigate. Thank you.
Our next speaker is Dr. Samir Sait, who will speak on the role of liquid biopsy in extraocular retinoblastoma, a retrospective analysis of patients treated at a single institution.
Good afternoon, everyone, and thank you to the organizing committee for providing me with a platform to present my research on the role of liquid biopsy in extraocular retinoblastoma. I have no relevant financial disclosures. Tumor-derived cell-free DNA, also referred to as circulating tumor DNA, can aid in the diagnosis and prognosis of retinoblastoma. Retinoblastoma 1 alterations are detectable in the plasma in patients with intraocular disease. And in fact, RB1 tumor fraction, also referred to as the variant allelic frequency, may serve as a semi-quantitative measure of tumor burden. And it has been demonstrated to increase before treatment is administered to these patients and also subsequently decrease post-treatment initiation, whether that's surgical enucleation or with intraarterial chemotherapy. However, the role of circulating tumor DNA in extraocular disease or metastatic disease has not been explored. So we undertook a retrospective study, which was IRB approved, and identified 12 patients with extraocular retinoblastoma who were diagnosed between March 2015 to March 2023, who had serial samples of plasma and/or cerebrospinal fluid collected for analysis of circulating tumor DNA. The plasma samples were analyzed using a platform called MSK Access and the CSF samples with a platform called MSK Impact. Both of these assays are clinically validated and certified assays and hybridization-based next-generation sequencing assays which can pick up both single nucleotide variants as well as copy number alterations. So we wanted to ask some important questions using this. The first was, can we use the plasma circulating tumor DNA and particularly the RB1 variant allelic fraction to predict the risks of developing metastatic disease after enucleation of an eye with advanced intraocular retinoblastoma? And we identified 3 patients who had plasma samples collected prior to the development of metastatic disease. So these were eyes that were enucleated and we had samples prior to enucleation. And in all 3 of the patients that we identified, we saw a substantial increase in the retinoblastoma 1 variant allelic frequencies after enucleation, but prior to the development of metastatic disease, which suggests that this is should be considered a risk factor. Of note, 2 of the eyes had high-risk features on the enucleation pathology, but 1 of those did not. Secondly, we wanted to ask, in patients where we've already diagnosed the metastatic disease, can we now follow or track plasma RB1 circulating tumor DNA variant allelic fractions and monitor the response to treatment and also predict risk recurrence during surveillance? In all, we identified a total of 6 patients, 3 of whom had stage 3 disease and 3 of whom had stage 4A, which means there was no CNS involvement or no brain or central nervous system involvement. And interestingly, in all of the 6 patients, the plasma ctDNA level was very, very high for the RB1 at the time of diagnosis of metastatic disease. And this, in 5 of the patients where we had follow-up samples, this decreased substantially and essentially becomes undetectable within a month or 2 post the start of chemotherapy in these patients. We also wanted to understand if you can identify patients during surveillance who've completed chemotherapy and see who's going to develop a recurrence. And so this is just the panel on the left shows a patient who achieved a very good response both by imaging as well as by circulating tumor DNA, which essentially declined to undetectable levels post-chemotherapy and remained in a remission. However, the panel on the right demonstrates a patient who subsequently had a very good response initially with disappearance of all the circulating tumor DNA, but then had a central nervous system recurrence, and the plasma circulating tumor DNA was positive. So again, underscoring the fact that we can use plasma sampling to identify patients at risk. Then we also looked at patients who had cerebrospinal fluid samples collected, and we identified a total of 6 patients, 4 of which already had CNS disease, and 2 patients who actually had stage 4A disease without known CNS involvement at diagnosis. And interestingly, in all 6 of these patients, the CSF was positive at the time of diagnosis. And in 2 of the patient samples where we had serial CSF samples collected, the CSF showed that the circulating tumor DNA cleared after the administration of just 1 or 2 rounds of chemotherapy. This is an example of a patient again where we will use the CSF to track the tumor response to therapy and then look for recurrence. And this was a patient who underwent chemotherapy and had second look surgery and then received high-dose chemotherapy with stem cells as well as radiotherapy, and was in a remission for approximately a year post the high-dose chemotherapy, but then subsequently suffered a recurrence. And in the CSF, we could pick up the RB1 at a low variant allele frequency, but it was positive nonetheless. And then very interestingly, just another case that we wanted to highlight was a patient who originally was diagnosed with stage 4A disease. So there was no known CNS involvement at diagnosis. And this patient had CSF cytology that was negative at diagnosis, but the CSF cell-free DNA in retrospect was positive for the RB1 alteration. And this patient, after the completion of all of the therapy, had a CNS recurrence, suggesting that perhaps positive CSF circulating tumor DNA may represent submicroscopic CNS disease, and these patients deserve more intensive therapy. So in conclusion, monitoring of plasma and cerebrospinal fluid RB1 variant allelic frequencies can aid in the diagnosis of metastatic disease post-enucleation in children with intraocular retinoblastoma, help monitor therapy response in metastatic disease, and detect tumor recurrence during surveillance of chemo. It's also extremely useful for the initial diagnosis of CNS retinoblastoma when cerebrospinal fluid is always positive, and can also help detect occult CNS metastatic disease at diagnosis. And this underscores the fact that these plasma and CSF circulating tumor DNA assays should be incorporated in prospective retinoblastoma trials. Thank you.
Thank you. Our next speaker is Dr. Seema Das, who will speak on circulating cell-free tumor DNA-based liquid biopsy of cerebrospinal fluid in retinoblastoma.
Dr. Seema, can you present from this podium, please? Yeah. I request the next speakers to be ready and alternate between the podiums.
Very good morning to everyone, and thank you ISO for this opportunity to present. I don't have any financial disclosure. While worldwide we know that retinoblastoma from various studies has extraocular stage at presentation, and the recent data from the large Indian cohort shows that almost 1/4 of these patients has extraocular disease at presentations. And we know that the survival outcome is poor when the disease is extraocular, and even among the extraocular cohort, the survival outcome has been reported to be slightly better in the stage 3 disease as compared to the stage 4B disease, which has uniformly poor outcome. And we also know that disease staging is usually based on the clinical features. Radiology plays a very important role while staging the CNS disease, and cytology or the histopathology or cell block of the CSF fluid also helps us in staging the disease. However, if there is a minimal dissemination of cells into the CNS, those can be missed based on the conventional staging modality, and those can come back as disease relapse later on, causing a poor outcome. In our setup, these are the kind of patients we are usually bothered about. A young child who comes with an accidental orbital retinoblastoma following an intraocular surgery. The imaging shows an enhancement of the optic nerve till the orbital apex. There is no CNS disease at presentation, so the disease is staged at stage 3. We start on the conventional treatment protocol with the high-dose chemotherapy, he responds well with the no local recurrence and the local regression of the disease. However, comes back later on with a CNS relapse and dies because of the disease. So aqueous humor and blood-based liquid biopsy has been used very commonly now and has shown to be very promising results in disease prognostication, response to treatment, as well as for predicting recurrence. But what we are bothered about as clinician, is there a test which can tell us if the disease is already gone to the CNS at presentation, and instead of stage 3, it is actually stage 4, which can help us in talking to the family accordingly and help in better prognosis. So with this purpose, we decided to evaluate the usefulness of cell-free DNA, CSF cell-free DNA-based liquid biopsy as a modality for detection of early CNS disease, which might allow in prognostication for the retinoblastoma patients. For the purpose of these patients, for the purpose of this study, we included the CSF sample, which is stored, the DNA which was extracted from the CSF, which was stored in our biorepository. So in all, there are 51 patients where CSF samples were available, but for the purpose of this study, we wanted to restrict to the unilateral non-germline patients so that there is no contamination from the germline DNA and the results can be much more clearer. So only patients with stage 3 as well as stage 4A retinoblastoma were excluded who did not have any CNS disease as presentation, and all these patients were CSF cytology negative at presentation. Blood sample and tumor sample were available, were simultaneously collected and also analyzed. This was the sequencing pipeline. DNA was extracted using the Kaizen kit, and the sequencing was done using the Illumina platform, and the Agilent enrichment workflow was used, and those samples which is passed the QC were underwent sequencing with 1000x depth or higher. And the variants were filtered using the various databases, including the ClinVar as well as the MSK OncoKV. And finally, where the variants were identified, the concordance of the mutation in the CSF ctDNA, and if it was identified in the plasma and the tumor, those were also compared. So we had 10 unilateral non-germline RB in this cohort, and the mean follow-up duration ranged from 4 to 21 months. And these are the average amount of cfDNA which were isolated from the CSF as well as the plasma. Among these 10 patients, 5 had positive CSF liquid biopsy at presentation with this following variant allele frequency. And among this whole cohort of 10 patients, 6 eventually died because of the disease at the follow-up duration. So looking at this data, we can say that cfDNA actually picked up 5 of those 6 patients before the conventional imaging could pick them up, giving the sensitivity of the test to about 83.3% and a specificity of 100%. As expected, the mutations were all over the RB1 gene and not localized to one particular spot. And we also looked at the concordance between the plasma and the tumor tissue, wherever it was available and a mutation was detected, with the CSF ctDNA mutation. And in plasma, there was about 66% concordance, and in the tumor, there were 2 tumors. Out of the 3 tumors, 2 had, we could isolate and get a sequencing done. There was 100% concordance. So looking at the clinical course of the disease, if we look at the time frame, CSF-based liquid biopsy could detect disseminated disease, and in the cohort who eventually died because of the disease, it could detect it by a mean of 7 weeks prior to the symptom onset or detection of CNS dissemination on the neuroimaging. So if we look at few specific patients, this was a young girl, 7-year-old girl, unilateral non-germline RB, presented with a group E disease. The family refused enucleation. We started her on chemo. After 3 cycles, we again counseled the family for enucleation. They subsequently abandoned treatment. Came back later after 9 months with an extraocular disease, stage 3 disease with enhancement of the proximal optic nerve, but no CNS disease at presentation. We started again her on chemo, she responded. The eye went into phthisis, we did an enucleation, the imaging came out, the histopath came out to be clear, but the CSF and the blood sample which was collected at the time of presentation with the disease recurrence showed a particular mutation, and at 8 weeks follow-ups after the enucleation, she started develop CNS symptoms and died because of the disease. Another patient where at initial presentation we only had the blood sample because the metastatic workup was done elsewhere. There was a plasma mutation which was detected. Enucleation was done after starting the patient on high-dose chemo, and while on chemo he developed a massive orbital recurrence, and at this time the plasma which was collected as well as the tumor which was collected via FNSE had another mutation which was detected, which was not same as the first mutation. Some of CSF, which was collected during the time of presentation, showed the two different mutations for the first one as well as the second one, which was there during the time of recurrence. So, just to conclude, what it tells us that CSF-based liquid biopsy based on RB1 mutation detection has a sensitivity of 83% for detecting early CNS disease in this cohort of patients. However, this was a small number. We need to validate it further with probably a larger cohort. And we also need to correlate it with the imaging and the clinical findings to be able to give a more conclusive idea. What is the possible implication and the potential implication of the findings? Possibly we can actually look at the disease staging in a different way if we know the molecular makeup of the CNS tumor also, and those which are probably stage 3 or stage 4A at presentation. If this study becomes, or if this test becomes more robust, we can incorporate this for the disease staging also. And possibly if we detect the disease early and if we treat it early, right now we don't have a very good treatment protocol for CNS dissemination, but probably if we detect it early at a minimal dissemination stage, there might be scope of some treatment modality which might be able to give a better outcome. This is my group who has actually worked, specifically Ria and Aman who are here. They are the one who have worked on this study, and I would like to acknowledge them here. Thank you very much.
Thank you. Our next speaker is Dr. Dipankar Das. We're switching from cfDNA to lasers. So the next 3 topics will be about laser. This study title is Study of Red and Green Laser in Retinoblastoma Seeds.
Good morning, respected chairs, moderator and expert panel, ladies and gentlemen. Well, at the outset, I'd like to thank the organizer for giving me this opportunity to present a paper on study of red and green laser in retinoblastoma seeds. I do not have any financial or commercial interest in any of this material discussed here. Well, retinoblastoma seeds pose a clinical diagnostic challenge as well as in the pathology. We have seen Professor Munier, when he published his data of seeds, particularly the vitreous seeds, on dust, sphere, clouds, and mixed type of seeds. And we have published our data on the pathological sample where we have seen the undetermined seeds also. Now, mostly these seeds are being seen in pathology using crossing, fluorescent stain, and HND sections. But what is important is that when we process a seed, there are loss of the seeds during the processing, and we sometimes see less seed from the gross specimen. And so we thought that there may be use of lasers or some innovative staining in this. The objective of the study is to use a red and green laser in RB seeds in vitro in raw specimen of enucleated RB eyeballs. Institutional Ethics Committee approval was taken in the study. Experimental study were done in enucleated eyeball, were carried out with laser, class 3 laser product, complies 21 CFR wavelength of 532 nanometer, and they were seen in Zeiss axioscope microscope. Now, in 6-year study, we have seen around 59 cases of RB, where 35 cases have definite RB seeds. With red and green laser, RB seeds had shown varied changes. RB seeds were seen in anterior chamber 1 case, over crystalline lens 3 case, vitreous seeds 19 cases were seen, and retinal seed was seen in 1 cases. In retinal pigment epithelium, 2 cases were seen, and subretinal seed was seen in 1 cases. Combined vitreous and retinal seeds were seen in 7 cases, and calcified seeds were seen in 2 cases. Both calcified seeds were in regressed retinoblastoma in a RB. Now we see the pattern of regression of the vitreous seeds. We have seen in few of the cases with type 0 and a conversion into calcified seeds, and crystalline refracted seeds were seen in a few cases along with amorphous and combination of regressed seeds. Now we can well appreciate the upper 2 photograph of active seeds versus inactive seeds. In inactive seeds there is a hollowed one and configuration, and the sprouting of the seeds were documented in a laser configuration. And while you can see the lower photograph, the active seeds in red laser and the partially inactive seeds in the red laser. So level-free fluorescence is based on autofluorescence originating from fluoropods of active RBCs. Nonlinear microscopy has capacity of linking the structural information of cancer seeds. Our seeds showed an alternative way of conventional light microscopy to detect the RB seeds. Spatial image can be acquired from point-to-point configuration as in our study in a very cost-effective way. Limitation of the study was sample size was small. Further studies in larger specimen and scales are required in that way. In conclusion, the laser was effective to diagnose RBCs in raw specimen. Proper intensity of laser were used to detect the seeding. In future, the properties of light can be used to detect all these pre-hyaloid, subhyaloid, and subretinal seeds by using the property of light in real-time live retinoblastoma seeds detection. Thank you for patient hearing. I'd like to acknowledge my pathology department and clinician, and I like to quote that process of innovation are after a lot of basic experimental changes and scientific imagination. Thank you for patient hearing.
Our next speaker is Dr. Manoj Parulikar, who will be speaking on quantifying the efficacy of ICG-enhanced laser for retinoblastoma tumors.
Excellent talk so far, and thank you to ISU for the opportunity to present our work. No financial disclosures. Oops. So laser treatment, focal treatment for retinoblastoma is largely delivered through the 532 nanometer green laser or the 810 nanometer infrared laser. And you can see on the, there's a point to work. On the left, we've got the 532 laser with lots of small spots. And on the right-hand side, you've got the large spot 810 nanometer laser and the kind of scar that you would expect from both of these modalities. 810 nanometer laser, 810 nanometer laser TTT was first described in 1982. It's a low-frequency 810 infrared diode laser absorbed by the RPE. It generates heat of about 45 to 60 degrees centigrade after 1 minute and tends to penetrate about 2 to 3 millimeters back from the RPE. Logically, it therefore works best when there is underlying RPE and a tumor which is less than 3 millimeters in height. We do encounter challenging situations, and here are some examples. So when you I have no idea what's happening with these slides. They tend to have a life of their own. But when you look at the RB regression patterns, we see that type 2 or type 3 are particularly challenging, where you've got a completely non-calcified remnant or a partially calcified remnant. And these are some examples. This is a partially calcified remnant after 9 sessions of TTT. And this is the fellow eye of the same patient, again after 9 sessions of TTT. This is an uncalcified remnant after several sessions of thermotherapy. This is an example of recurrence within a depigmented scar that you can see right in the center. And these would be very difficult to treat with conventional TTT because there's no underlying RPE. These are examples of macular tumors in familial retinoblastoma, where chemotherapy alone may not be enough to treat these tumors. And if we are going to laser them, we need to limit the RPE damage to preserve vision. This is an example of disease on top of a calcified base. And you can see that since there is no underlying RPE, it's very difficult to laser and eliminate the residual disease. ICG is a chromophore, absorption peak of 805 nanometers, which is very similar to the diode laser emission of 810 nanometer. And therefore, there's enhanced response to TTT after ICG infusion into retinoblastoma tumors. We tend to use 0.3 to 0.5 milligram per kilogram intravenously. We start our laser 30 to 60, we give it 30 to 60 seconds prior to TTT application. ICG has a large molecular weight. It's 98% protein bound. It does not diffuse into the surrounding tissues, and therefore there is a lot of intravascular ICG dye retention within the tumor vasculature. It is safe, non-toxic, inexpensive, and has much wider applications in medicine. It has a dual effect. The hyperthermia caused by TTT induces apoptosis, and the photodynamic effect from the ICG generates reactive oxygen, which damages cells as well as vessels. The higher the ICG concentration, the lower the fluence threshold, and therefore the lower laser energy that we use. So we looked at the efficacy of ICG-enhanced TTT in 16 eyes undergoing local laser treatment of RB following chemotherapy. All eyes had large uncalcified or partially calcified tumors more than 3 millimeters height or residual disease with slow response to laser. The primary outcome measure, I'm really sorry about these slides, I have no idea what's happening here. Half of the tumor was treated with 8-10 nanometer large spot laser to titrate the laser energy, and the time to graying was noted. Then we gave ICG and we treated all of the tumor. So we treated the remaining half, counted how much time was required to get the response, and then went back to the pre-treated area. And the secondary outcome measure was the total time to cessation of laser, comparing ICG-treated tumors and similar tumors in historical patients. But of course, this second outcome measure is not as robust because it compares biologically distinct tumors in different individuals. So really, the primary outcome measure was the most important. And these are examples of pre and post-laser. Post-laser pictures are on the right-hand side. Again, you can see that there is enhanced uptake with the ICG. The difference is subtle, but you can see quite clearly, if you compare that portion with that portion, you can see that the ICG uptake, enhanced uptake, is much better. And these are our results. And you can see that the treatment time to get the same result following ICG was about half, 50% reduction in the duration of laser treatment to give you the same result. So the mean duration of laser per episode was reduced. There was a 40 to 60% reduction in the time to whitening for each laser spot. And the mean time to cessation of laser treatment for each patient was reduced compared to historical matched controls. ICG enhancement significantly reduces duration of treatment, energy required, total number of episodes of laser. Efficacy starts between 10 to 83 seconds. Most ICG is washed out by 4 to 7 minutes. So really you need to start the treatment within a minute of giving the ICG. And the clinical implications are that it would limit collateral damage to the overlying functional retina. There's a huge benefit in reducing the number and duration of EUAs, which is very relevant as more eye-conserving treatment is undertaken. And I just want to thank our team for all their efforts, and particularly our fellow Nishita for gathering all this data. Thanks very much.
Thank you. And our final speaker will be Dr. Rachna Mil, who will be speaking about ICG-enhanced TTT versus TTT for treatment of thicker tumors in retinoblastoma, a randomized controlled trial.
A very good afternoon. I think my job has been made much easier today, as the last two talks are almost on the similar topics. I would like to thank my co-authors, especially Dr. Ipshita Burman, whose thesis, this topic was a thesis actually. I have no financial disclosures. So I'll not spend much time since we've already discussed about the role of ICG, the focal treatment methods that are used in intraocular retinoblastoma. And Dr. Manoj has already covered the benefits of using ICG in combination with transpupillary thermotherapy. we know that transpupillary thermotherapy is most effective for smaller tumors, and how ICG enhances the effect of transpupillary thermotherapy. However, most of the studies in literature are retrospective with historical controls, like in the last presentation. What I wanted to do was to evaluate in a prospective study, in a randomized control study, to see if ICG-enhanced transpupillary thermotherapy achieves a greater reduction in tumor height for thicker tumors, which we defined as tumors more than 2 millimeter in height after the initial chemoreduction, compared to plain transpupillary thermotherapy. The secondary objective was to compare difference in complication rates. So we chose tumors which were more than 2 millimeter height after initial 2 cycles of chemoreduction in group B to D eyes, and we excluded the tumors that were involving fovea, or if there was any media haze precluding visibility of the tumor, or in tumors which were completely calcified after chemoreduction. Institute ethical clearance was obtained, and the study was conducted at RP Center over a period of 1.5 years. Standard baseline clinical workup and examination under anesthesia was done. So this is how we recruited the tumors. We did EUA after 2 cycles of chemoreduction in group B to D eyes, and individual retinal tumors were evaluated for inclusion and were randomized using simple randomization table. If there were more than one tumor that fit the inclusion criteria in one eye but fell in different treatment groups, then only one tumor was included. However, if both the tumors fell in the same treatment group, then both the tumors, even within the same eye, were included in the study. Group 1 was subjected to transpupillary thermotherapy, while as group 2 was given ICG-enhanced TTT. The endpoint of treatment was 4 consecutive treatment sessions at 4 consecutive EUAs done at every 3 weeks, or if the tumor achieved a height less than 1 millimeter, whichever happened earlier. We used a dose of 0.6 mg per kg body weight of ICG, which was given 30 seconds before transpupillary thermotherapy was done. The endpoint of treatment was mild change in color of the tumor, and this was repeated at every consecutive EUAs for the next 4 times. The baseline characteristics of both, we recruited 28 patients, 14 tumors in each group, and the baseline characteristics for the patient was comparable in the 2 groups, including the mean age, the family history, a laterality, the ratio of male to female, color of the skin, presenting complaints, and the eye included in the study. Regarding the eye, the distribution of the ICRB classification was similar in the 2 groups. The tumor location was largely similar, except supratemporal location was more common in the TTT group. But most importantly, despite the randomization, the tumor height at the beginning of treatment was larger in the group that was planned for ICG-enhanced transpupillary thermotherapy. However, at the end of treatment, that is the 4 sessions of treatment, the change in tumor height was significantly more for the group that was treated with ICG-enhanced TTT. In terms of percentage, this was 44% compared to 21% in the group that was given transpupillary thermotherapy alone. So the final tumor height was in fact comparable. It was 1.93 in the first group compared to 1.74 in the ICG-enhanced group. So despite a greater thickness at baseline, the final tumor height was similar. These are representative cases for treatment in 2 groups. There was no difference in the side effects in the 2 groups. Our results were similar to a previous report published in 2015, where 30 eyes were evaluated and 42 retinoblastomas with a mean tumor thickness of 2.5. They reported 32% reduction in tumor height, and ours is around 44%. So to summarize and conclude, the combination of ICG-enhanced TTT brings about greater reduction in the tumor height in thicker tumors of retinoblastoma without any, however, there is no significant difference in the side effects. Thank you so much.
So I think we've come to the end of the paper presentation. So all of them very good and a lot of take-home messages. Now we'll open up for discussion. Maybe ask the expert panels to, if you have any questions, and then the audience can.
I had one question to Tim. He mentioned a case of positive DNA in the contralateral eye. Can he?
Yeah, so that's really the interesting finding is why would an eye, contralateral eye, have cell-free DNA? And so, you know, you hypothesize that there is probably diffuse extension in this rabbit of DNA throughout, but why it's in the contralateral, quote-unquote, healthy eye, I can't explain. We have to do additional analysis of the cell-free DNA to sort of analyze that, but it's counterintuitive. And it really makes you think, we have all these unilateral cases, and many of us are proceeding with aqueous biopsy. None of us are touching the healthy eye appropriately, but there's clearly something happening in these eyes. You know, when you have differential protein expression, and it's higher in one eye, and it's the eye that doesn't have RB, you know, again, we think of this as an ocular situation, but it's a holistic situation, and I can't explain it yet, but it definitely is an unexpected finding. And it demonstrates why we need more animal models, because we're never going to assess the contralateral eye in a healthy eye. We're not going to simply do that.
So Dan, just to clarify, when you say there was cell-free DNA in the contralateral eye, you mean there was cell-free DNA with markers of the tumor? Because cell-free DNA is a naturally occurring process that even healthy cells release cell-free DNA, and we differentiate cell-free DNA from tumor cells versus normal cells by the markers they harbor and the size of the DNA fragment.
So TBD.
Okay.
I can't answer that definitively
Okay.
yet. That's the honest answer.
Thank you. Yes, Ashwin.
Hi, Ashwin Reddy, London. This is a question for Tim Coulson. So you're talking about anti-VEGF drugs. We are using anti-VEGF drugs, obviously, for retinopathy prematurity and for retinoblastoma, for neovascularization and hemorrhage and so forth. Do you foresee a time when we won't have to give intravitreal Malfilan and topotecan, and we can just stick with Avastin, which is a anti-neoplastic drug? That's how it was created. And that could also help with neovascularization after intraarterial chemotherapy. So you're doing the two hits, and often intravitreal chemotherapy and intraarterial chemotherapy are given together anyway. So, yeah, what's your thoughts on that?
Yeah, it's a very appealing prospect. There isn't too much data yet. There was one small clinical trial done in China several years ago using Avastin for treatment of retinoblastoma with some promising results, but it's definitely something that needs further exploration, starting in preclinical models, especially in the vitreous seed setting, but there's, I think, real potential there.
Great. Yes?
Hi, Prithvi from Stanford. Tim, I'm going to keep you up here. Wonderful talk, and I think it really shows the need for more of these molecularly based experiments that you're doing. And to tack on to what Ashwin said, I mean, fine, single agent anti-VEGF that we're using in the eye anyways is fine, but you know, I think this is also an opportunity for looking at other mechanisms of drugs that we have available in other oncologic diseases. Even in the eye, I mean, we had trials with anti-angiogenic steroids, which could be used in sequence. And I think the future, I'm hoping, and I'd love your comments, is that, you know, maybe it's just a whole different caliber of drugs that we think about using, not just adding Avastin to like our current protocols. But your thoughts?
I couldn't agree more. I think one of the shortcomings of our field is that there really hasn't been the targeted therapy revolution for retinoblastoma that there has been for so many other solid tumors. One of the challenges we have are the animal models that are available, right? These rabbit orthotopic xenografts are labor intensive, expensive. It's hard to do any kind of medium throughput screening of drugs, but I think as these models become more established and widely used, there's potential there to explore new experimental agents.
Hi, so a question about the ICG augmentation. If there's a calcified tumor and there's regrowth over it, do you think it would help as well? Manoj? So I was actually wondering, how does the ICG help? Because if the tumor is very thick, does the laser get all the way through the tumor and then enhance its effect? And what would happen if there's calcification inside the tumor? Would it still help when there's something growing on top of it?
So that's actually one of the indications for the disease. Can you hear me? That's one of the indications for using ICG. The beauty of ICG is it remains in the association. Because it's protein 19% remains within the association. And most of these tumors have a degree of local association.
So you're thinking it's working from within the tumor, not from the core?
It doesn't work. It works on depigmented stars. So one of the examples that I showed was a completely depigmented bacterial star. And then that's where the ICG comes into the.
There's so much time.
Questions in the app.
Thank you.
I would agree with what's been said. When we published our series with Hassan Rizoglu, we basically used ICG-enhanced TTT in very fair-skinned children who had very little RPE pigment that needed a better uptake. So we generally didn't need it for children who had darker complexion.
Yeah. I'll just go to the online question next. There was one, I think, for Dr. Stathopoulos. It asked, could you comment on the cutoff or definition of 6P gain in your cohort? Yes, because the subsequent presentation, which I think was from the LA group, defined high-level 6P gain as greater than 4 copies. Could there be a difference in the two?
So we did 0.5 for baseline. Underneath it could be noise. In the LA studies they did 0.20% from baseline. For us it will be then just 0.10 more. I think that won't be much difference.
Can I ask one question?
We have lots of time until 12:25. We started early, so I'm going to keep you hostage here. This is interesting discussion.
I want to ask a question to Dr. Seema Das. Actually, very interesting study. Why did you include only non-germline cases and did not include germline cases in your study? Any reason for that?
Yeah. Thank you very much. So basically this was a very pilot study, proof of concept, and we just wanted to see whether we can detect the RB1 mutation-based ctDNA in the CSF. And we also know that if we include the germline cases, all the cases, we can never be sure whether we are detecting the germline DNA or the tumor-derived DNA. Though variant allele frequency can give us a clue, but this is not something which is probably very foolproof, at least in the pipeline that what we are using right now. So we just wanted to validate that as a first step. We now have data available for the non-germline cases also, and we're also looking at the copy number changes for the non-germline germline cases. And probably complementing that, if you complement the two together, we will probably have a larger data and which will be inclusive of both non-germline as well as germline cases.
Dr. Das, I'm wondering, further to that question, how do you compare your findings with those of, like why do cfDNA or ctDNA and CSF to begin with? About 12 years ago, the team from Toronto showed, nobody was talking about cfDNA back then. We just assumed we might be able to find some molecular evidence of minimal residual disease and showed that we could see both the RB1 mutation and the somatic copy number alterations. In fact, one of the children that we published on later ended up with metastasis, so this is relevant to the other publication as well. So how do you see your results comparing to those?
Yeah, so I think in our setting, the whole idea of working on the CSF-based cfDNA and rather than the aqueous and the the blood-based is in our setup, the question that we face almost on a daily basis is survival. We talk about eye salvage, but what is more important for us is the survival outcome. So most of the time, in fact, the patient who come to us, they are not at a stage where we can even take aqueous humor because the disease is already extraocular. So if we can sort of get answer from this test, and if there is something which can tell us whether the disease has already gone to the CNS, this is something which will be applicable in our scenario probably much more than
Oh, no, I don't disagree with that. I agree. I'm just wondering, I think one thing we haven't talked about, we're all defining circulating tumor DNA in slightly different ways. So the reason why circulating tumor DNA is so effective for aqueous humor is that we're not expecting to see any cells in this aqueous humor, so we wouldn't want genomic DNA. But when you're looking at the CSF and worried about metastatic disease, you might expect cells there, in which case you could just look for genomic DNA, which is what we had done years ago. So I guess your hypothesis is there are metastatic cells that you can't see on the cytology, but you're looking for cfDNA. Why cfDNA and not, it's just a matter of extraction. Why not just...
So are you talking about why not the cells and why this
DNA?
Yeah,
why cfDNA? Why is that? Is it just a buzzword and are you actually looking at genomic DNA but calling it cfDNA? I'm curious to know about your methods of DNA extraction.
So that's the reason we have taken the cases which are stage 3 and not CSF cytology positive. At least going by the cases that we see in the clinical settings, sometimes there are stage 4 disease also where the cytology does not come out to be negative. And by the time the cytology comes out to be positive, they are already at a stage where the symptoms are already started.
Yes.
So probably there is always a window period where you do not get the disease detected on CSF based on the cytology, but possible that the tumor cells are already there, and if you're able to detect the DNA, that could be a little early
I
detection.
agree with you because we showed it 15 years ago before we knew about cfDNA. So.
Yeah.
Next question.
Can I ask Dr. Seema one more question while she's still there? Dr. Seema, I'd just like to ask that going forwards, based on the results of your work, if we now detect cfDNA in a CSF of a patient with extraocular RB, would you change your treatment protocol or chemotherapy regimen or in any way, or your surveillance in any way, like based on that information?
I think that should be the goal for the future, but I don't think this data right now at a stage based on which we can take a call on changing our treatment decisions, or maybe how we counsel the patient. Maybe once we have more robust data, when you're pretty sure that if you're detecting a ctDNA, we are pretty sure to say that, okay, this patient is going to develop metastases and symptoms down the line. I think that's the stage we can go for changing our management decision as well as the way we counsel the family.
Thank you.
Yeah, may I ask a couple of questions? So the first question is for Dr. Parulelkar and Dr. Rachna Meen. It's about your work on ICG enhanced TDT. So we have specific indications where we do use ICG. What I want to know is, would it in any way affect the way chemotherapy would behave on the tumor? Since you're specifically targeting a dye which is intravascular, are we damaging those vessels and preventing access of chemotherapy to the tumor?
Yeah, point well taken, because in our study we did it while we were giving chemotherapy in these eyes. But frankly speaking, as we observed these tumors, there was no change in the vascular pattern. There was no sclerosis or anything of the vessels that we did observe. So we did not observe that. But yes, I think since you're saying it's intravascular, there is a possibility that it might affect the vascularity of the tumor, but I would want other opinions on this.
In our series, and we had sort of a large series of ICG-enhanced TTT in really fair-skinned children, we saw no sclerosis of vessels leading up to the tumor. Of course, where we did the treatment, we had sclerosis of vessels, but nothing leading up to the tumor. And we thought that it really didn't impact the delivery of chemo.
Thank you, Carol Rachna. Can I comment on this as well? So in the majority of the cases where we are using ICG, we are post-chemotherapy, and usually it doesn't affect it. And we hardly ever will use ICG while there is concurrent chemotherapy. So I really don't think it would affect the uptake of chemotherapy. Thank you.
My question to Dr. Rajna or Dr. Manish. So, when you choose the patient, do you first do ICG angiography, take pictures to see the vascularity and the blood supply of the tumor when you choose to give ICG and CTT? And my second question is, do you have any experience of treating with ICG and CTT like typical cases like cystic RBs?
So for the first part of your question, no, we did not do any ICG angiography, but these cases that we treated were treated primarily. So we had not done any laser photocoagulation or primary TTT treatment. But yes, of course, in cases that are residual after an initial treatment, it might be a good idea to do angiography if you're not able to see the vessels. But I think that is Dr. Manoj's, we should take opinion on this from Dr. Manoj.
Thank you. Excellent question. And I agree with you. It's a great idea to do microvessels, which was probably not going to show up as well with fluorescein angiography as we would like. We work on the assumption that there is a degree of microvasculature. But I think it's a great idea, and maybe we should start doing it for our cases before they start. Thank you very much. Which is why we present all these cases, so that we can learn from the audience.
The part 2 of your question, what was that?
Do you have any experience in treating the same method in cystic RBs?
Okay. In cystic RBs, I usually avoid using laser treatment of any kind, especially in the part that is cystic. The solid part we do use, but mostly these tumors do not show any change in my experience.
I would agree with what Dr. Meal has said. Cystic RBs by definition tend to be biologically less active, and often there is a residual component which could go on for a long time. I don't think ICG would particularly increase the risk in these cases, and it may well be that I have no personal experience of using it in cystic RB. Have you had any cases?
Sorry, I have also not tried ICD enhanced TTT in these cases.
Thank you.
Can you hear me? Yes. Here, Venkata, take this. So I was getting some texts about 6P, so I thought I would just make it part of this discussion. So, Christina, I don't know where you are. You're right that when you follow Baslin, which is the methodology that we described for calling any chromosomal alterations, it's a 20% deflection, and below that would be noise. That being said, that doesn't mean that 20% is a 6P call. So a 6P call in Zhu et al. Was a 1.5 mean to the medium, which is, again, greater than 1 copy number additional. So 4 or more copies is another way to say it. I think ultimately this is an unanswered question. This is a finding that we sort of serendipitously fell into in this group, and it was really exciting research for us. I think the only way that we're really going to understand it is to take aqueous and look prospectively at how these patients do. If you're taking aqueous at all different times, you could have an eye that has 6P at diagnosis, and at the end of therapy, you don't see 6P, right? So we really have to understand what we are defining and then follow prospectively in a multi-center way. I will say, and Venkata is here, when we moved from our research protocol to our clinical protocol, all of the tests came back as 6P gain present, and Dr. Shaw's here, our medical oncologist, and we were all like, oh, expletive, shoot, are these all 6P eyes? But it wasn't high-level 6P gain, it was that 6P gain is present. So a lot of RB has 6P gain. It's one of the most common chromosomal alterations in this cancer. just like we see 2p gain, right? That doesn't mean MICAN amplification, and 6p gain in and of itself does not mean high level 4 or more copies of 6p gain, and that's, at least so far, primarily at our center and with the few centers that give us samples, has continued to hold as a poor prognostic biomarker. Do you want to make a quick comment?
Yeah, actually, as I presented, 71% of the cases in our 21 cohort samples has a 6p gain. And what I tried to show through the presentation is that the high-level gain can also be further delineated into either amount of circulating tumor burden and also the integer copy number. Is it just 3 copies or 4 or more? So, I mean, again, all the studies so far I see is, since retinoblastoma is so rare compared to other cancers, for example, it's hard to come to a definitive conclusion, but hopefully this will become clearer with more collaborative studies which are larger.
Thanks. Venkata, while you're there, one of your slides indicated that LB-seq for kids also has retinoma. And some of the earliest genomic analysis of retinoma, like Jesse's saying, you know, you start to see those gains, even though it's a benign tumor, it's not those high-level gains. So do you have any retinoma data to share with us? Or is that just means you could have a retinoma to study?
We did have one case. Interestingly, with retinoma, the amount of DNA that we extracted was about, if I remember correctly, about 0.35 nanograms compared to well over 10 nanograms you might get for retinoblastoma. And then, even with that, we proceeded to do the test, and we did see profiles similar to not really osteosarcoma, but it's not typical of retinoblastoma. So this was just one case. So this anecdotal.
Thanks.
Do you want to take a question? Yeah. So again, regarding the 6p gain, so how do we handle it if you have multiple tumors in that eye? Because you could have one of the tumors that does have the 6p gain and then the others, and in aqueous humor you have the sum of all of this. Or do you have any hints that those tumors that are more aggressive shed more ctDNA?
Such a smart and good question. Not a surprise from you. So we did not remove eyes that were multifocal. Basically, we do have a subset of eyes that have multifocal tumors. I presume, like you said, that in our high-level 6p in the aqueous, that's probably coming from one of those clones. But if it does act aggressively, I think it will dictate how the eye responds to therapy, even if the other clones, you know, play nice in the sandbox.
We have time for one more question. There's many online, but many of them have actually been answered in our discussions and even in some of the talks. However, if you have a burning question that was not answered because it's part of the online, please come to the microphone. Thanks.
For Professor Kousen, the question is that in the normal retina, the RPE, the Muller cells, the astrocytes, some neurons, and the endothelial cells make VEGF. So in the vitreous seeds, you showed a beautiful picture of the RNA scope for VEGF with a very diffuse distribution of transcripts. Now, which cells are making VEGF? Is it the neuronal type RB cells? Is it the glial type RB cells? Or do you get benign glial cells in those seeds creating VEGF to then enhance the survival of the RB tumor cells?
Wonderful question, thank you. So, of course, in the case of the rabbit xenograft, it's just the wary RB1 cell lines, so all the cells are quite uniform. In the case of the human seeds, though, we haven't explored other markers. That's a really interesting thing to explore further.
And we'll take the last question from Paula.
Okay, thanks very much for all of these very interesting presentations. Just one comment. So supporting teams' work, I think that you are already using anti-angiogenic drugs, as topotecan is an angiogenic drug, and also melphalan, it is also affecting the retinal vasculature. So I'm not so sure if we need to add some other drug, as these are already making the angiogenic effect. Perhaps you want to comment. And then I have two questions. So one is for Samir. I wonder if you have studied the correlation between the cell-free DNA from the tumor, derived from the tumor, of course, in the CSF and in plasma, because patients would be much easier monitored in plasma than in the CSF, right? How it reflects.
So it's a great question, and we have very limited sample size, and this is a these were collected at the antibiotic-resistant patient and occurrence. So in the fourth stage for 8 patients that are showed who were not developed CNS occurrences, we sampled both the CSF and plasma, and both the CSF and plasma were positive and occurrence. I think what's interesting is the position of the lab showing that perhaps you could do that because unfortunately we didn't have the CSF samples or plasma samples prior to the occurrence. Most of these were corresponding to the kind that we saw in something like
I think we haven't done the awards, and there's a, so Dr. Usha?
Yeah, so all of the papers were very good, but then we need to grade them. So now the topper for this session is Dr. Timothy Carson. Please come on stage to receive your medal.
I request the presenters of the top 3 papers, as they are announced, to please come on stage, and the chair, the moderator and the expert panelists to please join for a group photograph as the medal is being presented.
The second on list is Dr. Dan Gombos. Please come on stage. And the third, Dr. Manoj. Please come on stage. Dr. Manoj.
Chairperson, the moderator and the panelists for an excellent session. Just a reminder, there are a lot of questions on the app, so I request the presenters to also check the app and answer some of these questions. These will be present throughout, but because of lack of time, constraint of time, we are unable to take all the questions live, but the authors can just go and answer to these questions in their free time.
All right, next we have an oration, the Jerry Shields Lecture. And for this, I invite Dr. Dan Gombos as chair, Dr. Jessie Berry to co-chair, and Dr. Victoria Vishnevsky-Adai to moderate. And I also invite the expert panelists, Dr. Fairuz Manjandavida and Dr. Santosh Nabar.
Good afternoon, everyone.
So it's a big pleasure and honor for me, being one of the students of Jerry Shields, to present this name talk and the awardee, Dr. Catherine Patton. So I will start with Jerry Shields. He doesn't need an introduction in this audience, but still I would like to mention that he is the Emeritus Director of the Ocular Oncology Service at the Wills Eye Hospital. He is a professor of ophthalmology at the Thomas Jefferson University, Philadelphia. He was born in 1937 in Connecticut, US, as the youngest child of 8 children. In 1964, he graduated from the University of Michigan Medical School and then completed an internship in Denver Hospital in Colorado. Look at this. He also served in the Army. He did 1 year as a battalion surgeon with the United States Marine Corps in Vietnam. No more, maybe this is how his interest in worldwide education started. And then he served 1 year at the US Navy, mainly in Europe, in Naples, in Italy. Then he also graduated his residency at the Wills Eye Hospital in 1967 and pursued a fellowship program at the Armed Force Institute of Pathology in Washington, D.C., and additional fellowship in vitreoretinal surgery in Wills Eye Hospital. At that time, there were only 10 physicians worldwide with interest in ocular oncology. He also formed a very, very good partnership with Carol Shields, which also doesn't need an introduction here. So that makes him the guru of the guru, as we learned here in India. So he is the teacher of the teacher's teacher. And together, this partnership led to a very nice family that they are still raising with 7 children, 5 of which are physicians. So let's mention some of Jerry Shields' major accomplishments. So in 1997, he established the strong ocular oncology service at the Wills Eye Hospital, which most of us know and were educated there. And for 50 years, as Carol says, he didn't leave the office. And he's still active in the office, in the care of patients with cancer in the eyelid, conjunctiva, intraocular structures, and orbit. And he pioneered many of the procedures that we do practice today. He published together with the very strong team of the Wills Eye Hospital, he published over 1,800 scientific reports in peer-reviewed journals. He authored and co-authored 13 major textbooks, and 2 of them are depicted here, and we know that they serve as the Bible for anyone who wants to start and do ocular oncology. He has given 1,560 national and international lectures, and 82 of them were prestigious named lectures. He received several prestigious awards. In 2013, he was nominated the National Physician of the Year, and in 2014, he received the award of the American Academy of Ophthalmology, Admiral Award. He shared knowledge with all of us, and he and Carol had more than 200 fellows during those years of service, 50 years of service, and some of their fellows serve now in leadership positions all over the world, in Europe, Asia, South America, North America, Africa, Australia, and Israel. He was nominated by his peers to be the first president of this society. And it is very, very rarely when we meet a person that is contributed so much to one subspecialty. So for all that and more, they also honor him with this named lecture. And the first lecture was given last year by Carol Shields. This year lecture will be given by Dr. Catherine Patton, that we also know, but I'm going to share some of the information she generously shared with us. So she is a professor of ophthalmology at the University of the British Columbia, Vancouver General Hospital, and the British Columbia Children's Hospital. She is the director of the Ocular Oncology Unit at the University of British Columbia and the director of the Diagnostic Ophthalmic Ultrasound Unit in the same hospital. She's the head of the Division of Ocular Oncology and Tumor Group Chair at the British Columbia University. She studied medicine at the University of Western Ontario, and she did her residency at the British Columbia University in '87. She did a fellowship in ocular oncology in Toronto, guided by Random Simpson and Brenda Galli, that also doesn't need an introduction in this audience. Then she did another fellowship on diagnostic ultrasound in Bascom Palmer Institute, and she joined the ocular oncology service that was established in 1937, but she established inside their service the service for ultrasound diagnosis, and she runs it since then, and then later on she became the director of the whole service. She also established the first and the only, actually, proton therapy facility for ocular treatment in Canada, and she runs it since 1990. So Catherine Patton actually was there in all the footsteps of all the major advances in ocular oncology. She was part of the collaborative ocular oncology study when she was in Toronto. She was there when they initiated the systemic treatment with chemotherapy for retinoblastoma, the concept of chemoreduction. She was part of the Brenda Galli lab project that studied the loss of heterozygosity in retinoblastoma children. She was there when they developed, together with Lynn Murphy, the concepts of local chemotherapy, the delivery, the subtenon techniques that they started, and today the evolvement of that to the chemo plaque concept that is used in Canada. She was there when they applied the intraarterial chemotherapy in Canada, and she started that under the guidance of Francis Mounier. And she introduced the custom brachytherapy and the use of new isotopes in Canada. She also was part of the generation of the Canadian National Retinoblastoma Guidance that were laid out in 2009, and they're still active there. She is very involved in education of students, resident fellows, and not only in ocular oncology, but in general ophthalmology and cataract surgery. She's serving in many leadership positions. She's the Associate Dean in the Faculty of Medicine in her hospital. She's the co-chair, or she was the co-chair of the ESO meeting in 2005. She was the honorary treasury, the former honorary treasury of this society, and she serves an advisory person to the board since then and today. She received some major awards, as you listed here, and she is very focused lately at medical ethics and personal integrity, and she's advising the board in this aspect. So just a little bit about her other life, not the professional life. So she and her husband Jeff are an A-team, and they are very, very interested in classical music, downhill skiing, and hiking. And she climbed the Kilimanjaro, the Everest camp, base camp, the Dolomites, and here she is with Jeff doing the Via Ferrata. You can see how they are holding the iron suspensions, doing the Via Ferrata, which makes you climb in the air, more or less. So it's a very unique experience. She is also very good at feeding her friends. So she has many culinary interests, and she likes to travel and see nature. So she says that she firmly convinced that her new electric machine is just a phaco machine in wheels, and it's a sign for things to come in life as well as in work and in our next decades as physicians. She says that her life is made magic by the trust of the patient and tolerance of her husband Jeff. So please welcome Dr. Catherine Patton to deliver the Jerry Shields.
Good afternoon, everyone. Thank you so much to the organizers for a spectacular meeting. Dr. Februz and Dr. Santosh, you've done a phenomenal job. And thank you also to the committee for this unbelievable honor and for the opportunity to speak to you. When I was told that I had been chosen to give this talk, I asked about the criteria and what the topic was to be. And Dan Gombos wrote back to me and said, you can talk about anything, but it has to be awesome. And Dan, I'm not so sure about awesome. Following Carol as the inaugural speaker is a little bit daunting, and my form of awesome won't be quite like that, but you can tell me afterwards. I couldn't possibly start, even though there was an introduction ahead of time, without saying something about Jerry Shields. Being asked to give this talk left me reflecting on life and what has happened and how many of you there are in the audience. When I first met Jerry, it was at small meetings, and there were rapid-fire case rounds and study club, and I was an ophthalmology resident, bowled over by the idea that you could look after cancer in eyes and that somebody could be so smart and so involved and so interested and excited about teaching. And Carol, I think this was just before you, or just around you. So this is a long time ago. But when you look around the audience and around ocular oncology worldwide, you see his enormous influence on so many and on everybody who's gone after that. The idea of a personally run group that entered so many different fields, that got involved in everything, that adapted new technology. So this meeting is 2024, but I looked up what we heard yesterday. I won't repeat except to say I was at some of the early meetings as well and distinctly remember the Jerusalem one. But I wanted to highlight the 1999 Philadelphia one. That year was the 25th anniversary of the ocular oncology service, I think at Wills Eye Hospital. It was a 4-day meeting. Folks were having a 4-day meeting, but I don't believe there were any parallel sessions. There was lots of time for discussion and analysis. And look at who the guests were. Alfred Knudsen, Peter Lomash, Lauren Zinnerman, Don Gass, and Anna Meadows. We had pathology. We had folks from Europe. We had people who were medical oncologists. And so amazing to think that here we are, all this time later. Now, 20 years after the establishment of the society. But of course, you know that Jerry was into other things, and not only did he help many, many ocular oncologists flourish, he had a flourishing family and lots of fun, and was absolutely convinced that being together, sharing things together, mentoring people was an important component of how you conducted life, how you encouraged people, and how you created a great legacy. He has certainly done that. He captured this in his autobiography, and we know all the components of what he had. Nowadays, we would call Jerry an influencer. So I chose as my topic to talk to you about where are we going, but this won't be like what we heard yesterday. There is a proverb. I went down the rabbit hole of trying to figure out its provenance. Suffice it to say that it's probably a truism attributed to Africa. If you want to go fast, go alone. But if you want to go far, go together. Just imagine for a moment that you have a problem that you have to solve. I was thinking about this, and at the time I was starting to think about this, these poor folks who thought they were gone to space for a week got stuck for probably 8 months. I don't think they went with 8 months worth of clothing or 8 months worth of things to do or 8 months worth of preparation. Nonetheless, they have a problem to solve. It's a real problem and it needs a real solution. And this is what the news was of the day, that they eventually decided that the best solution to their problem was to actually let go of the one piece that tied them to home. Rather than hanging on to it and trying to fix it where they were, the whole idea was send away your life raft. That, to me, is an amazing piece of thinking. And I'm sure they didn't do it alone. I'm sure that it was in a group, but there was an announcement. People gave a unified front and a discussion about what was going on, and they had a plan. And they articulated that plan in public for the news, the media, and everybody else who was watching. I want you to hold on to that thought. So I was thinking about what are the influences currently for ocular oncology globally. What is going to happen with our current demographics? Are we thinking about what's coming in the door as opposed to the solutions for the problems we're looking at now? What does the future hold with climate change? We have all these digital devices and the new AI. How is that going to influence us, both as a tool, and we've heard some of those lovely talks already, but also as a threat to our own integrity, to our patients and their families' understanding of what's going on, and maybe as a disruptor, not a replacement for what we're doing. One of our colleagues was talking about a model. You can look and say, well, AI might replace you, but actually look at what's happened with some of the things in retina, that Avastin was going to fix things. It simply meant they needed more retina surgeons. So I don't believe this is going to be the end of ocular oncology or even much of an extender. I think it's going to give us different answers and more to work on. There are new drugs and new mechanisms. The way publications are done and distributed has changed, and some of them are for pay, and some of them it's difficult to figure out the provenance. You have to work hard to see whether or not you believe it or wish to publish there. Funding models for both research and clinical care are changing, and changing under our noses, changing without our input. How are we going to respond to this with our kind of disease? The global burden of disease, not only ocular oncology, but everything else, is also changing and is actually designing the landscape that we're living in. You may not think of yourself as a resilient person, but you just lived through a pandemic, something that hadn't been seen for 100 years, and it's given us a different appreciation of how much we are connected to each other, how much we have problems to solve that aren't of our making, but actually how fast you can generate and validate and implement a vaccine if you work together. So I would like to look at the impact of ocular oncology in the middle of all of that. In my experience in my roles both at the hospital and in the academic setting, it's about 5% of a hospital's activity and about 5% of a faculty of medicine. In other words, we're small potatoes. And that's all of ophthalmology. What about ocular cancer? Ocular cancer in the cancer world is relatively small. There are about 2 million new cancers in the US a year, and about 3,300 of them will be ocular. In the UK, it didn't make any of the top 20 commonest cancers. And if you look at global registries, ocular cancers are about 0.15 to 0.2% of all cancers. That's how the rest of the world sees us and where we fit into the paradigm. Where does ocular oncology fit in ophthalmology? I think it depends on your location. In Jerry's world, Jerry, by force of personality, by liaisons, by working hard, by appealing to people, by talking to the public, made people care about ocular oncology. What about ocular oncology in oncology? I don't know about anybody else, but for me, the COVID pandemic changed things. Our access to treatment, our access to care, our wait lists, the things that burdened the system, all of a sudden changed, and they were more backed up and more behind. And yes, I might have something to refer in, but they also had real parameters for care and for larger volumes that were hard to meet. And the main headline that's of concern about that is that the percentage of general tumors that are now being diagnosed in emergency rooms rather than in a care pattern. So that is, again, the environment that we're kind of working in. So what do we have to tell them about? The Knudsen two-hit hypothesis. The largest clinical trial, maybe the only clinical trial, of surgery versus radiation. That came at the Champalimaud Center ARVO science meeting, where groups that were not ocular were talking to us about our field. I was part of the COMS study. I never realized that the rest of oncology didn't have such a study. The heritability factor in the TNM classification makes us unique. Tumor genetics, when I started, we went to the ISGET, or the International Society for Eye Genetic Disease and Retinoblastoma, because we in retinoblastoma wanted to know about the genetic techniques, and most of them were in heritable eye disease. Now it's all over the place in all of oncology. So we were there early. Early implementation of AI happened in imaging in ophthalmology. And then liquid and optical biopsies are again unique. We can look at the tumors. We are doing amazing things with them. So if you look at those unique factors, it makes us interesting, appealing, and maybe leading edge. Now I'm going to do the most dangerous thing a speaker can ever do, and I'm going to mention a few things. Folks, I love all of you. You have all done amazing things. I will undoubtedly forget somebody's world-changing thing. These are only examples. I wanted to think about how thinking had changed in the last 30 years. And we have had some thought leaders in our field who have looked at a problem and pulled a technique or a process that isn't part of our normal world to think about it. For example, Bertol D'Amato was busy building the bridge while he was walking on it in the way Liverpool was collecting data and changing the modeling while the data was being collected. So it was a feedback loop known as a neural network. He talked about the neural network concept. Most of us hadn't heard about it. We don't use it in other ways, but it was a technique to help us through an ophthalmology problem. Teams. Everybody has shown spectacular pictures of large groups of people with whom they don't function. It's not an individual sport. What we do is a team effort. People weren't talking about that 40 years ago. Almost all of you are now, and it's a big recognition of that we don't operate in isolation. Patient partnerships. Not only the family support groups, but the family input and patient input that is now required in some places for funding, for research, has been a big game changer. Partnerships with other centers. Matt Wilson and the St. Jude's group have a very well-developed way of linking to other people, providing them backup, not doing the work for them, but helping them acquire skills that are appropriate for their centers. They even have a kind of board game to help you think through it. And Matt, I'd like to borrow the game and take it back home, because I think those ways of thinking about how we do our work change something that isn't in any textbook of ocular oncology. Point of care treatment and how you document it can change the outcomes. Brenda Galley has created with her team the Depict Care that shows graphically what's going on for the patients and families to look at, but also for the researchers to understand visually at a glance what's actually happening. Transnational registries to solve our orphan disease problems. Andrew and Dee Dee have this global data collection because we need more input than just one center can provide. We've gone through big data and its contributions. We've now got robust classification systems so we can talk to each other, to outside folks, to the oncology world, and to funders about what we're doing. And we have meaningful patient participation in many ways. So how do we make a difference broadly in what our world looks like and what ocular oncology looks like 10 or 20 years from now? We need to learn the lingo of the administrators, the funders, and everybody else. We have our own. All of medicine has its own language. But if you don't understand the language and the parameters that others are working by, you'll never manage to get your message across. We need to group together, and people have done a brilliant job of that in many places already. So we're well on the way, whether it's ISOO, the Collaborative Ocular Oncology Group, OOG. Now, some of these are working groups on specifics. ISOO is uniquely a collaboration of all of us, but not over patients. It's a way of sharing education and sharing advocacy, and it could step up to the front for this. 1RB World is patient and survivor driven, another way to have collaborations, and they invite the doctors and the speakers and tell you what they want to hear about. Again, important for us to see for how our patients are treated. We need to think about how we do visible leadership. Some of our members have been leaders in ARVO, at the American Academy, in PSYOP, the Pediatric Oncology Group that Guillermo Chantada is president of currently. Those places make ocular oncology showcased. They tell our story, they tell the story of the patients and the challenges, and they present different venues for us to learn new things and adapt new techniques and remain relevant. We can leverage. The WHO has a Child Global Initiative, and it turned out to be a wonderful place for looking at global outcome. The goal isn't really high. I think it's 60% survival globally for retinoblastoma. But it is a game changer across the field. And in the meantime, it's got attached to it ways of gathering information so that we've got sound information and good things about how different countries are collaborating and how the incomes are affecting what kind of treatment is available. At the 1RB World, we heard a talk from people in Australia about Oceania, where they were looking at the presentation of retinoblastoma in that population. And I was very puzzled by one of the things that I heard, where they talked about retinoblastoma being the most common childhood tumor. And the dinner discussion with the presenter said, well, actually, it's because they don't diagnose the leukemias and the other things before the children have died. So we have to remember that what it might look like numerically to us in one place may not at all be what it looks like somewhere else. What can we do to make this better? We need to permanently invite people in. We have had some medical oncologists, radiation oncologists, pathologists here, and we need to have them with us always when we're talking. Maybe we need to have more of them, or at least for them to have subgroups of their own that are ophthalmology interested to help us solve these thorny issues. We should also be really thinking hard about who else isn't in the room, whether it's which global partners aren't in the room or what other useful tools and groups aren't around. Epidemiology, for example, people with health economics background, those folks are required to help us do better and solve problems. This is from the Child Global Initiative for Cancer Registry Development. It's a WHO project. It has a short time window. I believe they started in 2018, 2019. They'll be done by 2025. But for a short while, it puts retinoblastoma front and center in many places where it wasn't visible before. People are interested and they're watching what we can do. So what I wanted to know is what's coming down the road in ocular oncology. I can think about this all by myself, but that's no fun. I'd rather have a conversation with the rest of you and learn from you. What do you want? What's coming as the biggest development or innovation? What's the highest priority to change care, and what barriers exist? And what gives you the most satisfaction? So I asked that question and people sent me answers. I asked it when you got here, not when you were at home, so it wasn't rejected. It wasn't something to put down the bottom of the pile. I asked it before we started talking, partly so I could have answers, but also so you were thinking about what your own situation was. And these are the things that people said to me in narrative format. The biggest questions: earlier diagnosis and treatment. How will immune treatment influence patient outcomes? How can we improve access and equitable access? And then here was a game changer idea, and it came up in two places: how to reach 0 deaths in primary ocular cancers. Whoever put that on the list, we want you to lead the charge, because I think we need the big question, the big thorny question, to help us make a stab at what we can do piece by piece. Somebody else said we need to make sure that our knowledge is passed to the next generation, not just the next generation of ocular oncologists, to the next generation of ophthalmic practitioners who miss things, biopsy stuff Carol doesn't want them to touch, neglect the lymphomas, don't get that something is metastatic until way too late. And then there was a request for tools that were cheaper and easier to implement. How about the next big development? Things that will come through telehealth, through AI, guidelines and standards people were asking for, and I think this is another place for the society to work, because right now it's very different in many places without necessarily having advice. What do we do with precision medicine? What do we do with robotics? And then the highest priority for patient care was a surprise to me. People thought more psychosocial support for patients throughout their journey was important. In the usuals, like institutional supports and fully integrated service. The same thing about applying innovations and scientific advances so that it gets from the presentations that we're seeing to something practical and implementable safely. I asked about barriers. They're all the usual same things. And then I asked about you. 60 people answered, and I asked where you work. So 10% of the people who answered were in low-income countries, 18% in lower middle income, 15% in upper middle income, and just over half in high income countries. We're becoming more global. We need to make sure that we support this, whether it's with travel grants or with other things, because of where the burden of disease lies. Where do you work? 83% work in the country of their birth, 90% work where they got their medical education, but only 62% work where they got their fellowship training. That means people are traveling to train. We're cross-pollinating. We need to keep that up, but we need to be mindful when we do it, what we're sending people back to. I also asked about where you work. Do you work in an eye hospital, a cancer hospital, or a full-service general hospital? Why did I ask that? Because I think it matters. I think it matters hugely what kind of resources you can attract, what sort of zeitgeist there is, what other tools there are. So Will's Eye Hospital is an eye hospital. Now it's associated with Jefferson University, but it still has within its framework the focus on eyes. If you're mostly working in a cancer hospital, you may have a very, very different mandate, other opportunities, but different challenges. So what was in my own list? There were a couple of things that I didn't see. One soul said prevention, but didn't put any kind of information with it. I think that would be my gold star goal. What can we do to prevent some of these tumors? Would HPV vaccines prevent a percentage of our OSSN? Is there something we could do that will turn down PRAME, make people less likely to have a PRAME-positive tumor? Can we influence this with environment, with medication, with diet, and with lifestyle? I would also put wellness, your wellness, and the wellness of those you work with front and center here. We heard lots about wellness and mental health during COVID, but this is a real and ongoing thing. And every time I come to a meeting, I'm blown away by the things other people do to keep themselves working and going, like the lovely yoga session we had this morning, like those of you who are runners, cyclists, and all sorts of other things. But I think this is important. It's important that we talk about it and share it, and that it's important that we be there for each other when things aren't going so well. Whether that's not going so well with your favorite ocular oncology unit, not going so well with your own health, not going so well with your family, not going so well with how society is behaving right now and the goals and the things that we can do together. Workforce planning. There's really nothing out there about that, and that may be where we need to go next. It's happening on its own when you look at how many people are trained here and working here in India who've gone away to train, and they will be training more beyond them. But maybe we could be a little more diligent and a bit more deliberate about it to create what we think of as the future instead of just replicating the present. Aging and demographics, and then climate change. This is a map of the percentage of people aged 65 and older. So you can see where the young folks are. Now, if cancer is a disease of aging and mistakes, insofar as it is that, this will be where the burden is. What about climate change? It's been all over the news. It's taken up lots of political will. COP29 just happened. It gets a lot of press. There are impacts. It will impact the environment we're working in because of finance, because of change in heat, because of change in atmospheric rivers and floods and heat domes, all of which we've had in little old Vancouver next to the mountains and the ocean. Never thought that I would see such impacts there already, and there will be more of this, impacting health, impacting infectious disease, impacting clean air and clean water. There are data points out there, but none of them specifically refer to ophthalmology. And I could find only one article, Impacts of Climate Change on Ocular Health, a scoping review. And in this scoping review, they showed the number of articles being published, where the articles were being published from, what the change variables were, and which ocular structures they were applied to. But there was the tiniest 3 lines about anything to do with oncology. It talked about TERT promoters and probably things that will be surface disease. Folks, this is wide open, and we need to claim it and recognize that it will have an effect on what we're doing. Back to our problem with the spaceship. We're in India. I turned on my phone today, and this is what's on the news. They're packing research samples to be sent back, not for them to be sent back yet, that's still 2 months away. Why is this here? Because one of the astronauts is of Indian origin. This is a live story. For those of us who remember the Kennedy space era, this was exciting stuff a long time ago with poor computers that are weaker than what we have on our cell phones. This business of how do you solve your problem, where does your spaceship come from? What do you do in the meantime? Hopefully it's one that will stimulate you to talk to each other, to think about it, and stimulate the society to maybe take action that we can all stand behind, so that ocular oncology has gone further together, up our mountain, together, everywhere. I couldn't get a picture from here from yesterday, but you get the drift. All of us together will go further. Thank you so much for the honor.
Catherine Payton, thank you so much for decades of service and leadership in the field of ocular oncology. And thank you for Mission Fulfilled. That was an awesome lecture. Thank you for being our ethical spotlight and focus and telling us where we're going to be and what we need to focus on. And on behalf of the board of the International Society of Ocular Oncology, I'd like to present you with second Jerry Shields.
I have an announcement for all the beautiful, gorgeous women here in this hall. We have the Women in Ocular Oncology lunch session, which will be in Adan. Sorry, gentlemen, we have more things coming for you as well. So this is for the beautiful, gorgeous lady at Adan, all day, all night. We have the Women in Ocular Oncology lunch session. Please join us. It's going to be very interesting panel discussion. Thank you so much. Thank you, Dr. Fairoz. For everyone else, is lunch in the foyer, and we'll reconvene back here at 2 o'clock.
beats on the track. natural beats on the track.
start our next session, papers on retinoblastoma. And for this, I invite Dr. Manoj Parulekar to chair, Dr. Vikas Menon to moderate, and I also call expert panelists, Dr. Rojana Pon and Dr. Kaliki.
Yeah, that's great.
I've become Fairuz for some time. Cannot match it.
If you make a start. Okay. Brilliant. Well, let's make a start with the afternoon session. Thank you to the moderator and the panelists, and thank you all of you for coming back in time after lunch. It's always so difficult to get away from such a decadent lunch, as well as speaking to our friends over lunch. Without further ado, I'm going to hand over to the moderator to invite the first speaker.
Okay. The first speaker for this session is Dr. Guy Negretti, and the topic is outcomes of cryotherapy for the treatment of retinoblastoma in 92 consecutive patients.
While he's ready to start, I request all speakers to sit in the front row and also alternate between the podiums. Thank you.
Good afternoon, everybody. Today I'm going to present the results of our study looking at the outcomes of cryotherapy for the treatment of retinoblastoma in 92 consecutive patients. No conflict of interest exists. So cryotherapy was first pioneered for the treatment of retinoblastoma in 1967. And we tend to use it for the treatment of small peripheral tumours, and we tend to employ a triple freeze-thaw technique. We know particularly from retinal detachment surgery that cryotherapy can cause rhegmatogenous retinal detachment if used in excess by inducing cryonecrosis. And there is worry that the same might be true in retinoblastoma, because we tend to use much higher amounts of cryotherapy than in traditional retinal detachment surgery. And the main study that gives us some indication of what the risk may be was published in 1989 by Shields. And it suggests that the risk of retinal detachment following cryotherapy for retinoblastoma is 2%, and the risk of vitreous hemorrhage is 6%. We wanted to report updated incidence data in the current era of retinoblastoma management, and also report outcome data, including visual acuity, for those patients who developed complications following cryotherapy. So we included all children treated in London for retinoblastoma between 2013 and 2022, with at least 1 year of follow-up. And we subclassified cryotherapy-related retinal detachments into 3 groups. So those with a confirmed rhegmatogenous retinal detachment, where a retinal break was clearly visible on examination. Those with a presumed rhegmatogenous retinal detachment, where a retinal break was highly suspected on indented examination but not confirmed. And then exudative retinal detachments, which we didn't analyse further. So 124 eyes of 92 patients were included, and 7 of those eyes, so 6%, went on to develop a cryotherapy-related rhegmatogenous retinal detachment. 9 eyes, or 7%, developed a vitreous hemorrhage. Of the retinal detachments, 4 spontaneously resolved, and 3 persisted. Of the vitreous hemorrhages, 4 spontaneously resolved, and 5 persisted. So of the persistent retinal detachments, we observed 1 because it was not progressing and was not threatening vision. We did barrier laser around 1 because it was very localized and was progressing. And we enucleated 1 patient, not because of a retinal detachment, but because there was concern about tumor activity. Of the persistent vitreous hemorrhages, 4 eventually were enucleated and 1 was observed. Now, the enucleations again were not because of a vitreous hemorrhage per se, but because of concern regarding tumour activity. So final visual acuity in globe-salvaged eyes that developed these complications range between 6/9.5 and 6/95. In only one case was visual acuity following the complication worse than baseline vision prior to the complication, and that was in one retinal detachment case. There was no reduction or permanent vision loss in any of the vitreous hemorrhage cases that were salvaged. So the number of cryotherapy applications did not seem to be relevant in causing retinal detachments, but it was in vitreous hemorrhage. So in those eyes that developed a vitreous hemorrhage, the mean number of cryotherapy applications was 34, whilst in those without a vitreous hemorrhage it was 14.1, which was a significant difference. This is an example of an inferior regumatogenous retinal detachment that developed following 6 cryotherapy applications on the left, beside a cryotherapy scar, and then 8 months later it had resolved spontaneously with no treatment. So in summary, we have demonstrated that there's a low incidence of persistent complications following cryotherapy, with persistent regumatogenous retinal detachment developing in around 2% of our cases, and persistent vitreous hemorrhage in around 4%. Regumatogenous retinal detachment and vitreous hemorrhage may spontaneously resolve without any active intervention, and if it does occur, it does not tend to lead to permanent vision loss. Increased number of cryotherapy applications did not increase regumatogenous retinal detachment risk, but it did increase vitreous hemorrhage risk. Thank you.
Thank you, Dr. Negretti. Next, Dr. Shields is not available right now. So next, I would like to invite Dr. Sota Oguro. She'll be talking on selective ophthalmic arterial injection. Selective ophthalmic arterial injection using a balloon catheter for retinoblastoma.
Good afternoon. I'm Sota Oguro, interventional radiologist. So there's no COI. So I'm start. Enucleation rate of retinoblastoma decreases in favor of glow salvaging techniques, including intraarterial infusion. In 1990, Kaneko and Mori from our group pioneered targeted chemotherapy in intraocular retinoblastoma using melphalan. And there are 2 different types of targeted chemotherapy. One is microballoon technique, and the other is microcatheter technique. But microballoon technique has not publicly disclosed in details. So in this presentation, the details of microballoon technique, selective ophthalmic arterial infusion, SOAI, will be explained through the video. So here's a figure of SOAI system. Microcatheter is inserted by a 4 French multi-shape 4 French catheter and 2 side ports with the check valve and a small chamber named M chamber are connected as shown. And deflection of a microcatheter can be made in M chamber like this. When saline is vigorously injected from proximal port, the microcatheter is ejected by the water flow. So here is the video. So first, check the location of internal carotid artery, ICA. Then advance the 4 French catheter into the ICA. And check the shape of the ICA on TSA. So this looks tortuous. And open the distal port and make the deflection of the microcatheter in M chamber, then close the distal port and open the proximal port. So now I'm ready. And from now, repeat vigorous injection from the proximal port. And see, here's the balloon. And repeated vigorous injection. The microballoon is ejected by the water flow. And the balloon diameter is fine-tuned, and repeat vigorous injection. Okay, but the length is a little bit shorter, so I added a bit more deflection here. Then repeat the vigorous injections. The balloon diameter is fine-tuned again, and the microballoon is pushed by water flow. Then open the proximal and distal port so that I can pull back the microcatheter to eliminate the unnecessary slack. Then close the both port. Now I can pull the entire system back while inflating the balloon. Oops. What's happening? Yeah, and I will try to occlude the flow and confirm the blocking the blood flow in the ICA distal to the ophthalmic artery on DSA. So finally, the melpram mixed with the contrast media is injected from the proximal port. Can you hear the sound? Oh, that's too small. But heart rate decreases caused by vasovagal reflux about 30 seconds. Let's get it slow. Now, right after the injection, the skin redness at the treated area also appears. After 10 minutes manual compression, the right groin was secured using step T. As a result, from the 250 cases, mean age was 19 months, including one month girl. Technical success rate was 99%. Two cases failed. One is no ophthalmic artery from ICA. The other had a too wide ICA for occlusion. Mean procedure time was very short, 18 minutes from puncture to sheath removal. And because of this short procedure time, heparin was not used. And severe adverse events was very rare. And the microcatheter technique allows direct delivery of melpram into the ophthalmic artery, but it has very high success rate, and this is a comparison. The good point of SOAI has a short injection time and short procedure time, and no wedge injection and no minimum weight. But bad things we cannot treat if the ophthalmic artery is branched from the ICA. And in some very few cases, it's very difficult. So in conclusion, the SOAI microballoon technique is disclosed in details. And please email me. I can share the video. Thank you.
Dr. Carol, next. Okay.
Can we go to Dr. Shields?
Okay. All right. So,
I see. Okay.
We move on to the next speaker, Dr. Joseph Abbott first. Dr. Joseph Abbott, please.
Okay, great. Good afternoon, everybody. So it's a great privilege to be able to contribute to this fantastic meeting. I'm going to tell you the story about intra-arterial chemotherapy in our unit and the sort of evolution which mimics many units around the world, but perhaps has one important other finding. So I have no disclosures. It's great to be able to follow on from the Japanese team who introduced this technique to the world of selective ophthalmic artery chemotherapy. I don't need to revisit that. And this audience will be very familiar with the American group that popularized the technique and refined it. For this reason, we were using the technique of catheterization of the ophthalmic artery from June 2010 when we introduced the technique in our unit. So we had a case which, around the time of publication of some of the experience of groups, particularly the Lausanne group, in 2021, explained how catheterization of the ophthalmic artery was associated with increased side effects and ocular side effects. And we had a case which sort of brought that to mind, and we changed our technique around then of a case that had profound choroidal ischemia. So our pre-modification technique, as is described in these slides, pre-mod, was cannulation of the ophthalmic artery and various other steps which are very familiar. We changed the technique in May 2021, and as discussed, the main change was that this was an occlusive, we changed from an occlusive technique to a non-occlusive technique, and the catheter tip was placed at the os but not in the os. It so happens that since that time, perhaps with increased familiarity and expertise from our interventional radiologists, all the catheterizations have been done via the internal carotid rather than alternative routes since that time. We also introduced steroids topically and systemically, and some vasoconstrictors described in the literature to the nose and skin. So did we find a reduction in toxicity like others? And perhaps more importantly for this particular talk, did we find a cost of reduced efficacy? So this was our study group. There were about 180 treatments, and there were 36 pre-modification eyes, and 23 post-mod. So we looked at toxicity from 3 different parameters, which I'll go on to, and efficacy from 2 parameters, which I'll explain. So using the Lausanne group's chorioretinal atrophy scoring, we looked at our own chorioretinal atrophy pre-modification, and this graph reflects those. So the grade 5 is obviously more severe than grade 0, and when we modified the technique, there was a great improvement in that, and actually that was statistically significant for any atrophy of any kind. Vision loss, small rates of vision loss reduced with the modification in technique, and ptosis actually increased a small amount but wasn't significant statistically speaking. And in terms of efficacy, it's quite hard to quantify this, but we've quantified this here by looking at subsequent further therapies that were required after the intra-arterial. And you'll see that in our pre-modification era, quite a lot, well, 12% or thereabouts required enucleation. And in the post-modification era, far fewer came to enucleation, but we were using more intravitreal chemotherapy, and so clearly those 2 things may not be unrelated. But this is the sort of interesting thing that we found, and was something of a surprise. I set out doing this looking to make sure that the new technique was not inferior, but in terms of globe salvage, we found that the newer technique was much improved in terms of percentage salvage, and that was statistically significant. And perhaps this was just because we were changing our indications. So if you look at the group on the right, the slide doesn't come up quite as intended, but the group on the right are the post-modification, the group on the left are the pre-modification. So as we became more and more comfortable with this technique, we were using it for more primary treatments and for lower complexity eyes. Perhaps that's a bias. But even if you break the results down, looking only at group D and group E eyes, then the salvage rate increases in both, And even if you look at secondary eyes on the bottom of the chart, that also increases in terms of salvage rate. So, in conclusion, this post-modification approach at the os rather than in the os, if you like, in our population very clearly had lower retinal toxicity in keeping with other papers. But there was no loss of efficacy. In fact, there was quite the reverse, an improved globe preservation across both the more advanced presentations and across those kids that had secondary treatment. So I hope you find that an interesting finding, and I thank you very much for your attention. And I'd just like to recognise, as discussed, retinoblastoma is a team sport, and these are my colleagues and teammates that I learn from every week. So thank you for your attention.
Next, I would like to invite Dr. Usha Singh from PGI Chandigarh.
Respected chairpersons and friends, I'll be presenting the side effects and complications of intraarterial chemotherapy in retinoblastoma eyes. There are no financial disclosures. Intraarterial chemotherapy has proven to be efficacious in retinoblastoma tumor control with potential eye and vision salvage. It has gained widespread recognition as primary treatment for group B and C eyes with globe salvage rates ranging from 95 to 100%. However, in reference to treatment complications, it is technically challenging, needs neurointerventional skills, and has a learning curve. The aim of the study was to evaluate the retinoblastoma patients treated with ISE for side effects and complications and the outcome. Medical records were reviewed from June 13 to April 24. And we had 52 eyes of 46 patients in the mean age of 22 months. It was primary in 16 eyes and secondary in 36 eyes. The overall globe salvage rate was 75%. Coming to the catheterizations, there were 128 catheterizations which were attempted, and the overall success rate was of cannulation was 93%. And there were some other, during the procedure, there were other problems like failed cannulation, difficult cannulation, ophthalmic artery stenosis and spasm, allergy to contrast. Now, literature reports that the overall success rate of cannulation have ranged from 79 to 100%. And there were some cases, 4 cases of anatomical variations. There were 13 eyes which failed the treatment and had to be enucleated. So the initial response in these tumors were good to excellent in 6 of them, and it was poor in 7, which later led to regrowths and leading to enucleation. However, in one patient, the response was excellent in 1. This patient developed regrowth after 3rd ISE and multiple new lesions in previously unaffected eye. There were other local complications like adenoviral conjunctivitis, cataract. Coming to the vascular occlusions, we had 1 CRAO, 1 BRVO, 2 BRVO, choroidal atrophy and vitreous hemorrhage. The CRAO occurred in a seeing eye, which the lesion was extramacular, and this was very distressing for us to see the vision go. And prethysical globe in 1. Although the exact mechanism of vascular event is not clear, it has been speculated to result from the fragile neovascularization of the ischemic retina or from toxicity by chemotherapeutic agents. The local side effects were lid swelling, redness, a sectoral skin erythema as seen in the clinical pic over here, 3rd nerve palsy in 2 eyes and 6th nerve palsy 1, cheek swelling in 1. Strabismus usually occurs as third or 6th nerve palsy and typically resolves within few months, which was also the case in our series. Here are some of the complications seen over here, but in our study there was no metastasis, no death, no febrile artery occlusion. Coming to the discussion, the occurrence of occlusive vasculopathy such as vessel stenosis or total occlusion following IC may be related to ischemic changes in the choroid and retina. It remains unclear whether occlusive vasculopathy results from rheological disturbances linked to ophthalmic artery catheterization or from direct drug toxicity to choroidal vasculature and or the retinal pigment epithelium. This is a recent review of all the complications reported. Whatever we have seen in our series has been reported over here. And this is the further review of analysis of all the cases. So coming to the conclusions, our findings indicate that IC is safe and effective treatment for patients with ICRB group B, C and D retinoblastoma in majority of IAC interventions. Preoperative detailed counseling, intensive post-procedural monitoring and prompt treatment are effective in minimizing morbidity innate with IAC by the virtue of its neuroinvasive nature. Anticoagulant therapy can manage most of the arterial occlusions. And at this junction, I would like to mention about a case which has not which is not a part of the study, but this has occurred very recently. The patient came back with massive lid swelling, cheek swelling, and a loss of vision in the intraarterial eye. So when we did the red cam, we didn't see any hemorrhage, but we saw massive choroidal detachment. So usually what is done at our institute, usually we keep them for 6 hours of tight bandage on the femoral artery, and we keep them under observation. And after, if they're fine, about another 2-3 hours, we let them go home. But this child went home and he didn't have any problem at that time. But the next day he came with swelling involving the entire eye. And when we did, we saw choroidal detachment and vision was very poor. So we had to give IV methylprednisolone to this child. He was 2 years old. We gave about 300 milligram over a period of 3 days and switched to oral. So this is something I would like some of the more experienced people to comment on and how to go about managing these cases. I feel they should be kept for 24 hours. Thank you.
Thank you, Dr. Usha. We'll take all the questions and comments at the end. We are going to take questions and comments at the end. So we'll have discussion at the end of the session.
We'll have discussion later.
At the end of the session. So next is Dr. Stephen R. Chen. Dr. Stephen.
Oh, he's coming.
All right. Thank you to the program committee for the invitation to come and present our findings on combining IAC and antiplatelet therapy. Here are my disclosures, and none of them are relevant. So the purpose of our animal experiment was to investigate the effects of combining intraarterial chemotherapy with aspirin and Plavix, with the eventual goal of perhaps reducing the number of ophthalmic vascular events from IAC. So there's actually been a 40-year history of IAC in the liver, and it's been frequently reported that there are vascular events or vascular changes following IAC in the liver. This group looked at all their cases between 2004 and 2010, and they found that in 38% of their patients, there were vascular changes within the hepatic arteries. This is one of their patients. You can see the severe vascular pruning within the right hepatic artery. You can see multiple stenoses as indicated by the arrows. This is another one of their patients. You can see the hepatic arteries severely diminished in size, and there are also stenoses indicated by the arrows. So they theorized that the 3 chemotherapy agents had a direct toxic effect upon the vascular endothelium within the hepatic arteries. And of those 3 agents, cisplatin is the most similar to the carboplatin we are commonly using in the retinoblastoma now. Except that cisplatin is actually much more effective, but also somewhat more toxic as well. So why don't we use intraarterial cisplatin for retinoblastoma? Well, it's known that intraarterial cisplatin has severe ocular toxicity. In this patient that received intraarterial ophthalmic infusion of cisplatin for a lacrimal tumor, You see an image on the right that there's disappearance or stenosis of the ophthalmic artery. And this patient also, unfortunately, almost immediately lost vision. In our previous experiment, we studied the pathology of a tumor-bearing rabbit model after IAC. And what we found was that of the 3 chemotherapy agents, the carboplatin had the most ocular toxicity. There was severe choroidal ischemia. There was vessel thrombosis within the carboplatin-treated eye. So as a result, on this experiment, we decided to further increase the dose of carboplatin and then tried adding aspirin Plavix to prevent that vessel thrombosis that we saw previously. So this is incidentally how we do IAC in a rabbit. So we're going up the aortic arch, selecting the carotid artery on the right. This is the external carotid angiogram in the rabbit. Over 70% of the time, the ophthalmic artery comes from the external carotid. And this is the ophthalmic artery selection, which is maybe a little more difficult than the human. And then the subsequent ophthalmic angiogram. So this is our first rabbit, our control rabbit that received neither aspirin or Plavix. And you can see the rabbit has the interesting intra-ophthalmic artery anatomy. So thus, when we infused the carboplatin got to both eyes. And you can see some reflux into the brain as well, so to the brain as well. So the pathology matched up with the vascular anatomy of the infusion. We saw a vascular toxicity within both eyes and within the brain. And we saw hemorrhage within the opposite eye and within the brain as well. The next rabbit was the rabbit that received daily aspirin. And this is that rabbit's angiogram. The fusion was just to one eye. And remarkably, after daily aspirin, the aspirin seemed to be very protective. There were no pathological alterations, no evidence of a vascular injury within the rabbit that received aspirin daily. Then we gave one of the rabbits daily Plavix, and this is that rabbit's angiogram. Then following Plavix administration, we also saw less actual vessel damage and injury. However, there was hemorrhage, both peripapillary retinal and subretinal hemorrhage within the treated eye. And finally, we tried a dual antiplatelet therapy. It's very common in our neurointerventional procedures to use both aspirin and Plavix to prevent vessel thrombosis of the stents and other devices that we use. And this is that rabbit's angiogram. And this is the pathology. So we saw edema within the optic nerve and retina of the treated eye. And strangely, we also saw a remote vitreous hemorrhage in the contralateral eye. So in conclusion, within our experiment, at least at high carboplatin doses, antiplatelet therapy seemed to be protective against vascular injury, with aspirin probably being the optimal agent, since it demonstrated less hemorrhagic toxicity compared to Plavix or Plavix and aspirin. So at least we have some animal model evidence that perhaps routine use of aspirin may improve ocular outcomes and improve the safety of carboplatin IAC and retinoblastoma. Thanks for your attention.
Next is Dr. Tatiana Ushakova.
Good afternoon, dear colleague. I am not anesthesiologist. I am ophthalmo-oncologist and head retinoblastoma management in our clinic. I express my great gratitude to the scientific committee for the opportunity to present the results of study conducted by fellow anesthesiologists of our clinic. The importance research. Progress in the field of organ-preserving treatment of retinoblastoma over the past decade has become possible thanks to the introduction of a technique of superselective intra-arterial chemotherapy. However, repeated selective intra-arterial chemotherapy procedure during catheterization of the ophthalmic artery are accompanied by cardiorespiratory disorders. Purpose of the study to analyze the effectiveness and safety of regional anesthesia techniques, retrobulbar and peribulbar blockade with 0.5% ropivacaine solution performed under ultrasound control for prevention of severe cardiorespiratory disorders and repeated procedures. 777 procedures have been performed in Blakin Cancer Research Center since 2017 to 2023. Of this, in 84 cases, 10%, pronounced severe reactions, cardiovascular respiratory disorders were noted during repeated procedures. For prevention disorders during the subsequent selective intra-arterial chemotherapy procedure, with general anesthesia, a retrobulbar block was performed in 66 patients, or peribulbar block in 14 patients under ultrasound control. The observation period in the intensive care unit is 6 hours. Observation period in the department is 1 day. Here you see ultrasound guided insertion of a needle and spreading local anesthetic. In group retrobulbar block, in 41 patients, 62% did not develop cardiorespiratory disorders. Only in 2 patients had moderate and in 23 mild disorders. In group peribulbar block, moderate disorders had in 5 patients, and in male 2. In conclusion, the use of regional blockades for severe cardiorespiratory disorders is accompanied by the decreased frequency and degree of development of respiratory disorders. Retrobulbar block is more effective and is associated with greater hemodynamic stability compared to peribulbar block. Thank you for your attention.
Thank you, Dr. Usakova. Next, may I invite Dr. M. Ashwin Reddy.
Thank you to the organising committee for the kind invitation to speak today. I'm going to be talking about the resolution of oculomotor disorders following the use of intra-arterial chemotherapy for retinoblastoma. That has been alluded to in a couple of the talks today. I'd like to thank my colleagues in London. I have no conflicts of interest. So, intra-arterial chemotherapy, we've heard a lot about this in this session. Came to London thanks to Jude Kingston, who sadly passed away a few years ago, about 2009-2010. And as Joe Abbott has mentioned, it's that balance between treatment and the complications. And one complication I'm going to talk about now is ocular motility. So we first published this in Ophthalmology in 2012. And this was a classic third nerve palsy in a patient who had intra-arterial chemotherapy. As you can see, there's ptosis, there's dilated pupil on the affected side compared to the other. The limitation of up gaze, down gaze, and adduction, but abduction is okay. So 3 directions of gaze. So interesting, the pupil was affected in this case. And can cranial nerve palsies happen with Malphalan? Yes. So you can have seventh nerve palsies, is known and recorded with treatment for head and neck tumours using Malphalan. And as has been shown in this session so far, there are cases of third and sixth nerve palsies. Most centres have seen them if they're looking for them. Taiwanese group, Ong et al. In 2015 found 3 cases out of 17, 2 being a third nerve palsy and 1 being a sixth nerve palsy. But there's no information, as we've heard also, about the onset or the resolution. Quite a lot of them are temporary and they go away after a few months, but we want to look up data for that. So there's a retrospective case series. These are refractory retinoblastoma treated between 2014 and 2020. This was what Joe would call pre-mod. So nowadays we put the catheter at the ostium. At that time we were putting it more into the ophthalmic artery. I think for this sort of assessment of nerve palsy, you really need to have orthoptic assessments before and after each injection if you really want to find out if they're happening or not. So we have an orthoptist who does this as part of our multidisciplinary team. So we had 41 patients at that time, and the age at injection was a median of 15 months. So assessing a 15-month-old toddler an eye movement is not easy, and that's why you need people who are trained to do this. And we had 7 developed cranial nerve palsies, which is 17%, but at least it gives us some numbers so that we can discuss something about the onset and the resolution. So we had 6 patients who had a third cranial nerve palsy. Interestingly, all of them were partial with pupil sparing. And we had 4 with a sixth nerve palsy and 3 that had both. So with a third nerve palsy, we had an adduction range of movement, so going in, ranging from minus 1.5 to minus 7. So minus 7 is pretty straightforward and easy to spot, but minus 1.5 is actually quite tricky in a toddler. They were all had their pupil unaffected, so were partial, and not all of them had the ptosis. Only 4 out of 6 had the superior division involvement, including ptosis. And for the sixth nerve palsy, we had an abduction deficit between minus 3 and minus 7. So when did it come on? So the median time was 5 days for the onset, so within a week of the injection. And 5 out of the 7 resolved. And of those 5, if they, in that group, they resolved at a median of 3 months, ranging from less than a month to nearly 2 years. So a median of 3 months. So we had 2 that didn't resolve. One had a nucleation at 5 months and had a cumulative dose of 37.5 milligrams. Now that patient may have resolved, but we don't know. And we have one that after 4 years still has not resolved. But that had a huge cumulative dose. We had repeated intraarterial chemotherapy being given. So that was 47.5 milligrams cumulative dose. So we've heard something about the position of the catheter, but the dose is also important. So what can we conclude? So even with low doses of Malphalan, and the lowest in this group was 8.5 milligrams, you can still get cranial nerve palsies. The median onset, as I said, is 5 days. The resolution is 3 months. Resolution seems to occur with lower doses, less than 20 milligrams of Malphalan in our very small group, and assessing with orthoptists is important. So for discussion, why is this happening? So in the cavernous sinus, you can see the third nerve is pretty close to that internal carotid artery, as is the sixth. So possibly tributaries from there are getting to these nerves and causing problems. The pupillary fibers may be quite resistant. Interestingly, we didn't find aberrant regeneration, but you see there are other nerves involved as well, the fourth and the fifth, and assessing those in small children can be difficult, but I suspect they're involved as well, just because of the position in the cavernous sinus. So I'd like to thank my colleagues in London, and as many of you know, we named our unit after Judith Kingston, who passed away while she was working with us. So thanks for your interest.
Thank you. Thank you, Dr. Ashwin. I would like to next call upon Dr. Masood Naseripur.
Good afternoon, everybody. I would like to thank organizing committee for such a constructive and well-organized meeting. So I would like to share with you the topic of targeted chemotherapy in retinoblastoma, outcome analysis based on laterality and severity of the disease. I have no financial interest to disclose. Well, we enrolled 747 eyes of 503 patients with retinoblastoma and categorized them based on the year of diagnosis, I mean before and after targeted chemotherapy, and evaluated the outcomes, patient survival and group survival based on the laterality and severity, unilateral versus bilateral, and group A and B versus group C, D, and E. Well, 1/3 of patients were in group 1 and 2/3 was in place in group 2 before and after targeted chemotherapy. Whenever we looked at the data as a whole, overall patient survival rate was more than 97%, and 11 patients, 5 in group 1 and 6 in group 2, died in advanced groups C, D, and E. However, there was no significant difference for patient survival before and after 2012. So, looking on the mortality rate in two groups, based on the laterality, showed no significant difference was evident between two groups. The same was for mortality based on the severity. There was no mortality rate in group A and B in two periods of the time. Let's look at the results for group survival. Well, group survival was improved in both advanced and non-advanced cases of group 2 compared to the group 1 significantly. However, when we looked at the subgroups, the difference was significant just in primary enucleation and unilateral cases. And as we observe here, there was somehow increase, not statistically different in secondary enucleation in unilateral group, as it's not surprising because we tried to keep more advanced cases in unilateral groups. So, how about the group survival based on the severity? Well, again, the same decrease in the primary enucleation rate was evident in advanced cases of group 2 compared to the group 1. So, in summary, introduction of intraarterial and intravitreal chemotherapy has led to significant reduction in primary enucleation in unilateral patients, as well as the primary enucleation in advanced cases. No significant difference was found in secondary enucleation based on laterality and severity, and also no significant change was evident in mortality rate in this regard. So as a conclusion, improving the treatment modalities associated with multidisciplinary approaches has resulted in these improved results during the last 2 decades in our center. Thank you.
Thank you, Dr. Masood. Next is Dr. Sonal Yadav.
Very good afternoon to all. I'm Dr. Sonal Yadav from Pune, India. So I'm going to talk about my paper on management strategy and outcomes in recurrent retinoblastoma. All right, so we all are familiar with this phenomenon. So this is a group DICRB tumor at presentation with a complete regression with a mixed picture. So it is post-standard chemotherapy, 6 cycles with thermotherapy. However, the same eye presents with the solid tumor recurrence on the calcium mount after around 6 months of regression. So recurrence of retinoblastoma tumor is one of the critical concerns in the immediate as well as intermediate post-treatment period. With the increasing amount of globe salvage treatments that we are using now, monitoring for active and recurrent disease is essential to catch them early and treat them well for eye salvage as well as survival. So this intraocular recurrent disease has been documented in retina, vitreous as well as subretinal regions. The rates of new tumor development following all types of treatment have ranged from around 6 to 45%, with the maximum being systemic chemotherapy without focal treatment. With focal treatment and systemic chemotherapy, it has been 17 to 18%, while with intraarterial chemotherapy and focal treatment, this has been around 0 to 23%. So the purpose of our study is to determine the rate of recurrence in this intraocular retinoblastoma group and review the clinical profile and management outcomes. This is a retrospective case series including 24 eyes of 20 patients with intraocular recurrent retinoblastoma. So the eyes presenting with intraocular recurrent retinoblastoma with complete chart records and follow-up available for at least 6 months post the completion of treatment of recurrence were included. Rate of recurrence, eye salvage and systemic metastasis as well as survival rate were calculated. So in total of 142 eyes of 123 patients treated with intraocular retinoblastoma at our center, 24 eyes of 20 patients had intraocular recurrent retinoblastoma, calculating this to as 16 to 9.9% of recurrence rate. The mean age of presentation being 25 months. 2 of these patients were hereditary retinoblastoma while 18 were sporadic. We had a little bit of a male preponderance with 7:3 ratio as male to female. Majority of the cases showed unilateral recurrence. However, 4 children had recurrences both of the eyes. Moving on to type of recurrence. So each eye had one or more type of these recurrent tumors. The most common was a recurrent retinal tumor, with majority of them being on the calcium mount and a few of them being on the prior flat scar. Then coming to recurrent vitreous seeds, we had spheres as well as cloud, and both in a few of the patients. And recurrent subretinal seeds, all of them in 7 patients were found in between the aura and equator region. All of the recurrent tumors were found in the mean duration from the remission of around 7 months, range being 2 to 30 months. Systemic chemotherapy, intraarterial chemotherapy, intravitreal chemotherapy with focal measures and plaque brachytherapy were used as a customized case-to-case basis algorithm for these patients for treatment. So in our group, we were able to save 13 of these eyes. That's 54% of eye salvage was achieved, and 11 of these eyes underwent secondary enucleation because of failure of salvage treatments. So at a mean follow-up of 36 months, no patients were detected with systemic metastasis, and all continued to be in remission. So to give a few examples. This was a solid tumor we saw at the start. This showed a complete regression after 3 cycles of triple drug IAC and triple thermotherapy. So another eye with solid tumor as well as witch's seed recurrence after 8 months of initial remission shows a good recurrence after systemic chemotherapy as well as intravitreal topotecan therapy. Solid tumor recurrence on a prior scar after 9 months of remission showing regression after 2 cycles of triple drug intraarterial chemotherapy. Witch's seed recurrence after 6 months of remission from prior treatment and complete regression after intravitreal topotecan. So we report a 16.9% rate of tumor recurrence in our small cohort in treating in combination of systemic chemotherapy and focal modalities. A recurrent solid tumor, witch's seeds and subretinal seeds were diagnosed at a mean interval of 7 months after initial regression. And after utilizing multimodal treatment modalities, 13 of these eyes were salvaged, that is 54% of eye salvage rate, while 11 had to undergo secondary enucleation. So thus we report 54% of eye salvage and 100% life salvage in these patients at the mean follow-up of 36 months. So when we look at the literature, so the percentages of recurrence after each and every treatment modality, as the papers discuss the efficacy of each and treatment modality has been given. However, the treatment outcomes after the treatment of these recurrent tumors has not been explicably mentioned. This review by Dr. Berry et al. Does review the recurrent retinoblastoma percentages as well as gives a broad treatment guideline for treatment of such cases. So the treatment guidelines provided kind of match with what we did in our cohort. So recurrent disease is particularly challenging for clinicians, considering the recurrent tumors and seeding may be more resistant to chemotherapy as well as radiation. And due to lack of clear guidelines, management of these recurrent retinoblastoma patients needs to be customized case-to-case basis. So systemic or intraarterial chemotherapy can help the eye salvage, while secondary enucleation still remains essential at times to reduce the risk of local spread as well as systemic metastasis. These are my references, and thank you for the opportunity and patient listening.
Thank you, Dr. Sonal. Next would be Dr. Carol Shields.
Carol's in a sari. Carol, very impressed with the attire.
Thank you. I'm moving to India. I sort of like the dress. And I'd like to thank Dr. Swati Kaliki for helping me get dressed. If my dress falls off, it's her fault. We've heard a lot of good talks. Am I plugged in and ready to go? Yeah. We've heard a lot of good talks today on the topic of intraarterial chemotherapy. We've had almost 20 years experience in over 2,000 infusions. We learned from Dr. Abbott that the technique matters. We learned from Dr. Chen that the agents matter. We learned from Dr. Reddy that the chemotherapy dose matters. And then we learned from Dr. Usha Singh that you have good news and bad news. Well, I'm going to talk to you about bad news today. We've had a lot of good cases, but I'm going to talk about, is intraarterial chemotherapy for everyone? I have no financial interest to disclose. Well, I'll just be really honest. IAC is not for everyone. Honestly, it's that simple. Every case is individualized. Our goal is to save life, save eyes, save vision, and save childhood, within reason. I mean, we've had some great cases, and so have you, such as this Group D eye treated with intraarterial chemotherapy, 2 cycles, tumor beautifully regressed, retina flat, and the child has some vision. So, I mean, with these good eyes, what are our concerns with intraarterial chemotherapy? Well, we have a few special concerns. Number 1, in germline bilateral kids, tandem IAC may not be the best way to treat these kids. That's just our personal view. We don't use tandem IAC, which is giving IAC in the same session to both eyes. We use what's called staggered IAC, to the one eye, the worse eye, first, and 20 days later to the opposite eye. Here's an example of a child who was seen elsewhere, and that can be a problem too, at a less experienced center. They gave tandem IAC to both eyes, super low dose, melphalan 2 milligrams, topotecan 0.15, which is super low, carboplatin 15 milligrams for 3 cycles. They had recurrence in both eyes, enucleated the right eye, and sent the patient with the left eye to us to save the left eye. And this is a big part of our practice. We're saving eyes following intraarterial chemotherapy elsewhere. Well, again, this is the only eye, so it's the left eye. The ophthalmic artery is sclerosed. Subretinal seeds possibly were recurrent right there. I wasn't really sure. This was the first day we saw the patient, so I waited. And sure enough, 1 month later, massive recurrence. Now I have a sclerosed ophthalmic artery, and these seeds are recurrent. So I had to have our interventional neuroradiologist go through alternative routes to give intraarterial chemotherapy, and we gave high-dose intravitreal topotecan, and we were able to salvage this eye, and this child is 2 years out doing well, but we had to be very creative with what we were going to treat this child with because we had lost so many of our easy routes to the eye. Another case treated elsewhere, tandem IAC. So this patient, this was risky for them to do the IAC. They gave subnormal dosing and the ophthalmic artery was blown. Had we seen this child from the start, we would have given intravenous chemotherapy for both eyes to start and then see which eye might need intraarterial chemotherapy. And again, as I mentioned earlier, we use a staggered approach, a 20-day interval between the 2 eyes if you need to give IAC to both eyes. It's safer, and you can give a normal dose to the right eye and then a normal dose to the left eye. We also have other concerns about IAC, like the age. We never give it, or hardly ever give it, under the age of 3 months. Well, here's a 3-month-old boy, African-American boy, retinoblastoma in the left eye, calcified intraocular mass in the left eye. But this baby is 3 months old. This baby has a risk for germline mutation, and we can't get that germline mutation testing fast enough to know whether we're going to do IAC or intravenous chemotherapy. In fact, his risk is 61% chance for having germline mutation, and that's based on this report from our department. And this is why we did this report. Likelihood of germline mutation with solitary unilateral retinoblastoma based on patient age at presentation in 482 consecutive unilateral retinoblastoma patients. 61% chance if you're 3 months or younger in age, and that's shown here in this table. So in this 3-month-old boy with a 61% chance to have germline mutation, possibly multiple tumors, possibly pinealoblastoma, are we really going to give IAC, or might we rethink this and give intravenous chemotherapy? Well, we chose intravenous chemotherapy to protect the eyes, the brain, and his life. And you can see afterwards, right eye was normal. Maybe we prevented tumors in the right eye. Left eye showed regression of the tumor with a large retinal fold centrally, and the tumor remained under control. Another concern, imaging. If the imaging suggests choroidal or optic nerve invasion, I wouldn't give intraarterial chemotherapy. I know some people say they do give it, but we don't give it. We either enucleate, that's what we do. We do enucleation, and then if we confirm it, give additional intravenous chemotherapy. So let's look at this 3-year-old boy, leukocoria right eye, large tumor in the right eye. And if we look at the MRI scan, T1 and T2, look at it closely. Big mass in the eye and little bit of irregularity to the sclera, but that's better seen on the T2. Is there optic nerve invasion or choroidal invasion in this case? Well, in this case, we were worried about that. And really, will this eye ever see with intraarterial chemotherapy? I mean, at most it's going to probably have light perception vision. So we enucleated that eye. The child had both optic nerve invasion, postlaminar, choroidal invasion, massive, and we had to give additional intravenous chemotherapy for 6 months, and at 1 year follow-up, he was okay. Had we done IAC, would we risk metastasis in this patient? I think we would. And then the technique, and this is where we have nightmares, where we see kids from other centers that might do 2 IACs a year, and the technique is really off. And Dr. Abbott talked about that. We always confirm the eye. We mark the eye with an arrow. Right eye is shown here. We mark the medication, M, melphalan, T, topotecan. We mark the dose, 5 milligrams, 1 milligram. Plus we write orders, because we don't trust that anyone's even going to look at our orders. We put it right in front of our neurosurgeon's face to know which eye to go to and what dose to give. We cover it with Tegaderm so it doesn't smear, and we use experienced neurosurgeons or interventional neuroradiologists, and we tell them don't pass the procedure ever. And then we go up, as we've seen too many blown ophthalmic arteries where they're sclerosed. When we go in, we always look into the ophthalmic artery, but we don't enter. This girl had tandem IAC. Elsewhere, after IAC, she lost all vision in both eyes. Sclerosed ophthalmic artery, she had wandering nystagmus. We would have given intravenous chemotherapy, and we had to go in with alternative routes to control both eyes in this case. Look at her OCT, no laminations. That retina is blown. So I'll finish with the cost. Santosh Hanavar has written a nice editorial in an Indian Journal of Ophthalmology last year on IAC and some concerns, especially the cost. And then Chantada wrote a nice article on IAC for retinoblastoma. We should centralize care. Every Tom, Dick, and Harry doesn't need to be doing this. He based it on this COG, Children's Oncology Group, study in the United States, where 67% feasibility of catheterization was achieved. And he said we should centralize IAC centers so that more experienced centers should be given this medication. So thank you. Those are our concerns. Tandem, we don't do. Young kids, we're careful. Imaging, look for extrascleral extension, and you need a good technique and keep the costs down. So IAC is not really for everybody. Thank you.
Thank you, Dr. Shields. As always, it was great.
Before we go further, our special guest lecturer, someone who's done a lot for China cancers, specifically retinoblastoma. She's been the guiding tool for all the stakeholders and scientists. She has a focus on retinoblastoma. She runs a Vision 2030 program through her candidates to organization for kids with cancer. So, there's a very special story we have about
Ms. Poonam Bagai. Her journey is a testament to the human spirit's capacity for resilience and transformation. Ms. Poonam's life took a dramatic turn when she battled cancer and depression in 2001. Rather than letting this experience define her, Poonam channeled her energy into waging a war against cancer. Over the past 2 decades, she has founded and nurtured Can Kids, Kids Can, a pan-India organization that has grown into a national society for change for childhood cancer in India. Today, Can Kids, Kids Can partners over 141 childhood cancer treatment centers across the nation. Her pioneering work has also led to the development of innovative, low-cost models of care emphasizing outreach, parent, and community participation. Her commitment to empowerment and collaboration has inspired a parent support group model and a childhood cancer survivors model advocating for change at all levels.
Sound, please.
Thank you very much for having me here today. Before I start,
How many people in this audience are Indian? Can you just put your hand up for a sec? Okay, great. And how many people in this audience are passionate about retinoblastoma? Can you put your hand up? Great, yeah, all of us are. So am I. So am I. Thank you. Today we're celebrating because India is fighting retinoblastoma. We've been fighting for the last decade, maybe more, and we're winning. And when I finish my talk, I've asked Rolika, we have badges, and if you feel proud like I do, please wear a badge because we are winning and we'll get there. So this is a model of multi-stakeholder collaboration over the last decade, paving the way to our 2030 goals. And I am just so happy to be here. I'm a cancer survivor, and my battle with cancer resulted in a pledge to come back to India and actually to find every child with cancer in the country. This is our goal, to have 100% access to care for children with cancer. It's a WHO mandated, UN mandated goal, 100% access to care, 100% financial protection, and at least 60% survival outcomes in children with cancer in India and other low middle income countries. So we focused a lot on access to begin with, and it was about how do we help institutions providing care. And we said, all right, we can provide you manpower, we can provide you social support, we can make sure that families that reach a center and access care in a center, they get good treatment, but can we provide them care and support? And so the focus was on access, the focus was on financial protection. But the lady there in the plane, who I flew in with on the 2nd to Goa, I met her in Berlin. We worked together, Dr. Amita Mahajan, a pediatric oncologist. And she told me about a doctor in Africa called Daniel Burkitt. And he had transformed the care of Burkitt's lymphoma in Africa. And she said, you know what, Poonam, I think we can do this one cancer at a time. We need to target certain cancers, especially retinoblastoma, because in our country, the care is just all over the place, sometimes with an ophthalmologist, sometimes with an ocular oncologist, and sometimes with a pediatrician or a pediatric oncologist who doesn't know where the child came from. Thus was born one cancer at a time, and this was our goal for retinoblastoma. But we didn't know what to do, and this was back in 2008 in Berlin, and I racked my brains and I said, we helped someone at the Center for Sight Hyderabad, and he seems to be doing really, really well with retinoblastoma outcomes. So I went to Dr. Santosh Honavar, and I said, Dr. Honavar, can you tell us how to get to a Vision 2020? And by when can we get to Vision 2020? And so I said, can you write us a roadmap? And this very busy gentleman, he was busy even back then, but he agreed to write us a monograph. And for that, ladies and gentlemen, let's give him a big round of applause. Rolika just asked me, why are you always so appreciative of him? Because he took the time to write us the roadmap. And that started us on this path of collaboration. He gave us a monograph and he said, timelines, deadlines, Gantt charts, this is what we need to do, this is what we can do together to make the difference. And that is what we have done over the last decade, working together. So what did we do? We set up a multi-stakeholder group. And in a multi-stakeholder group and collaboration, there are no leaders. We just all work together. Can Kids, my NGO, we are facilitators, we are a secretariat, we are funders, we get people together, but really our stakeholder group has no leaders. So number one lesson, there are no leaders in a multi-stakeholder group, but we collaborate and we collaborate and we collaborate. And this is what our collaboration has been. We started in 2014 and we met regularly, whether it was online, COVID, whatever it is, once a year, somehow we did a meeting somewhere in the whole country, sometimes hooked to some conference, sometimes, as I said, virtually, but we regularly had more and more centers join, more and more people join that collaboration. And I think personally that because there were no real leaders, there was nobody who actually walked away. Everybody just kept joining in. And to me, that's a big piece of it.
That network that we created today is 61 partnering centers across the country that treat retinoblastoma. It's NGOs, civil society organizations, it's patient beneficiaries, it's the All India Ophthalmology Society, the Indian Academy of Pediatrics, the Indian Pediatric Hematology Oncology Group for Research, and importantly, donors like the Sajeev Can Kids Fund. I know my time is short and I'm not going to walk through all the very many things we did, but to tell you that there were 11 things, and it started with Amita Mahajan and OCAT, it went on to Dr. Honavar and the monograph, it went on to creating a multi-stakeholder group. We created a whole network across India. We are partnering with the All India Ophthalmology Society, which is critical. Those 26,700 members are key, as are the pediatricians in the country, to get our children detected and diagnosed in time. We offered service delivery, and that's something that we as an NGO could do. When a family reaches a hospital, we provide the manpower, we provide support for timely diagnosis, we provide holistic care, we provide continuity of care, we provide education for the child, and we provide much needed manpower to our hospitals. Something where people in the West might not always understand. You have psychologists, you have child life specialists, you have counselors, you have even teachers, you have schools. But what we did was we provided that, and that ensured that families stayed within the realm of treatment, and it reduced abandonment. Then we came together and we said we will collaborate to do the country's first ever multi-center trial, research study. And the whole purpose was within the pediatric oncology space. This was one of the first in India. And this study, which we registered with the India Pediatric Hematology Oncology Group, enrolled its first patient in 2020, closed enrollment in 2023, and has an amazing 1120 patients across 21 centers. Many of the people in the room from India have participated in this. And the study that was led by Dr. Honavar, Dr. Mahajan, Dr. Seema Das, and Dr. Rachna Meel from the All India Institute actually did a lot of work to standardize care, to bring us together, to start talking about data correctly, to look at, okay, what are we looking at together? And for me personally, I don't understand the research a lot, although I do participate in research regularly. What's important is it brought us together, and then we started looking at data together, and that was important. You know, in the beginning, I remember we sent a patient from Jammu all the way to Dr. Honavar in Hyderabad down south to get that brachytherapy done. He would ask us for funding for brachytherapy because it wasn't available easily. Today, so many centers across the country do brachytherapy. So many centers, Dr. Shield, do intraarterial chemotherapy as well. But it is important. It is important to have more and more of what is available anywhere in the world, in our country as well. And then to have people within the collaboration to say, is this good? Is this bad? Do we need to take care of it? Do we need to not just blindly walk into something new? But we do have great standards of care now available across the country, not just in private centers, but in the government centers as well. Dr. Fairoz was mentioning at the Malabar Cancer Center, which is a government center, how she's been able to ensure that all the equipment that she needs is actually available for diagnosis as well as for treatment. The collaboration group did a lot of awareness work, did a lot of dissemination of health information. Across the country, every year it became a thing to really celebrate the Retinoblastoma Week. All centers, I remember in Chandigarh you do the walk at the lake every year, don't you, Dr. Singh? And different people do something, but it keeps creating the awareness in the minds of people that there is a retinoblastoma, that it is highly curable, and that we are determined to save lives, save eyes, and save vision. We've created a resource directory together which captures where are these centers. It captures what are the services available. It captures what is the financial protection available from the Government of India. And that is something we give to caregivers, to providers, so that we have the information increasingly out there in the public space.
A lot of work has gone into building capacities of health professionals, navigators, and advocates, of pathologists, radiologists. Different people have participated differently. Dr. Shields, you mentioned that the government doesn't do much. I don't know about your country, but in my country today, working with the Primary Health Center, working with the National Health Mission, doing MOUs with the state governments, has enabled us to reach the primary health center level, etc., to be able to actually create not just the awareness, but for us to be able to drive that we will be able to get our children detected in time. We worked on survivorship as well, because our survivors, and some of you met them on the 3rd, they were here, the survivors and the parents. They are a big piece of the voice, but they also need to be taken care of. Our children, once they survive, need to thrive, and it's important for us to have passport to life clinics and help them to reintegrate back into society. We have a patient advocacy group, and I'm almost at the end, and I don't know, I think I've crossed time, nobody's ringing a bell. I have another 2 minutes to share my story with you and to thank all of you. But we have a patient advocacy group, and that's important. Jyotirgamaya, which means towards the light. If we want to do multi-stakeholder collaboration work, then having the voices of the patients, and not just my story, but I'm a patient advocate, just like I stand before you today. There are a lot of young survivors who stand before audiences at different levels to be able to say that yes, India is fighting retinoblastoma and we're winning, and we need more and more people to work with us. So finally, we have had consistent and sustained funding and support for Fight RB India, and I cannot tell you how important that is in a low middle income country, because the help doesn't always, the institutions need the help at private and government centers. And a big piece of this collaboration has been to be able to ensure that as well. I want to just say a word for our regular donors, Kanika and Siddhant Sirpal, who have made this funding regularly possible. So Can Kids itself, my NGO, has spent over $800,000 in the years that we have supported and facilitated and run the secretariat for Fight RB India. And we are really excited. We are really excited because we have all achieved together. We have our access to care percentage is at 84% compared to 42% for all cancers. And that, I think, is the real power of this collaboration. So I really want to give a big round of applause to all the people who have participated, all the collaborators, all the centers who make it possible so that when we find the children, they get good treatment, care, and support. I want to congratulate you for your conference, and I want to tell you that we bank on you for the survival pieces. We can do access, we can do financial protection, which is what a civil society can do, which is what funders can do, but we need you to help us to get to that 80 or 90% survival for children with retinoblastoma in India. That's our Vision 2030. We will dialogue with international experts. We were delighted to have a panel of you with us on the 3rd, and I think we've made some good new friends this time, including ladies who worry about saris falling off but look beautiful in them, including the other lady who said, if you flatter me, it'll get you anywhere, but I hope we do research with her, Dr. Jessie Berry. And we will continue the journey towards our 2030 goal. Without the collective efforts of many, many countless stakeholders, we wouldn't be where we are today. But we are together united in the belief that every child in India and worldwide with retinoblastoma deserves life, sight, and hope. So let us honor the past, celebrate the present, and embrace the future with renewed commitment today. Thank you very much again for having me. As I said, if you are proud of where we are together as a community, Rolika has badges. I would love for you to wear the badge and say, yes, together we will win. Thank you very much for having me.
Thank you, Mrs. Bagai, for joining us, and thank you for your words of encouragement and hope. We've got a few minutes for questions before we move on to the next session. So should we start with, if anyone has any questions, can you please step up to the mic and introduce yourself and ask questions of any of the speakers in this session. While people are making their way up, can I start off by asking some questions that have appeared on the app? One of the questions was, did you start the patients on anticoagulants? We don't know who that question was addressed to, however.
No, it's not mentioned who it is addressed to, but I think.
But there were several talks on IAC,
yes.
So if anyone wants to step up and answer
Anybody
that
can
question.
answer on that, yeah.
Dr. Singh, can someone get the microphone to Dr. Singh, please? So it would be worth writing who the question is addressed to, if you don't mind, when you put it on the app. Thanks.
So all our patients after post-procedure, they are put on aspirin routinely.
For how many days, ma'am?
They're given for about a week or so, and that's it. 3 days to about 7 days, that's it.
And is it started before the surgery, couple of days before the surgery, is it started?
No, we don't start it before.
Okay, thank you. Yet another question, what type of melphalan is used for intraarterial chemotherapy? Is it Alcaran or Evomila? It's been reported that there are benefits of using Evomila, as it does not used to be used as quickly as Alcaran. So it's clearly a more stable product. I don't know.
I think this would be for Dr. Ashwin Reddy.
Ashwin, do you want to answer that? And then if Carol and Joe have comments, then we'd love to hear them. And Dr. Singh? I think Joe's there, so if you could get that microphone working.
Maybe Swati can also give us her inputs. She also has tremendous experience with intraarterial.
Oh yes, Swati, do you want to comment on that?
Is it working?
Okay, yeah. A brief comment is that we've struggled to get Evomila in the UK, or at least we have in Birmingham, while Ashwin's coming to the microphone. So I understand there are advantages with that product, but the results that I was reporting were not with Evomila.
I'm pretty sure we're using Alcaran. I don't think we're using Evomila.
So no experience from the UK with Evomila. Swati, do you have any?
So in US, we did a retrospective analysis of Evomila and regular melphalan. The efficacy was the same, but logistically the Evomila was easier, and because sometimes the regular melphalan has to be mixed multiple times, the cost was lesser with Evomila, but the efficacy was the same.
So overall the cost of Evomila is lower.
Correct.
Because there's less wastage.
Correct.
Thank you, Aparna.
What about your experience, Swati?
Yeah, we use the regular melphalan itself, and I think that has been effective, and that's what we continue.
And have you seen these oculomotor nerve palsies, third nerve palsy, and?
Yeah, I think I was surprised that the percentage was relatively high, what Ashwin presented. We haven't seen as many, really. Yes, there have been some cases where there is discoloration on the forehead and eyelid swelling, but palsies, not the percentage that at least Ashwin presented. We have seen a few, but not as many. I think they're transient, and by the time they present to us, 3 weeks later, it's already gone.
Yeah, thanks, Swati. Are they being assessed though? Who's assessing vision and eye movements?
Sorry, can you?
Who's assessing the eye movements and the vision in these toddlers?
Yeah, I think unless the parents report it when they come for the next visit, so that's what I said, if it's very transient, it resolves within a week.
It could also be subtle.
Yeah.
And very partial.
Yeah.
And that's why having someone who's assessing them.
Correct.
You can find them.
Yeah.
Because of the transient nature, but also they don't have to be the full-blown third nerve palsy. There can be just some limitation in some directions of gaze, especially if the pupil is spared.
Yeah.
So that's another element.
Yeah, agree. I think at least in our practice, it's we see the patients 3 weeks after they receive the IAC, so probably it's transient and it's resolved by then.
Carol, did you have any comments on that?
Yeah, I was just going to make a point about the Evomela, which is, we always call it sugar-coated melphalan, versus Alcoran. Alcoran lasts for like an hour, hour and a half. Evomela, like 4 hours. So when we do intravitreal injection, we really want to have Evomela. Now and we used to have to wait for them to mix it up. Now they're able to, our pharmacy, to freeze it so that we just call the pharmacy and they have the medication to us right away. But we're always really careful. We always do, if we do intravitreal injection, we always give the melphalan injection first. Now regarding IAC, they still use Alcoran, our team. But they're very careful about getting it directly from the pharmacy and without delay injecting it.
Okay, that's really useful.
Yes, I think there's an audience question, please. Yes.
Yes.
Livia?
Yes.
Just
Livia,
have one last
just
question.
one
please.
question for Ashwin Reddy. When you have palsy, do you continue the following ISC procedures?
Absolutely. So we just continue going.
Even
and
if they
so
maintain their
it might
palsy?
happen on the first injection, it might happen on the second, it might happen on the third.
Yeah, sure.
So obviously, if it's the first and second, we will continue. Because
Anyways.
the priority is controlling the tumour. As we know that most of these resolve, they're less than 20 milligrams cumulative dose.
Okay.
So
Thank you.
that's why we do that.
So now we proceed to the awards.
Right. Well, fascinating presentations. Thank you very much for all the questions and the discussions and to the discussants. It's time to present the awards. So we've been asked to rank the top 3 presentations. And so in reverse order, we've got Dr. Guy Negretti, who presented on the outcomes of cryotherapy for the treatment of retinoblastoma. Guy, would you like to come up? In second place, we have Dr. Joe Abbott, who spoke about an evaluation of intraarterial chemotherapy techniques. Does safety come at the cost of efficacy? And it probably comes as no surprise that the gold medal is Dr. Carol Shields.
I request all 3 winners to come up on stage and the panel to join for a picture too. Speakers and panelists for that wonderful session. We move on to our next retinoblastoma paper session, and for this I invite Dr. Livia Rowick as chair, Dr. Purnima Stapit as moderator, and our expert panelists Dr. Andrew Stacey, Dr. Delfitri Lutfi, and Dr. Masood Naseripur. I request all speakers to come to the front row of the hall and be seated, and also to alternate between the podiums. Thank you.
A very good afternoon. I'm Purnima from Nepal, and I will be beginning paper 9 and 4th session of retinoblastoma of today. Our chair will be Dr. Livia, and then in the expert panelists we have Dr. Andrew, Dr. Delfitri and Dr. Mansoor. I think Dr. Mansoor is not here yet. So may I call upon the first speaker, Dr. Dupe from Nigeria, to talk on retinoblastoma, achieving treatment goal with adjunctive intravitreal topotecan injection.
Thank you so much for having me. Please pardon my voice from the travel. So I'm presenting a case series of intravitreal topotecan, 14 eyes of our 11 patients. I have no conflict of interest to declare. Our story on focused retinoblastoma treatment since 2007 started with only palliative, then only enucleation, and currently we are able to do IAC and the intravitreal injections. Once we've been able to achieve the IAC, we found out that we are able to do only one in every time in any child because of cost. And so when we have vitreous seed left, we need to do something about some of these patients, and when we use intravenous therapy as well. And we know that in 2023 there was a publication from Abrahamson on usefulness of 90 microgram of topotecan in recurrent solid tumor. So we decided to try and use this in our cases, and so we evaluated treatment outcome using 90 microgram of topotecan in our patients. We had 14 eyes of 11 patients who had this as adjunct treatment. All these had seeds left after previous treatments, and the primary outcome was tumor regression or control of vitreous seeds and complication. The median age of our children was 24 months with a range of 2 to 48. All were bilateral. 6 of them already had one of the eyes enucleated before we even saw the patients. 9 had TTT previously, 3 had IAC before our injection. And the type of seed, vitreous dust was the most common type of seed we had. The classification was more of group D in about 50% of our patients. We had to use between 1 and 4 doses for us to have control of the vitreous seed. And at the point of submitting this abstract, we've only followed the children up for about 7 months. All of them had notable reduction in vitreous seeds, the group C, D, and E. We used it in one child that had a small macular tumor, in which we were trying to avoid laser and hoping that since it resolved in some solid tumor, it might resolve, but this did not work in that child. In all of these patients, none of them required enucleation, and there were no complications observed. I would like to show you this. This case was after 4 courses of intravenous VEC treatment, and we were wondering how long more are we going to go. We're not expecting much improvement. We decided to add topotecan. After 1 dose, the image on our right is what we got. Similarly, for this huge one that we had a lot of challenge managing, after 2 doses of topotecan, we were finally able to control the disease. This is the case of the macular tumor before and after the topotecan injection, in which we did not consider that there was any significant improvement. So we believe from our experience of these 14 eyes that 90 microgram of topotecan is safe, is efficacious in controlling vitreous seeds and subretinal seeds to achieve 100% globe salvage. However, it was not as effective in managing the macular tumor in the group B eye that we had, and we were able to save the eyes without any major ocular complication. This is similar to the report of Abrahamson, but he used only one dose. We have had to use between 1 and 4 in our experience, and our own follow-up is shorter. Rao et al. Had almost 2 years of follow-up in his children. We hope that when we see these children further, they continue to have control of their tumor. So we conclude by saying that 90 microgram of intravitreal topotecan is particularly important in our own society, where we may not be able to do multiple treatments, especially in those who require IAC, in which subretinal cyst sometimes just disappears, and they may require multiple doses. It's therefore a viable option, which I want us to try. We look forward to having more sample size and maybe multi-center to see what it is like on the long run. Thank you so much for listening.
Thank you, Dr. Dubey. 100% regression in even group D and E eyes is a great achievement. Next, I'm inviting Dr. Ayushi from India to talk on intravitreal melphalan versus topotecan for vitreous seeds in retinoblastoma, a study of 64 Asian Indian eyes.
A very good afternoon, one and all. I do not have any financial disclosures. We all know that the advent of targeted chemotherapy has brought in a paradigm shift in the management of vitreous seeds in retinoblastoma, with increased globe salvage rates to up to 85%. Although there have been numerous individual studies on the safety and efficacy of the two most popular agents that we use, intravitreal melphalan as well as topotecan, literature comparing these two in terms of efficacy and safety as monotherapy for vitreous seeds in retinoblastoma is limited. Therefore, we conducted a retrospective study to analyze the management outcomes following intravitreal melphalan versus topotecan for vitreous seeds in retinoblastoma in Asian Indian pigmented eyes. This was a comparative retrospective interventional series of 64 eyes which were recruited between December 2012 to December 2022 at LV Prasad Eye Institute, Hyderabad. 25 eyes were injected with intravitreal melphalan 25 micrograms and 39 eyes were injected with 30 micrograms of topotecan before and after April 2019 respectively as per the Institute's policy change. Patients with less than 3 months of follow-up or with missing documentation were excluded from the study. One additional injection was given following complete clinical resolution, which was defined as our endpoint of treatment. Primary outcome measure included treatment response, which was graded as complete, partial, or nil, globe salvage rates, systemic metastasis, and death. Secondary outcome measure was the complications, whether anterior or posterior. A p-value of less than 0.05 was considered as statistically significant. We found that both the groups were age and gender matched with similar tumor characteristics in terms of the largest basal diameter, tumor thickness, as well as the categorization of the tumor. No statistically significant difference was found between the total number of injections required for vitreous seed resolution in either of the groups. Although complete response was seen in a higher number of eyes receiving intravitreal melphalan, that is 92%, as compared to 72% in the topotecan group, the difference was not statistically significant. Globe salvage rates, metastasis, and death were comparable between both the groups. Although anterior segment complications were similar in either group, posterior segment complications were significantly higher in eyes who had received intravitreal melphalan therapy. This, for example, this is the red cam image of the left eye showing a combination of sphere and cloud-type vitreous seeds with regressed primary tumor. Following first intravitreal melphalan injection, the vitreous seeds started resolving with RPE changes seen in the periphery. There was progression of salt and pepper retinopathy noted following third and sixth intravitreal melphalan injection respectively. Complete resolution of vitreous seeds following the 7th injection of intravitreal melphalan was noted with grade 5 retinal toxicity. This is the 6.5-year follow-up image showing grade 5 retinal toxicity and best corrected visual acuity of 20 to 50. The blood vessels, as you can see here, are sclerosed with severe optic disc pallor secondary to melphalan. Sen et al. Recently analyzed 91 eyes who received intravitreal topotecan and found globe salvage rates of 85% and vitreous regression rate of 97%. Bogan et al. In their rapid xenograph model found that the salvage rates of intravitreal topotecan as well as melphalan were comparable, also seen in our cohort. Melphalan has worse side effect profile in pigmented eyes than topotecan as it binds more readily to the RPE choroid complex in pigmented eyes. Our study had few limitations. Firstly, it was retrospective. Secondly, electroretinogram was not performed for all eyes. And thirdly, visual outcomes were not assessed. Despite the above limitations, our study is unique in being one of the first studies showing a head-on comparison of outcomes between intravitreal melphalan and topotecan in Asian Indian eyes. The authors conclude that based on this study, the efficacy appears comparable with a better safety profile seen with topotecan, and therefore intravitreal topotecan should be the first line of therapy for managing refractory or recurrent vitreous seeds in pigmented eyes. Thank you for your patient listening.
Thank you, Aishi. We'll take the questions at the end of the session.
Yes, next session will be by Dr. Paula Shakewicz on safety, ocular and systemic of higher doses of intravitreal topotecan in rabbits.
Good afternoon, everybody. Thanks very much for the ISO Organizing Committee for the opportunity to be here and present our results about the safety, ocular and systemic of high doses of intravitreal topotecan in rabbits. This is an international collaboration, a study that was performed among different institutions in Argentina and the US. Here is my disclosure. So we all know that intravitreal chemotherapy is widely accepted for the management of refractory or recurrent retinoblastoma vitreoseeds, and globe salvage rates have greatly improved since its use. We have been discussing about topotecan, that it's a promising option for intravitreal injections because it has a favorable pharmacokinetics, because it is stable in solutions for injection. We have shown that it is safe in preclinical models, and actually it is also safe in patients for administering doses up to 90 micrograms. And it is very important that it's also active in preclinical models after intravitreal injections and also in patients against subretinal seeds and retinal tumors. Still, topotecan intravitreal doses should be optimized to balance efficacy and safety in difficult-to-treat retinoblastoma vitreoseeds and solid tumors. That's why we designed this study, these in vivo studies in New Zealand rabbits, to assess ocular and systemic safety of repeated intravitreal topotecan at equivalent doses higher than what it is currently used in the clinics. So in the clinics it's 90 micrograms, so we designed this study to be higher doses. But first we needed to assess whether the commercial formulation of topotecan would be soluble in lower volumes than what it is recommended by the manufacturers, so as to be able to inject the correct dose in low volumes into the rabbit's eye. So we also assessed the stability of those solutions so as not to waste anything of the commercial vial, and perhaps it could be saved for other patients or for other cycles of chemotherapy. So we had 4 groups of animals. One group was administered with 50 micrograms of topotecan in one eye, and the control of the contralateral eye was administered with vehicle. So 50 micrograms of topotecan would be equivalent to 100 micrograms in the human eye, right? Considering the proportion of the volume vitreous of the rabbits and humans. Group B was administered with 100 micrograms of topotecan. That would be 200 micrograms equivalent dose in humans, and the other group was administered with 200 micrograms of topotecan at an equivalent dose of 400 micrograms in humans. So rabbits were administered once per month, and they were followed up During this whole period of time, we performed the clinical evaluation, blood count, ERG, ophthalmic examinations, and then at the end of the study, we euthanized the animals and performed the histopathological analysis. So about the results, all the commercial solutions that we reconstituted in 4, 2, and 1 milliliter were soluble. Topotecan was soluble in all these solutions. The pH of the solutions, you can see that it is between 2.8 and 3.4, so it doesn't matter how you dilute the commercial vial. It is very acid anyway, and all the solutions were stable at 4 centigrades or stored at minus 26 centigrades until 30 days after the reconstitution, considering a concentration or a dose in the vial between 90 and 110% of the initial content. So about the safety study, all animals showed no weight, hair loss, or changes in hematologic values, as we can see here in the slide. The ophthalmic examination in all eyes treated with topotecan, vehicle, or saline, the corneal lens, vitreous, and anterior chamber remained clear without evidence of inflammation. The fundoscopy showed that animals treated with doses of 50 or 100 micrograms had no retinal or optic nerve changes. And again, I say that 100 micrograms would be a 200 micrograms equivalent dose in patients. But at 200 micrograms, that would be 400 in patients, 4 of 6 eyes treated with topotecan and 2 of 18 eyes with vehicle, we did see retinal atrophy, loss or attenuation of retinal vessels and focal loss of neural retina, as you can see in the panel that it's circled in red. About the ERG, the parameters remained unaltered after administering doses up to 100 micrograms, but after administering 200 micrograms, both A wave and B wave amplitude decreased, statistically decreased, and the histopathological findings also, we here see that it was conserved the retina thickness, no histological evidence of damage, but that was for doses up to 100 micrograms. For 200 micrograms, we did see in 4 of 6 eyes focal areas of retinal atrophy with the replacement of gliosis, as we can see here. And in one animal, we also observed optic nerve and retinal atrophy. So in the rabbit model, 3-monthly topotecan IV doses of 50 or 100 micrograms, that would be a human equivalent dose of up to 200 micrograms, showed no clinical, hematologic, histological, or fundus abnormality, but it was toxic at 200 micrograms. So it may be safe to treat relapsed refractory vitreocytes or even retinal tumors at doses more than double what it is presently used. Thank you very much.
Thank you, Dr. Paula. Next, I invite Dr. Ruzu from India to talk on dose-escalated intravitreal topotecan in retinoblastoma.
Forge your weapons in the fire of need. How? Let's figure out with this presentation on dose-escalated intravitreal topotecan. Vitreous seeds have been identified as the most common cause of treatment failure post-chemotherapy. Intravitreal injection of chemotherapeutic agent solved this problem to quite an extent. History of IVT started with melphalan given in dose of 8 microgram, but higher rate of recurrence was observed. So a shift to 50 microgram was attempted but soon discontinued because of its propensity to cause retinal toxicity. So a new balance was found between 20 to 30 microgram. Melphalan was then challenged by topotecan because of its effectivity, safety and stability for longer duration. But refractory vitreous seed was still a challenge, so a practice of combined topotecan plus melphalan injection was initiated. Also, effectivity of intravitreal topotecan at dose of 30 microgram was emphasized. However, suggestion of high dose 90 microgram opened an entire new window of hope with its use for subretinal seeds and recurrent retinal tumors. So this study was designed with a purpose of evaluating role of dose-escalated intravitreal topotecan. It was a retrospective, consecutive, non-comparative observational case series which included 31 eyes of 31 cases over a period of 35 months. However, cases receiving any form of concurrent IVC or IAC were excluded. All the cases with focal seeds in only one quadrant were given IVT in dose of 30 microgram. Seeds in 2 quadrants received 45 microgram. Seeds in 3 quadrants received 60 microgram, and highest dose of 90 was given to those with diffuse vitreous seeds or seeds in all 4 quadrants. For focal subretinal seeds, dose of 60 was given and escalation to 90 was done for diffuse subretinal seeds. Cases with less than 3 mm size small retinal tumors were given IVT in dose of 90 microgram. Following are the derived results for demographic details. Majority of cases belong to baseline group D and E with prior treatment received in form of either IVC or IAC. Most common indication for dose escalated IVT was refractory or recurrent diffuse vitreous seeds. Vitreous seeds were observed in total 27 cases in its various morphological variants. Primary dose escalation was done in 44% of cases and 56% of cases required secondary dose escalation. Interestingly, we found that with secondary dose escalation, average number of injections required was reduced to half. This case with diffuse seeds received 90 microgram IVT and laser TTT for the residual tumor and showed complete regression. This case with dense cloud of vitreous seeds completely cleared after 5 injections of topotecan. A case of refractory diffuse vitreous seed responded well to secondary dose escalation. Case with juxtapapillary seeds regressed and became amorphous. In this very interesting case of diffuse vitreous seeds, patient initially responded to 30 microgram, but later stopped responding, hence shifted to 45 microgram, but seeds again became refractory, so a highest dose escalation to 90 microgram was done. This is the regression pattern observed, and with 81% showed mixed type of regression. Of total 9 cases with subretinal seeds, all responded well with just average of 1 dose of intravitreal topotecan. In this case with small tumor recurrence, which was refractory to TTT initially, regressed completely with just 1 injection of intravitreal topotecan. Trial of IVT was also given to cases with endophytic budding type of recurrence, cases with multifocal recurrence, cases with juxtapapillary tumor recurrence or optic nerve head tumor where TTT is unfavorable showed satisfactory outcomes with complete regression in all the cases. This is the regression pattern observed, and 62% regressed with a flat scar with an average of just 1 injection. In a mean follow-up of 6 months, we noticed cataract in 2 cases and injection site cystoid cicatrix in 9 cases, which was then surgically excised, and on HPE we found inflamed fibrocollagenous tissue without any evidence of malignant cells. Till the end of the study, 21 cases remained regressed, but 10 cases showed recurrence with evidence of tumor recurrence in almost 6 cases. Out of all cases, recurrence in 90% of the cases showed vitreous seeds. Rate of recurrence derived for vitreous seed was hence the highest, 33%, and lowest for subretinal seeds, which was 0%. Out of all the cases of recurrent cases, maximum cases belong to baseline group D and 4 cases required enucleation. All the cases who underwent enucleation had a massive vitreous seed recurrence. Overall, live salvage rate was 100% and eye salvage rate was 87%. On reviewing the literature, there were only 2 similar published studies, but ours was the largest study in terms of sample size. In our study, IVT was given as a standalone treatment without any concurrent IVC or IAC. For retinal tumor, initial retinal tumor control was observed in 100% in all the series, and rate of recurrence was identical and highest for the vitreous seeds. So, despite the best of our efforts, eye which were initially unsalvageable because of resistant refractory seeds or recurrent tumor are now amenable to eye salvage by adopting a tailored approach, that is, dose escalation between 45 to 90 micron as an effective and safe modality. And lastly, refined arms are truly the savior's art. Thank you.
Thank you, Dr. Ruji. Next, I invite Dr. Yubai Shao to talk on high-dose intravitreal injection of topotecan for recurrent retinoblastoma in 13 consecutive cases.
Thank you. Good afternoon, everyone. My name is Yubai Chow from Willside Hospital. Today, I'm going to share with you our current studies about the high-dose intravitreal injection of topotecan for the recurrent retinoblastoma in 13 consecutive cases. No financial interest to disclosure. So speaking of the treatment for the retinoblastoma, the chemotherapy is still the mainstay for the treatment of retinoblastoma, including the intravenous chemotherapy, intraarterial chemotherapy, or intravitreal chemotherapy. So in literature review back to 2002, Dr. Shou published the studies, reported that the presence of the intraocular seeds was one of the most important predictor factors for the treatment failure in IVC. And in 2012, Dr. Abramson also reported that the IAC can achieve a good vitreous seeding control and eye salvage up to 90% in group D retinoblastoma. And how about intravitreal injections? Actually, intravitreal chemotherapy was firstly described in the 1960s. And previously, the melphalan is one of the most extensively used intravitreal medication to control the seedings in retinoblastoma. However, because of its toxicity, including the RPE alterations, retinovasculitis, vitreous hemorrhage, and cataract, not to say the potential risk for the male infertility, so it kind of limits the practical use of the melphalan to treat the retinoblastoma. And in some literature review, we can see that the high-dose topotecan has been proven to be safe not only in the animal studies, but also in some case report studies. So in our studies, the purpose of this study is to analyze the efficacy and safety of the high-dose topotecan in recurrent retinoblastoma. We did a retrospective cohort study, enrolled 13 eyes in 13 cases with recurrent retinoblastoma, and the primary outcome includes the tumor control, the globe salvage, and the treatment complications. And this is the baseline demographics. So the mean age is 14-month-old. The ratio of the male to female is 9:4, and 15 cases was categorized into group B, and around 23% of the cases was categorized into group C, and 62% of the cases was categorized into group D. And about the recurrence rate, recurrence type, around 78% of the cases are with Sabrina seeds, and around like 46% of the cases with vitreous seeding. 78% of the cases with Sabrina seeds. So let's take some cases as example. And this is the 4-month-old Hispanic boy with a bilateral retinoblastoma. And after standard 6-cycle of chemoreduction therapy, 5 months later, we can see in the middle of the photos, yes, we can see there's a recurrence around the primary tumor of the macula with the Sabrina seeds. So we gave the kids for 3 serial injections of high-dose topotecan with 100 microgram in 0.2 cc. We can see the Sabrina seeds was nicely regressed. Another case is a 1-year-old African-American female with bilateral RB, and the right eye had been enucleated. For the left eye, after the 4 serial injection of IAC, we can see there is still some parafoveal active tumors with suboptimal response to the IAC. So we add on 2 more injections of high-dose topotecan with 90 microgram and 100 microgram with monthly interval. We can see the parafoveal tumor was nicely regressed, and it can confirm by the OCT. And this is the result of all the 13 consecutive cases. In summary, the average follow-up period is 38 weeks, and the mean number of the injection is 3.5. It can achieve 100% of the regression rate, and the mean regression interval is 7 weeks. 0 complication, 100% globe salvage rate, and only 1 case with recurrence. And for this case, we add on 2 more high-dose intravitreal topotecan injection. It's achieved a completely regression. So this study has been published in retina in this year. So conclusion, high-dose intravitreal topotecan is an effective and promising approach for the recurrent retinoblastoma, especially with the serenus seeds and vitreous seeds. And high-dose intravitreal topotecan can serve as the supplement or an alternative to the IAC. In the future, we'll keep exploring the long-term pros and cons of the high-dose IV topotecan. I would like to acknowledge Dr. Shields and Dr. Lally for their invaluable advices and guidance. Thank you.
Thank you, Dr. Yubashal. Next, I invite Dr. Aparna to present on a phase 1 study of sustained release topotecan episcleral plaque for retinoblastoma.
Thank you very much for this opportunity. I think it sets it up nicely because we've been talking about topotecan, and we're going to talk about our preliminary results of a phase 1 study of a sustained release topotecan delivered through an episcleral plaque for retinoblastoma. These are all the co-authors. I am a consultant for Day One Biopharma that makes tovorafenib for glioma, and it is not relevant to this talk. So this episcleral topotecan contains topotecan. It comes in two formulations, either a 0.6 milligram or a 0.9 milligram. And after a conjunctival peritomy, it is glued on to the episclera and the conjunctiva is closed. The chemoplaque is placed at week 0 and then it is removed at week 6. The toxicity assessment is done till week 9 and the total follow-up is for 3 years. This study was done as 2 independent phase 1 studies, but we are clubbing the results for the analysis. In Hospital for Sick Kids Canada, the dosages 0.6, 0.9 and 1.2 milligram was tested, and at my institution, Phoenix Children's Hospital, the 1.2, 1.5 and 1.8 milligrams was tested. So both were non-randomized, unblinded. It is a phase 1 study. The primary objective is to assess the toxicity, but we are also reporting on early efficacy data. This is a swimmer plot showing all the patients, all total 41 patients, out of which from the sick kids data, patient number 4 were excluded as per parents' withdrawal from the study. And if you look at these, this diagram on the side shows all the treatments that the child has undergone. As you can see, most of these patients are recurrent retinoblastoma after either systemic chemotherapy or after intraarterial chemotherapy. There were only 3 eyes that were de novo eyes that were first treated with systemic chemotherapy. As you can see, the higher the doses, more the toxicity. So CR means complete response, and because in this study, even if we used laser or cryotherapy, that was considered as a treatment failure. So CR is only when they have received the episcleral therapy and have received no other therapy. DLT is dose-limiting toxicity, and as you can see, as the doses are higher, there is more dose-limiting toxicity. The main important dose-limiting toxicities that we see were at the 1.5 and the 1.8 milligram, and the most significant toxicity that was seen was scleral thinning in 3 patients, out of which 1 was enucleated and 2 was salvaged with an amniotic membrane graft. So we really want to concentrate on this green box, which is the recommended phase 2 dosage, which we would be investigating in our second phase of our trial, and that is the 0.9 milligram and the 1.2 milligram. So if you look at all the data, this is all the complete responses for all the different doses. If you concentrate on the 0.9 and the 1.2, both together, the response is 77% in the 40 evaluable patients. And the enucleation rate was 9%. This is a retrospective comparison with the sick kids data on IAC compared to the chemoplaque. And if you look at 3-cycle and 4-cycle IAC, the CR rate was 13 and 17%. Again, I'm emphasizing CR is when no laser or no cryo, nothing else was done. It was just isolated IAC treatment, and the percentage of enucleation was higher compared to 77% in the chemoplaque study. I want to go back to the previous slide just to emphasize that not all our patients have reached the year 3 mark. till when we will be following, so we can call our final results only after year 3. Also, serum topotecan was tested on all the patients, and in none of the patients it was at a detectable level. So there is no systemic absorption, and hence there is no drop in WBC count or neutropenia. This is the example from the Canada group. This is the de novo eye at week 0. It was a group C tumor that was treated at week 9. You can see a good response, and this child is at 3.3 years with no additional treatment needed, with a vision of 0.8 logMAR score. This is one of the patients from the Phoenix Children's cohort. This child was treated with a 1.2 milligram doses, was initially treated with intraarterial chemotherapy. The tumor responded very nicely, but then had recurrent subretinal seeds. And this is at day 0. You can see all the different subretinal seeds. At week 46, this kid showed nice responses. Now at week 150, with no additional treatment required, this kid was a CR. As you can see on the OCT, you still see a nice foveal reflex, and this child's visual acuity maintained at 20/40. This is another child. This is a child that was treated on a higher dose, 1.5 milligram, bilateral sporadic retinoblastoma. The other eye was enucleated and had multiple recurrent tumors, was treated with chemoplug, developed some recurrence that was treated with laser, developed a new peripheral tumor that was treated with cryo and has remained stable. This child is not a CR because was treated with laser and cryo but had good response. I'm going to show you one of the toxicities. This is one of our patients was treated with 1.8 milligram. The plaque was removed earlier at week 2 because had massive choroidal detachment. This child had tumor subretinal seeds and vitreous seeds. All of them responded. At week 30 had a peripheral seed that was treated with cryotherapy, is currently at week 89 doing very well, but again had toxicity because of inflammation and the plaque was removed early. So preliminary results, we are seeing no systemic toxicity. There is dose-limiting ocular toxicity at 1.5 and 1.8. We are recommending that we test the 0.9 and 1.2 in our phase 2 study that we are starting very shortly. And again, with the phase 2 studies, we'll have better tumor response and better understanding of the complications, and will hopefully give us an idea on where this would fit in our treatment options for retinoblastoma. Thank you very much for your attention.
Thank you, Dr. Aparna. Next, I call upon Dr. Duagnit to talk on visual prognosis in retinoblastoma patients with multimodality treatments.
Hello everyone, I'm Duagnit, and I would like to share with you about the visual prognosis in retinoblastoma patients with multimodality treatments. I would like to acknowledge all of my co-authors here. The purpose of our study is to evaluate factors associated with growth preservation and long-term visual outcomes according to clinical characteristics and treatment modalities in intraocular retinoblastoma patients. We are looking for the significant factor associated with growth preservation and visual prognosis corresponds to baseline characteristics of the patient. The staging, here we use ICRB, IIRC, and HACC. The anatomical involvement and the multimodal treatment, which we are using intravenous chemotherapy, IAC, intravitreal chemotherapy, and radiotherapy. This is a single-center retrospective study of retinoblastoma patients in our center during 2007 to 2020. Of 156 eyes, 32 were excluded due to extraocular retinoblastoma and incomplete medical record. We included 124 eyes of 86 patients. 57 eyes were removed, 67 eyes were preserved. We exclude 5 eyes due to loss of follow-up. The preserved eye in unilateral disease and the better eye from bilateral disease were recruited for analysis to demonstrate the best visual performance without individual bias. A total of 56 eyes were recruited for the analysis. For baseline characteristics, 44% were female, 47% were unilateral, the median age of onset was 17.5 months in unilateral disease and 6 months in bilateral disease. The median follow-up time was 63 months, ranging from 37 to 90 months. 3/4 of our patients were in advanced stage, either group DE in ICRB or IIRC, and T2A or more in HACC. For ocular features, 40% had macular involvement, 23% had optic nerve involvement, and 54% had retinal detachment. 86% were treated with systemic chemotherapy. 43% were treated with IAC, which was primary in 38% and secondary in 62%. 10% had brachytherapy and 8% had intravitreal chemotherapy. The globe salvage rate was 54%, and 50 of them had good visual acuity of 20/70 or more. 124 patients were analyzed, and the statistically significant factors related to globe removal were ICRB Group DE, IIRC Group DE, and HACC staging of T2A to T3D in univariate and multivariate analysis. Macular involvement, optic nerve involvement, and retinal detachment was a significant factor in univariate analysis. IAC was a significant protective factor for globe removal in univariate analysis, but not significant in multivariate analysis. 56 preserved eye were analyzed, and in univariate analysis, significant factors associated with good visual outcome were systemic chemotherapy and ICRB and IIRC Group A, B, C, and HACC Group T1, which IIRC had the highest statistically correlation. Significant associated factors associated with poor visual outcome were macular involvement, retinal detachment, and IAC. Visual acuity from bilateral disease with 1 or 2 eye preservation groups was statistically better than a reduced unilateral vision from globe-preserving unilateral group. 62% with bilateral retinoblastoma had good visual outcome. Systemic chemotherapy is the mainstay treatment in our study and is the only good visual outcome associated treatment. Subgroup analysis reveals a statistically significant preventive factor for globe removal and worse visual outcome for ICRB Group A to C, IIRC Group A to C, and HACC Group T1A to T1B. IAC did not show a statistically significant association with globe preservation and good visual outcome in our study. This report may be associated with low proportion of IAC treatment group. However, the overall globe salvage rate for primary IAC in our study is 85%, suggesting its efficacy in globe preservation. In terms of visual outcome, we look at our foveal-sparing tumor eyes that received IAC and found that 60% of them had poor visual outcome, which 80% of this poor visual outcome is due to choroidal atrophy, which may be related to the IAC procedure. So in our study, all recent advanced clinical stagings are independent risk factors associated with globe removal outcome. IIRC staging is the best visual results predictor, good visual outcome, especially in group IIRC, group A to C eyes. Macular involvement tumors are strongly associated with poor visual outcome, and systemic chemotherapy is a significant preventive factor for globe removal and worse visual outcome for ICRB Group A to C, IIRC Group A to C, and HACC Group T1A and T1B eyes. I would like to acknowledge my team and thank you all for your kind attention.
Thank you, Dr. Duagnet. It is my honor to invite our next speaker, Dr. Francis L. Munier. He will be talking about recurrent diagnosis and management of diffuse infiltrating retinoblastoma, and it will be followed by his much-awaited keynote lecture as well. Dr. Munier.
First of all, I would like to thank the organizing committee for allowing us to share our results regarding diffuse infiltrating retinoblastoma, and DIR for short. So it refers to a rare non-endophytic, non-exophytic growth pattern of retinoblastoma, estimated at frequency of approximately 2% after the major study of Carol Shields published in 2008, where she reviewed 32 patients from her center to characterize the disease, diagnosed in older children with a sex ratio in favor of males, characterized by an undulating thickening of the retina with no predominant mass. There is, in almost all cases, a massive vitreous disease, and in the majority of the cases, an aqueous seeding, and they were all managed by enucleation. In terms of histopathology, it's characterized by a planar horizontal growth in the ganglion cell layer with a relative preservation of the optic nerve, the outer nuclear layer. In 2019, Christina Statopoulos published this paper reporting the first successful conservative management of a DIR patient, and also she described the signature, the OCT signature of this form of growth, characterized by horizontal growth in the inner plexiform layer, and also following treatment, this extraordinary regression, type 0 regression, with a restoration, almost complete restoration of the microanatomy of the retina. Now, the study refers to it's a retrospective review of all DIR patients seen in Lausanne between 2018 and 2024, excluding patients with diffuse anterior retinoblastoma, because it's another entity. The main outcome was patient and globe survival, and we were also interested to enrich our knowledge of the phenotype of this disease using the new modern imaging tools like OCT and 50 megahertz UBM. So in this period, we have seen 354 new patients. 8 eyes were diagnosed with DIR, so approximately 2%, at a mean age of 86 months. 4 patients had bilateral disease, 2 of them with an only eye, and we also found a sex ratio in favor of males, 5 males versus 2 females. The origin of the patients are from 7 different nationalities, and we will now talk about the results. 1 eye was enucleated up front. This is this patient. He had a unilateral group E eye, presenting with a leukocoria. There was no healthy retina as we examined the fundus. And here, this is the pathology we got from Alexandre Moulin. And you see the macroscopy and a very good correlation between the macroscopy and the transverse ultrasound. Now, the microscopy, interestingly enough, we observed also a very good correlation between the UBM this time and the microscopy, with this presence of lacunae in the growth, this planar horizontal growth. This is a view of the posterior pole. The UBM picture was taken ex vivo, and you also see this, the presence of these lacunes and the preservation, the remarkable preservation of the outer nuclear layer under the growth of the tumor. So these patients, as you have noticed, has a massive choroidal invasion, so as a unique risk factor, he received 2 courses of adjuvant and is doing well. Now, we'll touch the interesting part, the conservative management. So we had 4 eyes from 3 patients with primary DIR. I'm talking here of, it's a kind of new concept, primary deer is present, deer present at first visit, at diagnosis. And we had 3 eyes from 3 patients with secondary deer. So I propose and I introduce this nomenclature. It's referring to patients where the deer was absent at diagnosis and presented during the course of conservative management. Let's review these 6 cases. So these are images of the 3 primary deer-affected patients. You see the age, between 5 and 12 years of age at diagnosis. And you see the OCT signature is present with this preservation of the outer nuclear layer. Also, there is the presence of lacunes, not in all sections, but it's there. And in the patient number 3, we had a second lesion. You can see the second lesion, which is totally distinct from the deer itself, which has an appearance of retinoma. And actually, this lesion didn't change at all after she received intraarterial. So, interestingly enough, the fellow eye of this patient, patient number 3, had also lesions in the far periphery. And having a closer look to these lesions, you can see that it's a flat lesion, quite extended with scalloped edges. And when we do UBM on these lesions, we can again see a flat lesion down to the ora serrata with the presence of these lacunas. Now let's see the secondary deer. As you can notice on the 3 fundus picture, they are patients that had already received treatment, but they recurred at the age I'm indicating on the top, and they recurred with a signature of deer, OCT signature of deer. That is the preservation, this is the scalloped edges, the preservation of the outer nuclear layer, and the presence of lacunes. So let's go back to the beginning at diagnosis of these patients. I could retrieve photos, not for patient number 5, but I could obtain photos from the very beginning in the country of origin, before they came to Lausanne. And look, patient 4 and 6, they were actually familial cases. They were diagnosed at 3 months of age with a group B, and patient 6 at 1 month of age with a group B as well. Whereas patient 5 had a single tumor in the nasal side, and then they were treated, and they stood without any relapse for several years until they arrived in Lausanne with the signature I showed you. So in terms of treatment, very briefly, the asymptomatic eye received just cryotherapy, and that's it. And all the other eyes received heavy treatment with intraarterial, a mean of 4 injections, intravitreal, a mean of 4 injections. ICC was necessary in 4 of these eyes because they had anter-segment disease, plaques, and of course all of them with focal treatment. Now, in terms of ocular survival, 6 of 7 eyes were salvaged at a mean follow-up of 24 months, and 1 eye underwent secondary enucleation due to progressive detachment of the retina, persistent disease, and see atrophy of the macula. Some emblematic cases showing the diagnosis and the progressive disappearance of the lesions, here after also plaque. And also note on this picture how invasive this process is, that there are 7 millimeters between the edge of the tumor when you first arrived, and then the tumor reached the optic nerve head. Sad, all patients are alive without metastasis, but I have a very sad news today, because after the submission of the abstract, 1 patient died. Patient number 6, who had a very aggressive disease in an only eye and developed a cryptic retrolaminar relapse. that was and then also confirmed by MRI. And you see at the time of the diagnosis of the relapse in the optic nerve, we don't see anything at the level of the ophthalmoscopy. It's just as usual, but the OCT revealed an anomaly. And this anomaly, we did an MRI in the following days, and it was confirmed, whereas there was nothing in at the level of the MRI before, confirmed the presence of retrolaminar cryptic invasion, and there was nothing we could do, and the patient died 6 weeks later. Reviewing the very first scan of the optic nerve when the patient arrived in Switzerland from Belarus, actually we can identify on the level of the optic nerve at the prelaminar portion of the nerve, there is the presence of a tissue with hyperreflective dots, meaning that there was at some time the presence of this tumor at this level, and I think it's the reason why there was at some point a growth vertical into the nerve. So what have we learned? We have extended the phenotypic spectrum of deer to less advanced forms of the disease, with the growth in the optic nerve layer and ganglion cells in all the eyes examined, with the presence of lacunae. Topographic distribution of primary deer, the epicenter is typically between the equator and the ora serrata in 5 tumors with primary form of the deer. Can be asymptomatic and discovered fortuitously. Perhaps it's related to a new retinoma form a new form of retinoma. And it can result either, in my views, either from primary or secondary transformation from a late relapsing endophytic tumor. And finally, the incidence is 2% if we include the secondary deer. If we don't include them, it's about 1%. Finally, deer can be treated conservatively with a high globe retention rate, despite the intersegment involvement in the majority of the cases. Now, the big caveat, of this study is the tropism for the optic nerve cell, optic fiber layer of this type of growth, and it's a huge caveat for us because when this tumor reaches the optic nerve head, it's really a threat for the life. And OCT, I would say, is essential to follow and monitor this disease. Without that, you cannot do that. The paper on this subject, was the paper I mentioned initially. Nathalie Cassou published one case of its patient number 2 in her study, with also a successful conservative management of deer, and now we are adding 5 more cases. I would like to acknowledge my colleagues who refer the cases, especially Erika Maka in Budapest and Professor Annette Moll in Amsterdam and Dr. Pitnoe in Rwanda. And thank you for your attention.
Dr. Munir will be continuing with this keynote lecture as well.
And we have an introductory video for him.
Dr. Francis Mounier is a luminary in the world of ocular oncology, boasting a storied career that spans over 3 decades. Following his medical studies and residency in Lausanne, he distinguished himself by obtaining board certification in both ophthalmology and medical genetics. His pursuit of excellence led him to Children's Hospitals of Los Angeles, where he honed his expertise in molecular genetics and pediatric ocular oncology. Upon his return to Lausanne, he joined the esteemed Retinoblastoma Clinic at Jules Eye Hospital and co-founded the pioneering Swiss Ocular Genetics Unit. Today, Professor Mounier's legacy extends far beyond his numerous accolades, as his tireless efforts have illuminated a brighter future for countless individuals and families affected by ocular diseases, inspiring a new generation of clinicians and researchers to follow in his footsteps.
Thank you so much. I'm deeply touched and honored to give this keynote. Thank you, really. So, as you see in the title, we know that seeding can affect 4 different compartments of the eye. We know these are other illustrations of this seeding and the class of seeding, but it can be primary or secondary, you know. But the source of the seeding is key. Is key. We know that from the very beginning, key for the treatment strategy. For the first 3 compartments, it's very clear, the seeding is coming directly from the retina. But what is the source of the seed that we see in the aqueous? Where does it come from exactly? And it's exactly about this little study that I will present with you. It's just not academic thing. To me, it's critical to always understand from where the seeding, whatever the seeding is coming. To determine the source is critical, number 1. But there are other important questions that you have to answer if it comes to treat intersegment disease with ICC. And the second is the Schlemm's canal is invaded or not? As you know, we can, with intersegment OCT, nowadays we can determine that. Is the anterior uvea involved or not? Is there an intracellular invasion, iris invasion, yes or no? And finally, and maybe this is a little bit more subtle, is there an interciliary process implantation or not? Because it's a major risk factor for relapse, even if you do everything. So we'll have time for this keynote, we'll have time only to cover the first aspect. Before going into the details, I just give a little reminder of the fundus extremicus microanatomy. What is important is, 1, is to know the exact origin of the anterior hyaloid, bridging actually the ora serrata and the Vigert's ligament on the lens. And there are, of course, variants of this anterior segment, this anterior hyaloid origin, but basically it's the ora serrata. Now, another important thing is to know that the vitreous base here in red, is as a fenestrated inner limiting membrane, and there is no anterior hyaloid there. It's interrupted. It is prolonged, but only from the ora serrata to the Vigert's ligament. Another feature of the anterior segment, extreme periphery, is the fact that the oral teeth in ciliary territory are actually ectopic retina, and this ectopic retina is devoid not only of the inner limiting membrane, as the vitreous base is, but is also devoid of the inner limiting membrane. The hyaloid and the are missing. Both are missing. Voila. It's the same observation for the retinal islands that can be present sometimes, as illustrated here. Now, okay, just also to remember that what is in front, the posterior chamber in front of the pars plana is named the Petit's canal, and what is behind the zonule, between the zonule is the Hanover canal. Now, let's review together the different routes that a cell originating from the retina takes to arrive finally in the aqueous. Alors, I will treat this by order, decreasing order of frequency. The first mechanism is a transhyaloidal transfer. You have a vitreous disease, and you have cells anchoring, usually in the inferior part of the eye. You have seeds anchoring on the hyaloid. After a while, they can just go across this hyaloid, and they are in the Petit's canal. The second by order is a transoral pathway. It implies an extreme peripheral tumor. It is, I don't know if you can see this? Yeah, it's there, the peripheral tumor. The ora serrata is here. This is the yelloid. And you have a passage, direct passage. There is no cells in the vitreous, so the passage went directly from the retina to the aqueous. The third mechanism is if the ciliary body is invaded itself. And here I have a picture, thanks to Alexandre, demonstrating this. We can see here the corpus ciliaris, actually, that is showing up in the antechamber and seeding directly, actually, in the anterior chamber, not going through the posterior chamber, directly in the antechamber. But it can also seed in the posterior chamber from the ciliary body. This is an illustration of such transciliary invasion. You have the ciliary body thickened, and you have entirely the posterior chamber, which is filled with seeds, as you can see here. Fourth pass to seed in the aqueous is a so-called supraciliary pathway, where you have a supraciliary progression of the tumor that can reach, in this case, directly the antechamber through the iris root. You see here the corpus ciliaris there is a bascule of the corpus ciliaris, which is intact, is not invaded at all, but you have the suprachoroidal space which is invaded. Finally, for the spontaneous mechanism, you have what I call the epiciliary roots, and this refers to the seeding of tumor of ectopic retina, either the iris teeth, the retinal teeth that are in the ciliary territory, or a retinal island. This explains also the mechanism responsible of anterior diffuse retinoblastoma, which is another entity than diffuse infiltrating that we touched a moment ago. Look at this picture. This was a patient under chemo, and this picture was taken by Christina. And this is a teeth that is actually the source of the location, exact location of a transformation, and was stopped by the chemo and then treated by cryo simply. Finally, there is a sixth route, but it's iatrogenic. If a patient has been operated, surgery like a vitrectomy or cataract, when you have a posterior capsulorhexis, you have a disrupted membrane and you have a direct connection with the aqueous. So in summary, because it's time, the source of aqueous seeding are multiple. It includes direct seeding from the retina into the aqueous, can be transoral or can be epiciliary, like in the diffuse anterior retinoblastoma. Or it is an indirect with from retina to aqueous with a passage through the vitreous in the transyaloidal form of progression, or via the ciliary body in the transciliary variant, supraciliary via a suprachoroid invasion, and iatrogenic, as I said. So all of this is impacting, as I told you, the therapeutic strategy. And I have no time to go into details because I didn't cover the other 3 points, but this is the kind of algorithm that you end with when you take everything into consideration, and I thank you very much for your attention.
Thank you very much, Dr. Munir. And we have come to the end of the session, and we have about 15 minutes for the question answer. First, any question from the chair or the panelist? Any questions?
No questions.
Any questions from the panelists? Yes, please.
Yes.
I have a question.
I saw it.
Yes. We hear. we hear you.
Purnima?
Yes, we have some questions posted in the app. Oh, sorry. Questions? Yeah, please go ahead first.
So a general comment and a question. The comment is intravitreous topotecan. So from the findings that were presented by several groups, it seems like a potentially very powerful tool also for low-income country settings where you don't have IAC. So we need to bear that in mind. That's the comment. And question to Aparna. Hi. Very nice presentation. So one of the cases had a choroidal detachment. I know you don't use sutures to attach the plaque, but glue it. Could it be a perforation?
No, it was not a perforation. It was from extensive inflammation. So because the chemo is coming episclerally, there was massive inflammation, and the child was treated with 3 days of oral steroids, and all the inflammation settled and the tumor regressed. But it was not from perforation. That kid's sclera was intact.
Thank you.
Yes?
Please go ahead.
Hi, Manoj Parulekar. Question for Francis. Francis, great talk as always. I could listen to you all day, every day. I had a question about the lacunae that you described. If you did not see lacunae on the OCT, would you hesitate to make a diagnosis of BIR, or in other words, are lacunae an invariable feature of diffuse infiltrative retinoblastoma in your opinion?
I'm not sure it's invariable. So we had the majority of the cases sometimes you had to look for them because they're not visible at first scan, but it's a regular finding in my experience. But it's based, on on 7 cases, right?
And is there any difference between primary and secondary DIR? Do you find lacunae more in one than the other, or are they present in both?
Alors, in the secondary, I think it was more regularly present. In the primary, we had a little issue here regarding the true initial OCT picture of primary DIR, because 2 of the 3 patients I mentioned, they had received a treatment in the country of origin before coming. And there was 1 month to 7 weeks interval between, this treatment and our observation with OCT. So, of course, maybe the treatment has, erased this feature. I don't know.
Thank you.
In the app to Dr. Munir, do diffuse retinoblastomas have different genetics to conventional endo and exophytic tumors? That's why they respond differently to treatment?
Yeah, good question. I think anyway, for sure, I think, future will tell and genetic will tell what is behind this peculiar phenotype of retinoblastoma. Now, if I take the secondary DIRs, as you notice, 2 of them were familial and 1 was sporadic. All 3 were bilateral, and all 3 we had a mutation identified, right? But nothing remarkable, it's just a regular mutation, causal mutation. Now, the key and the response will be in the cell-free or whatever, there will be an answer, but we cannot comment more at this point.
Thank you, Dr. Munir. Please go ahead.
Yeah, I have a question for Dr. Ruju. When it comes to treating eyes with diffuse 4-quadrant vitreous seeds, which was one of the subset of your study with high-dose intravitreal topotecan, how do we go about choosing a safe site for injection, especially considering that we are injecting a higher volume, so there's a higher risk of reflux, and when there's a diffuse 4-quadrant vitreous seeds, any special precautions, and do you consider doing a UVM pre-procedure to choose a site of injection?
Yeah, so in this type of cases where the seeds are diffuse, we don't go as per quadrant, but we go as per clock hour. We indent each and every clock hour for the presence of vitreous seed, and it is marked before the IVT precisely, and it is given in the same clock hour followed by double freeze-thaw cryotherapy.
Yeah, thank you.
Thank you. There's one online question for Dr. Chow. What recurrence features influence whether you choose to treat the rescue IOC versus high-dose topotecan injection? And in all those cases, intravitreal topotecan was enough, and why it is so?
Yes, I think for such kind of case, probably for high-dose topotecan probably couldn't completely replace the role of the IAC. So usually initially for some complicated cases, based on our 13 consecutive cases, initially we probably would try the IAC or IVC and to see the response. So probably 1 or 2 cycles of the IAC or IVC. If the response is not that well, we add on high-dose topotecan, like a 100 microgram in 0.2 cc. So far we didn't see any complications, so I think high-dose topotecan is a pretty safe and effective choice for the recurrent retinoblastoma. Yeah. Thank you.
Thank you. Please go ahead.
Yeah, Gary Mercado from the Philippines. Thank you, Didi, for mentioning that it might be a possible treatment in areas that we don't have IAC. Given that, is it possible to start out with 90 rather than the graded upgrade from 35, 45 to 90, instead of doing that, just going straight out to 90 micrograms, given the safety profile of topotecan? And also, one more thing is that if you have risk factors like subtotal retinal detachment, wherein we see a lot of subretinal seeding as a recurrent after intravenous chemotherapy, should you start giving some sort of like prophylactic intravitreal 90 micrograms of intravitreal chemotherapy? I don't know who to ask that.
Yes, please.
So, Francis?
So, is there anybody who can answer that from those who suggested the intravitreal chemotherapy?
I didn't understand.
Do you want to answer?
Yeah, so I'll just share our limited experience that we have. So we have currently started using 100 microgram of intravitreal topotecan in 0.1 cc. It's not that we have done too many cases. We have done only about 5 cases till now, and we are doing even the pre-intravitreal chemo ERG before injecting, and ERG every time that the child is coming for the next injection. As of now, we see that it really doesn't cause too much of retinal toxicity, but as I mentioned, it's very small series at this point. No, not really.
So I've got a question for Francis. About the anterior chamber involvement, we talked about the risk factors for systemic metastasis this morning. Could you elaborate which are the eyes that you would never preserve, or where's your limit?
I think there is an increasing body of evidence in the literature that antersegment per se is not a high-risk factor for metastasis. But I don't include in this case, invasion of the Schlemm's canal. If you have a vascular structure, whatever it is in the eye, it can be the choroid, if you have vascular structure invaded, I think you are dealing with some kind of risk. So it's why I think it's so important, and it's my limit. Presently, it's the limit we have in Lausanne. If we have, good evidence that the Schlemm's canal is not invaded based on the OCT, and in most of the cases, not in all, it's not that simple to assess, but in most of the cases we can have this security. If it's not involved, we proceed for just the intracameral with concomitant treatment as needed. Of course, if you have the interciliary process implantation or if you have the intraciliary invasion, etc., you have to add other treatments. But otherwise, we just proceed with this local treatment without giving systemic chemo if this is limited to that. Yeah.
Thank you. I'm afraid it was the last question. Because we have to announce the awards of the session. So please come to the podium, Dr. Paula Shakovic, Dr. Aparna Ramasubramanian, and Dr. Francis Munier, please.
I request the moderator and the expert panelists to join the chair and the winners for a photograph. Move on to the last scientific session of the day on retinoblastoma. For this, I request Dr. Francis Munier to chair the session. I call upon Dr. Maria Pefkianaki as moderator and our expert panelists, Dr. Carol Shields, Dr. Dan Gombos, and Dr. Vijayanand Reddy.
Let me announce now the talks and you are taking.
Yes. Oh.
And I have to announce the talks, right? Yeah,
Thank
they told me that.
My pleasure. Okay, we'll just run immediately into this session. It's my pleasure to open the retinoblastoma 5 session. And I ask you, Maria, to introduce the first speaker, please.
It's my big honor to participate in this session among some of the pioneers of retinoblastoma treatment. So the chair of this session is Dr. Francis Munier, and expert panelists Dr. Carol Shields, Dr. Dan Gombos, and Dr. Vijay Reddy. So we are starting straight away with the first talk. I'm inviting Dr. Rita Sitorus come to the stage and talk to us about radiation retinopathy following multiple combined therapy in retinoblastoma. Expensive lessons.
Thank you very much. I would like to share presentation, my experience in the topic of radiation retinopathy following multiple combined therapies in retinoblastoma and expensive lessons. So I love this statement. The bad experiences can be the best teachers, but only if you reflect on them and learn from them. On that context, I would like to share with you my bad experience that I have in managing one case with radiation retinopathy, which is as a devastating ocular complication after radiation exposure following multiple combined therapies in retinoblastoma. We know that radiation retinopathy is the chronic and progressive damage to the retinal vasculature due to injury to the endothelial cell following exposure to any type of radiation. It may result from microvascular occlusion and leaking capillaries, typically occurring several months after radiation exposure. It has been reported that clinical risk factors may be related to the development of radiation retinopathy. One is prior or concurrent chemotherapy, and also the second is size and location of irradiated area. The larger the irradiated retinal area and the more posterior location could be have higher risk of radiation retinopathy. The other thing is extrinsic factors like type of radiation, dose, fractionation schedule, and elapsed time in the course of treatment. Now I bring you with my case report. A 5-year-old boy was referred to our hospital, an RB center in Jakarta, from local district hospital Lampung. This is in other island of Java Island, with diagnosis of anosmia in left eye. The left eye was inoculated grade A at the local hospital 3 months prior to the admission, and they also give, following the inoculation, 4 cycles intravenous chemo. The child have history of leukocoria since the past 2 years. At our hospital, we found that initial fundus of RA, the only eye, revealed multifocal tumors and juxtapapillary tumor. I will show you the slide later on. And briefly, after that, we given serial focal therapy, TTT, cryo, intravitreal melphalan, 1 session EIC, and that was administered at our hospital to control the tumor on the right eye. The challenge that should be noted that this patient and the parents with irregular follow-up schedule at us in Jakarta, mostly back and forth to Lampung District Hospital due to familial reasons. This is the slide, the photo fundus at the initial examination with us in Jakarta, which you can see this on the right eye, juxtapapillaris tumor with multifocal tumors on the right eye. At that time, we give chemo reduction and TTT, 1 eye, and cryo, because melphalan and topotecan not available yet at that time. And after that, 5 months lost to follow up because they come back to the district hospital, which was gave 4 cycles additional chemo at Lampung local hospital. Several months later, they come back to us with the photo like on the right side, the tumor like still there, and we gave a TTT, the second TTT, and then they come back again to the local hospital. Again, lost to follow up, and when come back to us, they already received in total 12 cycles of intravenous chemo, and we found that the main tumor progressed. There was a new tumor inferior of the retina, vitreous and retinal cysts, since we deal with the refractory tumor. At that time, melphalan is available, then we gave intravitreal melphalan and IC melphalan. And then the patient come back, return to Lampung Hospital. The bad news after that leaving us in shock. The patient was then lost to follow-up until he returned to our hospital with a history of additional series of 5 cycles of intravenous chemo and 25 fractionated dose of radiation, EBRT, performed at the local Lampung hospital. This is the fundus, neovascularization, retinal bleeding covering part of tumor. And then weeks after that get worsened. We discussed in our retinoblastoma team in our hospital, there was a pre-retinal vitreous hemorrhage covering most quadrant and the IOP increased. Then we decided to give intravitreal ranibizumab, 0.5 milligram, but no improvement. So we decided to do inoculation. So the lesson learned, IBRT should be administered with extremely caution or be avoided in patients with IO tumor who have undergone multiple prior or concurrent chemotherapies. Routine fundus follow-up should be done by ophthalmologists. In our study, over-administration and uncontrolled chemotherapy by the local hospital, highlighting the critical of strengthening good communication between multidisciplinary experts on patient referral scheme. Thank you. Let's
Let's move on to the next speaker. I'm inviting Dr. Asin Malipatha to speak to us about enhanced MRI protocols allow for improved recognition of pathological high-risk features in retinoblastoma.
Thank you very much. I'd like to acknowledge that this work was done by Huda Ahmad Hussain, a fellow with us who's back in Saudi now, and all of the other co-authors listed there. And I thank them very much for that. I have no conflicts of interest to declare. So in a situation like this, the only way to know how much or how far the tumor has spread is by using an MRI. And this is something that's intuitive to extraocular retinoblastoma, but how about intraocular retinoblastoma? So we have always used a contrast-enhanced MRI, and for us it's critical in a preoperative assessment of eyes with retinoblastoma. We found that this could detect optic nerve invasion, choroidal invasion, scleral and extrascleral invasion in helping us stage the disease. The limits are false negatives, as we know, and from what you heard from Didi this morning, the limits also are those in low resource settings where they don't have access, or even limited availability in some situations where sometimes the MRI schedule will only be available after the onset of treatment. Technology is improving, and you have higher magnetic strengths that are used from 3 Tesla to 7 Tesla. Radio frequency coils were discussed as well earlier today, with head coils and surface coils that could be used. Fat suppression is almost essential in some of our protocols, and thin slice thickness is also important as well. If we use these protocols, then the sensitivity of detection of the anatomical and histological features is much higher. So our aim here was to examine morphological features of high-risk pathology in eyes that have undergone primary enucleation and compare those histological patterns with radiological features that are visible in corresponding staging MRIs. This is a single-center retrospective study with where the MRI was done before primary enucleation, and we excluded those with unavailable histopathology slides or a poorer quality of MRI images. All MRIs and histopathology slides were reviewed by 2 independent observers each, that is 2 radiologists and a pathologist and 2 people reviewing the pathology slides. High-risk pathology was identified according to the 8th edition of the AJCC, therefore PT3 and PT4. And just a note to everyone that this does not include patients with concomitant focal choroidal invasion with pre- or intralaminar optic nerve invasion, which used to be considered a high-risk feature, but not after what Dr. Chavez Barrios has presented in the past few years. 88 eyes were eligible for analysis, of which most were group D, and the high-risk pathology was differentiated into a T3A in 8, T3B in 7, and PT4 in 2 of them, which means that the surgical margin was involved. So the high-risk features overall, if you look at the numbers of true positives and false negatives, you have 12 true positives and 7 false negatives, and 7 false positives as well. Sorry, 4 false positives as well. And if you look at choroidal invasion alone, you have 3 false positives, and more importantly, you have 4 false negatives. And if you look at post-laminar optic nerve invasion, we'd have 1 of those as a false positive and 4 false negatives. And with extrascleral invasion, there was 1 false negative in those that we examined. For scleral invasion, we also had 2 false positives and 1 false negative in that series. And if you look at the accuracy here, we had an overall accuracy of about 88% and a sensitivity of about 63%. But if you break it down, you would see the accuracy being 94% for post-laminar optic nerve invasion, 92% for choroidal invasion, 97% for scleral invasion, and 99% for extrascleral invasion. Of note is that the sensitivity is about 50 to 70% based on what feature you're looking at, but the negative predictive value ranges all the way from 90% to 90% overall to 95% to 99% in some of these. And these are some case examples from that. So this is a contrast-enhanced MRI again, and there you can see that there is a fusiform swelling there of the choroid, and that correlated well with the histopathology. And another one here where you had this sort of an enhancement, which is an omega enhancement of sorts, which correlated well with histopathology. But to really know which of these features would predict that MRI can see, the true positives there were usually those that had focal massive fusiform or omega-shaped thickenings, or a single extensive infiltration without choroidal thickening, and the false negatives were multiple cumulative focal infiltration without choroidal thickening and full thickness involvement without choroidal thickening. And my second conclusion there is that when you look at intraocular RV staging, an MRI usually improves its diagnosis. And if you look at how staging has gone in the recent past, with the use of MRI in 2025, I think MRI should be an essential part of staging going forward. Thank you very much.
Thank you, Dr. Asen. We continue now with Dr. Delstiri Lufti. She will speak to us about the impact of histopathological result on survival rate in retinoblastoma patients at the Sari Referral Center Hospital in East Indonesia.
Good afternoon, everybody. I am Delfitri from Surabaya, Indonesia. So I would like to share about our research. Maybe this is a simple research compared to you guys, but this is our first research in the hospital. So this is my hospital, Dr. Sutomo General Academic Hospital. So this is the impact of histopathological result on survival rate in retinoblastoma patient at our hospital. So as we know that the mortality rate of retinoblastoma is significantly low and in middle and low income countries such as Indonesia, and survival rates usually are over 95% in high income countries. And the survival rates and factor contributing to RB survival, all of them is particularly because the relationship with the histopathological features. So this study is aimed to analyze the survival rates in children with retinoblastoma and determine the impact of histopathological result on survival rate. This is a retrospective study with new patient diagnosed with retinoblastoma from 2016 until 2018, and all patients with histopathological confirmed retinoblastoma are included in this study, and we follow up the patient for 1 year and 2 years. For the result age, we got like 45 children with 36 unilateral case and 9 bilateral retinoblastoma. The mean age at diagnosis is 21 months, with unilateral case in 22 months and bilateral case in 17 months. For the unilateral case, we got like intraocular case in 31% case, and in orbital RB is 48.9%. And in bilateral case, we got like 11% intraocular, and combination intraocular and orbital in 8.9%. And this is actually almost the same with our past publication in 2013. Mostly is unilateral and bilateral is less, and also, but the amount is different. For the treatment modality in our case, we done like 60% enucleation for primary and secondary enucleation after the chemo adjuvant, and we did like exenteration in chemotherapy in 38% patient, and one patient in 2% is have exenteration, chemotherapy and radiotherapy. As we know that therapeutic modalities in developing countries are limited to surgical treatment, radiation and systemic chemotherapy. And our patient mostly presenting with extraocular metastases. So the goal of the therapy is to preserve life. It's unlike in developed countries. For the histopathology examination, we still using the poor differentiated. So we have like 71% and we got like 29% well differentiation. In poor differentiation, retinoblastoma, we got like 27 in unilateral case, 5 in intraocular and 22 in orbital RB. So all of unilateral orbital RB is poor differentiation. And we got like in bilateral like 6 with poor differentiated retinoblastoma. And in well differentiated retinoblastoma, we get all of them intraocular. So this is the survival rate that we got after 1 year. For the cumulative, we got like 77% survive, and in 2 years we got like 42.2% survive. In well differentiated patient, we got like 100 survive in 1 year, and 78.9% survive after 2 years. In poor differentiated patient, we got like 68.8% survive in 1 year, and only 28.1% survive after 2 years. Well, I don't know after 5 years. So we got like a statistical analysis, and the histopathological is actually significant affect the survival rate. In our case, the poor differentiation give like 54.3% higher likelihood of death compared to well differentiation. So for the conclusion, in our study, the poor differentiated tumor likely have a lower survival rate than well differentiation tumors. And actually, additional indicators such as high risk factors must be investigated in this case to give a better correlation between the histopathological examination and also survival rate. So the clinical implication in our study is, as we know that poor differentiation retinoblastoma has a low survival rate and is valuable predictor for prognosis. Of course, we have to do like deepen like high risk factor, and a poor differentiated also indicates it's the delayed diagnosis that has a significant impact of progression. So, but don't worry, this is like the first survival research in our hospital, so we did like the next one right now, and you can see that this is actually one of our cases that have like chemo neoadjuvant, and nowadays we perform less exenteration. So thank you for your kind listening.
Thank you, Dr. Delfiri. We'll continue now with Dr. Farnaz Yazir, who will speak to us about the correlation of histopathological risk factors and the role of adjuvant therapy in secondary enucleation for retinoblastoma.
Hi, hello, and a very good evening to all. I'm Dr. Farnaz Yazir, Fellow in Ocular Oncology, and I'll be talking on correlation of histopathological risk factors and the role of adjuvant chemotherapy in secondary enucleation for retinoblastoma. So what are the high-risk factors? How do we evaluate? What is the significance? And how do we manage the questions to be answered? The purpose of the study was to correlate the histopathological and clinical risk factors and to assess the role of adjuvant chemotherapy and thereby life salvage post-secondary enucleation in retinoblastoma. So we know that group E retinoblastoma is a spectrum, right? With certain cases responding very well to neoadjuvant chemotherapy and the rest being refractory and requiring secondary enucleation. But what about metastasis and life salvage? Thus, among the 406 eyes undergoing secondary enucleation, cases with baseline clinical risk factors and histopathological risk factors were retrospectively identified and the life salvage rates were estimated. To brief quickly about the risk factors, the clinical ones being extraocular spread, sterile orbital inflammation, buophthalmos, anterior chamber seeds, pseudohypopyon, hyphema, neovascular glaucoma, and the histopathological risk factors being the infiltration of iris, ciliary body, anterior chamber and vortex veins, massive choroidal invasion, scleral and extrascleral invasion, retrolaminar optic nerve and transected end of optic nerve involvement as well. On clinical evaluation, we identify if the clinical high-risk factors are present or absent, and if present, baseline metastatic evaluation and neuroimaging was done in all the patients and they were treated with 6 cycles of neoadjuvant chemotherapy. After completion, neuroimaging was repeated. On the other hand, all the patients with no clinical risk factors were managed by chemoreduction with focal therapy as appropriate. On histopathological evaluation, we identified if the risk factors are present or absent. If present, repeat metastatic evaluation was done and they were treated with adjuvant chemotherapy for 6 cycles along with external beam radiation therapy if there was extraocular spread or scleral invasion. If histopathological risk factors were negative, regular follow-up was just continued for the other eye. So out of 406 cases, clinical risk factors were present in 243, that is 60%, and these were the clinical risk factors on your screen, predominantly neovascular glaucoma and anterior chamber seeds. Histopathological evaluation revealed that the risk factors were present in 122 cases, which is 30%, and these were the histopathological risk factors, majority being massive choroidal invasion and ciliary body infiltration. All right, so out of 243 patients, horizontally first, with clinical risk factors, 91 patients had histopathological risk factors and 152 did not have. Out of 163 patients without baseline clinical risk factors, 31 still had histopathological risk factors and 132 did not have. Moving vertically, out of 122 patients who had histopathological risk factors, 91 had clinical risk factors, whereas 31 did not have. So the correlation between clinical and histopathological risk factors was significant. Let me simplify this for you and also re-emphasize by including only the patients with clinical and histopathological risk factors. Among the 243 patients with baseline clinical risk factors, 91 eventually had histopathological risk factors, which makes it 37%. Among the 122 patients with histopathological risk factors, retrospectively, 91 had clinical risk factors, which is 76%. So, presence of a clinical risk factor predicts the possibility of a histopathological risk factor, and hold that thought till the end. For the life salvage, in patients with histopathological risk factors after adjuvant chemotherapy, it was 96% and of course 100% in cases with no histopathological risk factors. And the overall life salvage rate was 99%. So all the 122 patients with histopathological risk factors were treated with adjuvant chemotherapy for 6 cycles. 10 cases required external beam radiation therapy. With this, a life salvage of 96% was possible. Earlier published literature also emphasized the importance of adjuvant chemotherapy in reducing the risk of metastasis in patients with histopathological risk factors post-primary enucleation, and it was brought down to just 4% from 24%. According to the COG study, the 2-year event-free survival for patients with histopathological risk factors after adjuvant chemotherapy was 96% as well. So on reviewing the previously published similar studies, we found that our study had the largest sample size, choroidal invasion being the most common histopathological risk factor seen in almost all the case series. Neoadjuvant and adjuvant chemotherapy can significantly improve life salvage rates. So to conclude, the presence of clinical risk factors predicts the possible histopathological risk factor. Despite neoadjuvant chemotherapy, a significant number of patients may have histopathological risk factors on secondary enucleation. Still, adjuvant chemotherapy is advocated, and with this, excellent life salvage can be achieved. Early recognition and management of clinical risk factors and accurate identification of histopathological risk factors can optimize life salvage with adjuvant chemotherapy. So these are my references, and I would like to thank my mentor, Dr. Hunavar, for the opportunity, our medical oncology team, and our entire retinoblastoma team back at our hospital. Thank you for your patient listening. We are fighting RB, and yes, we are winning. Thanks a lot.
Thank you, Dr. Farnaz. We continue now with Dr. Ferouz, who will speak to us about primary orbital retinoblastoma outcome of intensive multimodal treatment protocol. Dr. Ferouz.
Hi everyone, I'm extremely pleased to present this research work on behalf of my team here regarding the outcome of intensive multimodal treatment protocol in primary orbital retinoblastoma. I have no financial disclosures, and I'm extremely grateful to the entire village who's part of treating these retinoblastoma patients in our practice. What is the purpose of the study is the purpose in my life. And I think everyone in this hall resonates with the same, where we are all in a vision and journey to save more life and reduce the mortality with love and compassion. Especially in advanced retinoblastoma, where the tumor has extended beyond the confines of the eyeball, extraocular retinoblastoma or orbital retinoblastoma has a dismal prognosis. Now, when we talk about advanced disease, it's due to late diagnosis. It could also be due to inadvertent intraocular surgeries leading to extraocular extension of disease. Most common clinical presentation is proptosis, fungating mass, or phthisis bulbi, but it can be a tip of the iceberg as well. This was a child who doesn't have a proptosis, total cataract, but when you look at the imaging, there is an intraocular mass extending into the optic nerve and with intracranial extension. Thanks to Didi and team and the Global Retinoblastoma Study Group, who has given us a lot of insights. Now, according to them, the advanced retinoblastoma, like orbital retinoblastoma, is more in the low income and the low middle income countries, which from high income, it is extremely more, which is 43%. Now, going on to the global burden of orbital retinoblastoma, this is a study from Ethiopia, where they report 54% of patients presenting with orbital retinoblastoma. Indian burden, thanks to Dr. Swati, who presented and who published 9% from India. So let us take a range of 6% to 55% in the low-income countries with orbital retinoblastoma. And indeed, it is a big challenge. So basically, our purpose was to report the intensive multimodal treatment protocol in orbital retinoblastoma, and it was in retrospective analysis of a prospective non-randomized interventional case series who had primary orbital retinoblastoma over 2 decades. The sample size was 47 eyes of 47 patients. Now, what is the need of intensive multimodal treatment protocol? The conventional treatment, we have all seen, the mortality is almost 100% with exenteration alone, radiotherapy alone, or a combination of chemotherapy and radiotherapy. Now, why intensive multimodal? Another question, because we have seen in breast carcinoma, in small cell carcinoma, and renal cell carcinoma, the effect of intensive multimodal and combination of treatment has given better results. And that's why the study, the inclusion criteria was all patients with clinical and radiologically evidence of orbital invasion of retinoblastoma with a minimum follow-up of 12 months. We excluded all patients who had systemic metastasis at the time of presentation, and the outcome measures was metastasis and death. Now, we included primary from the Dr. Hunawa's classification, the CT4 from the TNMH classification, and stage 3 Shantada staging. Our major concern was definitely life salvage in these patients. Many patients were dying because of extraocular extension. So chemoreduction, and after chemoreduction, we needed complete surgical clearance, which is just not possible with enucleation. So we treat the microscopic surgical residual and then prevent systemic metastasis. And this was definitely our aim. So we started with high-dose chemotherapy, 3 to 6 cycles, with evidence of complete radiological regression of the orbital component, and then we go for enucleation, which of course doesn't give you a complete surgical clearance, then external beam radiotherapy and 12 cycles of high dose, which is escalated dose of VEC protocol. This is pre-treatment, post-treatment, phthisis bulbi, this is when we enucleate. So of the 366 patients in a collaborative institute study, 64 patients had primary orbital retinoblastoma, 47 patients were included, and the age, the median age was 31 months, and the most common presenting feature was proptosis followed by orbital cellulitis, and the follow-up median was 63 months. Optic nerve extension was present in 12 patients, and T4A, 12, and T4B, N0, M0, 35. The chemotherapy mean cycles was 9.7 cycles, and surgery, all eyes were enucleated, and EBRT dose was 4,000 to 4,500 centigrade. Pre-treatment, post-enucleation, plus radiotherapy, where the child definitely looks happy. Results, so on your Left you can see Dr. Santosh Unava's first case, which responded to the intensive multimodal treatment protocol. And the other case is very interesting, where he didn't have a proptosis or orbital extension, but yes, extensive optic nerve extension up to the apex, which completely regressed with 9 cycles and further enucleated and given customized ocular prosthesis. This is my first patient, pre-treatment, post-treatment, and she's doing perfectly well after 7 years follow-up. So we did present our study, which included all the orbital retinoblastoma, just not primary retinoblastoma, and we got 90% survival, and this was presented way back in 2014. And then we extended and segmented our study only to primary orbital retinoblastoma, and we found 95% 10-year survival according to the survival curve in primary orbital retinoblastoma, where all the patient underwent enucleation. There was no exenteration. Metastasis happened in 2, and I have to highlight these 2 patients who had metastasis had optic nerve extension. So to conclude, survival in patients with orbital retinoblastoma definitely improves with intensive multimodal treatment protocol, and this is going to be useful to those of us who come from the low income and the low middle income countries. So what we do is chemo reduce to emphasize, confirm, reduction, enucleate, radiate, and chemotherapy. I do have a proposal here to modify the CTNMH classification, because optic nerve extension is T4A and orbital extension is T4B, but I think in our study we had proven that optic nerve extension is more lethal as far as mortality is concerned in orbital retinoblastoma. Thank you. We are all in this journey to save life. Thank you so much for your patient listening. Thank you.
Thank you, Dr. Ferouz. We continue now with Dr. Annette Moll, a follow-up of cystic pineal glands in retinoblastoma patients that does not increase detection of pineal trilateral retinoblastoma.
Thank you very much, Maria. I'd like to tell you about the follow-up of cystic pineal glands in retinoblastoma patients does not increase detection of pineal trilateral retinoblastoma. I have no disclosures. At least 40% are heritable retinoblastoma, and as you know, 60% are non-heritable retinoblastoma. And children with heritable retinoblastoma have an incidence of 3.5% developing trilateral retinoblastoma. The trilateral retinoblastoma tumors, 70 to 75 is in the pineal gland, and 25 to 30% is paracellular or supracellular space. And heritable plus trilateral is trilateral. Why is this significant? Retinoblastoma patients without trilateral retinoblastoma has a 5-year survival rate of up to 97–99% in high-income countries. But pineal trilateral retinoblastoma patients have a 5-year survival change of 44%. Survival of trilateral patients is strongly dependent on early detection of the tumor and its size. In the existing literature, the ideal screening interval for trilateral detection in retinoblastoma patients remain unclear, and several studies suggest that early-stage spinal trilateral often have a cystic appearance. Thus the current study purpose was to determine whether regular MRI follow-up of the cystic pineal glands in RB patients helps in effectively detecting pineal trilateral retinoblastoma. This is a prospective multi-center cohort study, patients from 2012 to 2022, and with a follow-up to 2023. In each participating center, the neuroradiologist of that center individually classified the pineal gland on both the baseline and, if applicable, on the follow-up scans in one of the following categories: a normal pineal gland, a cystic pineal gland, a suspicious pineal gland, and you can see in this slide how it looks like, irregular thickening of the cystic wall, fine nodular aspect, and a size exceeding pre-detected limits, and pineal trilateral retinoblastoma. At the baseline MRI, all patients underwent an initial MRI to categorize the pineal gland as normal, cystic, or trilateral. And when it was normal, no follow-up was needed. When it was cystic, A follow-up MRI at 3 months was recommended for category B and C. And if it was stable after 3 months, no further MRI follow-up scan was necessary. And additionally, the incidence of the non-pineal trilateral was also reported. This is how it looks like on the MRI. A normal pineal gland, a cystic pineal gland, suspicious cystic pineal gland, the pineal trilateral retinoblastoma and the non-pineal trilateral retinoblastoma. We have 607 retinoblastoma patients, 220 had a normal solid pineal gland, 366 had a cystic pineal gland, and 21 had a suspicious pineal gland. 9 trilateral retinoblastoma patients were found in the study, and the mean time from the baseline MRI to diagnosis of trilateral was 12 months. So 4 pineal trilateral and 5 non-pineal trilateral. Of the 4 pineal trilateral, 2 had normal pineal glands at baseline. 1 patient had a partly cystic pineal gland, and 1 pineal trilateral patient had a suspicious cystic pineal gland. The time between baseline MRI and the pineal trilateral diagnosis was 3 months. In only 1 of the 4 patients, the pineal trilateral was identified during a 3-month follow-up MRI per protocol. There were 5 non-pineal trilateral. Among the 5 patients who developed a non-pineal, 4 were identified during the baseline scan. So in the beginning, diagnosis of the eyes. And for 1 patient, the non-pineal trilateral was identified after 9 months. The detection efficiency was 494 follow-up MRI scans were required to detect 1 case of pineal trilateral retinoblastoma. And when we focused on follow-up, when focusing on suspicious MRI features, only 22 scans were needed to detect 1 case of trilateral RB. Many non-pineal trilateral cases were detected at the baseline MRI, and few additional trilateral cases were detected in extended follow-up after the baseline MRI. And the 5-year survival rate in 9 trilateral patients had a 5-year survival of 22%. The non-trilateral patient had survival of 99.1%. The pros is a comprehensive study. We have a high specificity and we have some insightful findings. And the cons are the low sensitivity, the high research use, requirement of 494 MRI scans to detect a single case point to significant research use and potential overscreening. And we also have a limited detection of time. And I think important patients with unsuspicious specific cystic gland should not be followed up. And based on MRI screening was able to detect most non-pineal trilateral retinoblastoma. And many thanks to the co-authors, especially Christian de Bloemen, the first author, and the whole ERIC group, that are the radiologists from Europe. And thank you very much for your attention.
Thank you, Annette. We continue now with Dr. Livia Lubroso, Urethral Retinoblastoma Group Survey on Mortality at Retinoblastoma Centers in Europe between 2012 and 2022, Part 1, Metastatic Disease from Retinoblastoma.
Good afternoon, everyone. And before I start, I wanted to thank all the organizing committee for their hard work setting up this outstanding meeting. So it is my pleasure to present here the results of a collaborative work conducted within the European Retinoblastoma Group. This is all the colleagues that participated, and I thank them. We have no financial interest to disclose. European Retinoblastoma Group is a partnership between professionals, families, and patients involved in the care of RB or affected by RB. The goals are to share and disseminate the knowledge and experience on the disease within Europe, to identify the problems of RB management, to create a network of RB specialists from all major centers, and it is accessible to all European countries. And the goal is to share and practice guidelines and standards of quality of care. So within the URBG, there are several working groups. Imaging, you've seen some of their work, adjuvant therapies, eye salvage therapies, parents association, and so on. So this was a survey realized between 2022 and 2023 within the working group 1, and it was sent with centers in contact with the RBG and having expressed their interest in RB treatment. 21 centers were then contacted and 19 answered from 14 different countries. So what was asked was the number of RB patients newly diagnosed from January 2012 to December 2020, the number of deaths, the causes of death, detailing pineloblastoma, metastatic disease, iatrogenic or others, and the treatments the patients received. So here are the countries that answered the survey. So we've seen 19 centers in 14 countries, which makes 3,184 patients during the study period. And during the study period, 62 patients died, which makes a mortality of 1.9%. Here is the distribution of the causes of death, metastatic disease, and progression to the CNS being the main cause, but also pineloblastoma, iatrogenic, and other causes, which is the topic of a poster which is in a parallel session just now. So metastatic disease concerns 41 patients, 2/3 of the deaths, and 24 of these 41 patients had metastatic disease to the CNS. The majority of cases presented with advanced RB at diagnosis with often already extraocular invasion. But there was also a wide range of initial clinical presentation and treatments, and particularly 8 attempts of eye salvage treatment by intraocular chemotherapy, all group D or E. Specifically, one of these cases was lost to follow-up, and one case is described as, I quote, excessive treatment. But also 3 cases of patients enucleated, followed by adjuvant systemic chemotherapy for high-risk features. Interestingly, there are also several patients that are identified as coming from another country, from a low-income country, and there may be possibly more. 2 didn't have the chance to receive any treatment due to the advanced disease on arrival at the center. One center, a middle-income country, described 14 deaths due to treatment refusal, meaning education refusal. Of course, this is a study, a survey. It has several limitations. This is data from centers treating RB, not national cancer registries, but very few countries within Europe have exhaustive national databases. It is a data that comes from larger Europe, including high-income countries mostly, but also middle-income countries, and both of them receive patients from low-income countries. And there is possibly the overlap of patients due to the migration of families between the countries whenever they think it's necessary for them. Lastly, long-term mortality is not addressed. But the strength is that it's a large number of cases. It is real-life data coming from expert centers. So survival is excellent in this setting, and it confirms other studies on survival rates in European countries. Disease progression and metastasis is the main cause of death, but there are also more information on the other causes of the deaths for these children. Most of the patients that died presented with advanced disease at diagnosis, but not only, and we observed 8 cases that intraocular disease could allow eye salvage attempt with intraarterial. So where do we go now? How to progress? It is necessary to continue to improve the diagnosis because in the series there are cases of misdiagnosis. It is important to continue to improve the efforts of the therapeutic management of this disease in low-income countries. It is important to identify risk risk factors of metastatic disease when eye salvage is under consideration, and probably, I hope so, biomarkers will be the future for us and to help us in deciding when to treat with eye salvage or not. And finally, we need to answer the question, when do we stop treating and try to preserve the eye, because we don't know when to stop and there is no consensus at this stage. So I will finish thanking again all the persons within the group that answered the survey and all my colleagues. Thank you.
Thank you, Livia. We continue now with Dr. Samir Farouk Said, late metastatic retinoblastoma, truly metastasis, or a poorly characterized second malignancy. I think because I don't have time here. Let me see.
Good evening, everyone. I'm presenting this research on behalf of my mentor and collaborator, Dr. Ida Dunkel, and I'd just like to thank the organizing committee for accepting our research here for presentation. We know relevant conflicts of interest to this presentation. Stage 4A metastatic retinoblastoma is usually an early event. However, rare cases, and this has been defined, I think, differently in different publications, of late onset stage 4A metastatic retinoblastoma have been reported. So we wanted to clinically characterize a series of stage 4A retinoblastoma patients and understand whether patients who have late metastatic disease were inherently different from those who were developing metastatic disease early on. So for this, we undertook a retrospective analysis of all patients treated at our center who were diagnosed with stage 4A retinoblastoma at Memorial Sloan Kettering Cancer Center in New York. These patients were diagnosed with metastatic disease between February 1993 to March 2023. And we use the definition of late metastatic disease as more than 13 months from the last treatment for intraocular disease, whether that was enucleation, radio, or chemotherapy. And all of the patients with metastatic disease were treated with intensive chemotherapy multimodality, including high-dose chemotherapy with autologous stem cells, with or without involved field radiotherapy to sites of bulky disease or residual disease post the high-dose chemotherapy. So these are the results of our analysis. 29 patients developed early metastatic disease, the majority of whom had unilateral disease. There were 6 patients who developed late metastases at a median of 57 months with a range of 24 to 82 months. 5 had bilateral disease and 1 unilateral, but all of these patients had germline RB1 disease. 14, so half of the 29 patients with early metastasis had orbital involvement, but none of the late metastasis patients had orbital involvement. And the sites of late metastatic disease were either solitary bone only in 2 cases, bone and marrow involvement in the other 2 cases, and then bone and liver or lymph nodal involvement in the other 2 cases. And then when we looked at clinical risk factors, we found that there was no evidence of an association of early metastatic disease or late metastatic disease with the survival based on this Kaplan-Meier estimator. And none of the other clinical risk factors also had an association, including the age at the initial diagnosis of retinoblastoma, the sex of the patient, and with or without orbital involvement. The late deaths that were seen in our cohort were primarily because of secondary malignancies. These happened usually 5 years from the end of treatment for the metastatic retinoblastoma. 3 of the patients had osteosarcoma within the radiation fields, and 1 patient had a glioma. So in conclusion, late onset stage 4A retinoblastoma metastatic disease includes primarily a dominant bone lesion, but never involves the orbit. It is potentially curable with a regimen that includes intensive multimodality therapy, which includes high-dose chemotherapy with stem cell rescue with or without radiotherapy to the involved bone, and then seems to occur exclusively in patients with germline retinoblastoma 1 mutations, suggesting the possibility that it could represent a poorly characterized second malignancy rather than true metastatic disease. However, I think we need to get to the bottom of this, and so biological investigations are planned in conjunction with our collaborators at the Institute Curie to address this question. Thank you.
Thank you, Dr. Samir. Thank you. We continue now with Ms. Miki, and will speak to us about the RB Neuro QOL study.
Good afternoon. I am Mieke Ouwendijk and I am a pediatric psychologist at the Retinoblastoma Expert Center of the Netherlands. And it's an honor to present to you our preliminary findings of the RB Neurocall study, also my PhD project. We have no financial disclosures.
Go to the mic.
Put the mic up. Sorry. Do you understand? Yeah. I'll repeat. I am a pediatric psychologist of the Retinoblastoma Dutch Expert Center. The RB Neurocall study is an ongoing study, and we expect to be done in 2027. We include the retinoblastoma survivors, but also, excuse me, risk carriers, the patients, the offspring, siblings of the retinoblastoma survivors carrying a genetic risk. And they were screened at our hospital, at our center, with, under general anesthesia. I will present to you the most up-to-date findings. Since our abstract submission, we included a little bit more participants, so I will present that findings to you. As a psychologist, but my whole team is very interested in the quality of life, one of the most important patient-reported outcomes, and several underlying factors are contributing to quality of life, such as the biological factors, oncological treatment, repeated anesthesia, neurocognitive functioning, psychosocial functioning, leads to quality of life, of which we know from previous studies is declined in retinoblastoma survivors. And our study aims to analyze and to identify the risk factors of those underlying factors in order to provide good care to lead the retinoblastoma patients grow up as a normal as possible child into adulthood. At this moment, we included 47 retinoblastoma survivors and 19 risk carriers. Some were blind, 33 underwent enucleation, and additionally or solely 12 underwent chemotherapy, 11 radiation. At this moment, we do not have the numbers regarding the laser therapy or cryotherapy. Since it's very short time, I will only focus on the cognitive functioning. We have a very large neuropsychological assessment covering most cognitive domains, such as intelligence, processing speed, attention, visual motor integration skills, working memory, language, also executive functioning, which is part of these several domains in terms of attention switching, working memory, and language production. And when we look at the first results, only at 3 domains, there are significant different outcomes when we compare our group, the retinoblastoma survivors, to the risk carriers, but also when we compare them to the Dutch healthy population. And regarding verbal comprehension, language skills, it appears to be slightly better in our group. As you can see, it is well within the yellow bar. That is the normal limit. So you can debate whether it is clinical relevant. Also, it might be a bias since we have very lot highly motivated participants who want to be part of our study. But nonetheless, it is good news. Auditory processing speed, we find that they are a little bit slower in reaction to sound. However, still within normal limits. So here again, it is the question whether it is clinical relevance. They're still doing good. But then visual motor integration skills. That appears to be poor, especially in the survivors, but also in the risk carriers. So we have to look further to have more data so we can differentiate between the several treatments, whether this is due to treatment, perhaps even to the anesthesia they had, but it is also an eye condition, so we have to rule out that it is visual ability that we are measuring. In that case, then it is interesting that perception is still good and within normal limits, while integration necessary for writing, drawing, fine motor development is lagging behind. So all in all, in conclusion, we see that especially verbal comprehension is good, auditory processing speed is a little bit lagging behind, but not that much and still within normal limits. Visual motor integration, we need to look into it, what it means. But apart from that, attention, memory, learning abilities is still good in our group. So rather than the cognitive profile, we expect, based on the current findings, that more psychosocial functioning leads to a declined quality of life, such as the treatment, the associated anxiety, pediatric trauma, the stress they endure during treatment. Of course, I'm not doing this alone. We have a very good interdisciplinary team, and our study was funded by several Dutch funds. Thank you very much for your attention.
Thank you, Smiki. So we continue now with Dr. Asna, treatment outcomes and late effects in retinoblastoma survivors.
Good evening, and thank you for this opportunity. I'm a pediatric oncologist, and I'll be quickly taking you through the treatment outcomes and late effects on our retinoblastoma survivors, what we do in our survivorship clinics. So if you look at the entire spectrum of pediatric cancers, retinoblastoma constitutes about only 5%. But India is taking almost 20% of the global burden of retinoblastoma. And our center is taking a huge burden as well. For about 450 new cases that we see of the entire childhood cancers, almost 21 to 25% of cases it is taken up by retinoblastoma. Well, simply because of the referral bias, but ours is one of the large volume centers which is taking the burden of retinoblastoma, associated with poorer outcomes, as is known to all in the LMICs, where the burden of extraocular disease is high with poorer outcomes. WHO is again identified, as was highlighted in the previous talk, retinoblastoma has been identified as one of the key tumors which can, if be tackled, can improve the overall outcome survival of childhood cancers. Now focusing on survivorship, why is it important? Because it translates into decades of life saved for every child with cancer. And as we know that with improved survival, there is a growing population of childhood cancer survivors. But then it comes at a cost because of the occurrence of late effects and chronic health conditions. And a clear correlation, a temporal correlation exists between the exposures and the occurrence of late effects and chronic health conditions. So for us pediatric oncologists, the focus from cure at all costs now has shifted to equivalent cure with minimal cost. All childhood cancer survivors, be it whatever cancer, are at higher risk as compared to the general population or controls for chronic health conditions. The dotted line that you see below, the black one, is for controls of general population, and all the above represent one of the cancers. And all survivors of all childhood cancers are at higher risk of chronic health conditions, which could involve any organ systems, which are popularly known as late effects, and thus there is a need that childhood cancer survivors need a systematic long-term follow-up, and thus this was our aim to project the long-term outcome and follow-up of retinoblastoma survivors at our pediatric cancer survivorship clinic. We have a registered clinic, weekly clinic, that is the PCSC, that is the survivorship clinic, and and this data that I'm going to present is part of the overall cohort. The retinoblastoma cohort is part of a larger cohort, it's part of a larger study, the childhood cancer survivorship study, which is ongoing since 2016, and we are building up the first childhood cancer Indian cohort of childhood cancer survivors. Data is captured with regard to demographics, growth, all the treatment exposures, the cumulative doses of chemotherapy, radiation, HSCT, etc. All are captured. Diseases outcomes are documented. Late effects, including growth, psychosocial issues, as was pointed out earlier, occurrence of a second malignancy, rehabilitation, inclusion into the society, advocacy on the healthy lifestyle, vaccination, genetic counseling, genetic predisposition, all are, and the surveillance plan that is made up for a child, all is tackled and managed in these late effect clinics. And it's a personalized plan that is given by a whole committed team of oncologists, social workers, psycho-oncologists, nutritionists, all from the late effect study team, and we run a dedicated clinic, and a comprehensive summary is given at the end of treatment. Just to give you a glimpse, for example, an RB child will be exposed commonly to chemotherapy, etoposide. Above you see the drugs, and lower down you see the late effects that can occur with etoposide, a secondary leukemia with carboplatin, a hearing deficit, a cognitive impairment with cyclophosphamide, if at all used, secondary leukemias and fertility issues. So also anthracyclines, radiation, which commonly lead to neurocognitive deficits, contractures, second malignancy, and so on. With also for there are effects due to enucleation, surgery, and of course if there is a heredity or a familial predisposition. And once we have the entire spectrum, we assign a risk, and a surveillance plan is made, and a long-term surveillance plan is made, and the children are followed up in a dedicated way in the survivorship clinics. Now coming to the result, these are dedicated to a period of between 2016 to 2024, part of the registry and the cohort that I just told you. About 293 patients, eyes were 391, majority were males, extraocular disease comprised about 30%, bilateral was 36%, family history was present in about 9%, median age of diagnosis was 2, a little earlier, understandable with the bilateral disease, and the median period of follow from diagnosis was about 4.9 years, and from end of treatment was 3.8 years. Majority were from a lower socioeconomic strata, as was even highlighted in one of the earlier talks. Regional variation was known in our set of patients, possibly because of referral bias. Some centers had higher footfalls for the disease and some had lower, but then maybe this could be related to the referral. Now coming to the exposures, which is one of the most important aspects of long-term follow-up, which translates into late effects. Chemotherapy was our strongest or our heaviest exposure. Commonly drugs, as you all know, are carboplatin, etoposide, and vincristine in various doses. 97% of our patients who were referred to us, whom we managed at our PCSC, received chemotherapy, followed by surgery. Enucleation was done both for intraocular as well as extraocular disease, followed by radiation, which was more done for the extraocular disease. A combination of therapies was also offered because of the disease profile, and amongst the combinations, chemo and surgery was the commonest combination modality that was used for our patients. If you look at the outcome of our patients, that was 293, it is heartening to see once they are in a systematic follow-up, 88% of our patients are alive and without disease, 5% relapsed, but then again were retreated and are alive, are a part of this cohort under follow-up. Those who expired constituted about 4%, and 3% were lost to follow-up. These were translated into survival curves. As you can see, the first curve represents the overall retinoblastoma survival, and the other one represents the blue one represents, understandably, for the intraocular disease, where the survival was better as compared to the extraocular disease. Growth was affected in about 30%, being a pediatric population. These are our concerns. They become malnourished, their height and weight gets compromised. Prosthesis was used about by 58%, but then the problems that we faced, that prosthesis were either ill-fitting or they were poorly maintained at about 19%. Socket problems secondary to the surgery as well as to the radiation that was offered, the problems occurred in about 58%, and what we observed were either there was a contracted socket, hypoplasia, thysic bulbi, or midfacial hypoplasia. The other problems that we observed were squint, hearing deficits, problems with vision. Reproductive dysfunction is now increasingly being recognized as the children are growing older and attaining puberty, and this becomes one of our important concerns. And second malignancy was seen in this cohort in 2 of our patients. One had Hodgkin's lymphoma and the other had acute lymphoblastic leukemia. Both were treated. Hodgkin's lymphoma has been retreated, is again a survivor, is doing well. The ALL patient requires a very long treatment for 2.5 years and about to complete, and is at present in remission. These are some of the pictures which shows the deficits that we face. But on the right side that you see that now with improved availability of processes, we are able to provide customized processes to some of our patients. As highlighted in the other talk, this is another area of concern, the psychosocial and cognitive assessment done by a psycho-oncologist in our team. And the deficits, in the interest of time, I'll not be touching upon, but then deficits are identified in the psychosocial, cognitive, and behavioral domains, and the age-appropriate tools are used, and remedial measures are advised for these patients. Genetic testing and counseling is done as on a case-to-case basis. Predominant concerns being if there is either a family history or age of onset less than 2 years, multifocal or bilateral. And as you can see, just a glimpse of 5 patients where we could identify the RB1 gene. And of course, then we offer, since these are children, often these are the first or the second child of the family. Then if there is a need, then we also do subsequent testing for the parents or for Sanger sequencing. And if the mother so desires, we do a tonic villus sampling if she is pregnant and she so desires. Otherwise, we follow a surveillance plan as the risk of recurrence exists. And also we advise on a surveillance plan for the sibling of the family. In survivorship, healthy lifestyle is an important concern. Besides advocating the others, worth mentioning is the vaccination that we have to, give to these patients for hepatitis and HPV, because these are 2 vaccinations which will prevent these children from a second neoplasm. Role of philanthropic organization is also there as they support us in these many domains. So to conclude, the paradigm of successful cancer therapy is the balance between oncological efficacy and toxicity or the occurrence of late effects. Late treatment-related complications justify the long-term systematic follow-up of childhood retinoblastoma survivors and importance of after-treatment survivorship clinics. There is a need for awareness towards the existence of late effects. Thank you, and I acknowledge the support of the entire team. Thank you.
Thank you, Ranjana. Thanks all the speakers for the excellent talks. Before we go to the audience for the questions, we have 2 questions in the application for the speakers. First is for Dr. Ferouz. Dr. Ferouz, would you enucleate if optic nerve invasion is minimal? This is the first question for you.
Optic?
Yes, would you enucleate if optic nerve invasion is minimal, less than 5 millimeter?
So if it is just retrolaminar, probably I would enucleate with a long optic nerve stump. But if it is longer, I would go ahead with this high-dose intensive multimodal treatment protocol, because they can be even skip metastasis in retinoblastoma. So for us, survival really matters. And once, if the cut end of the optic nerve comes positive, it's a very, very bad dismal prognosis. So I wouldn't regret as a treating specialist on that. Yeah, I wouldn't take risk. But if it's just retrolaminar, probably I will enucleate with a long optic nerve stump.
So how many millimeters is safe on an MRI?
Well, I have not done a study on that specifically to give you evidence, but anything like, beyond the posterior surface of the globe, if I feel the thickening is just behind the posterior surface of the globe, probably I might go ahead and cut the enucleation and look for histopathological high-risk factor for the optic nerve involvement, and then think of a radiotherapy post that.
And you base that on enhancement, or do you base that on thickness? What is the feature on imaging that makes you nervous?
The thickening of the optic nerve.
Thickening, not the enhancement.
Yeah, and the extension. Yeah. It's a good thing to look upon. Maybe we can do a study on that. Yeah. Thank you. And
there is one more question for you. Dr. Yes. Okay. So, involvement of more than 5 millimeter retrolaminar optic nerve invasion in imaging. What would be the best treatment protocol, orbital or standard treatment?
More than 5 millimeters, we just got the answer right away. So we would go for intensive multimodal treatment protocol and radiation. Thank you.
Thank you.
Okay, once again, thank you to all the speakers. I think we had a really very, very interesting session. Now, the question from the audience to the speaker, it's open. We have plenty of time, it was even better than Swiss timing, you respected
I have a question for Dr.
so
Mal.
well.
I have a
So
question
we have plenty
for
of time. Please.
Francis, I have a question
Mashwin,
for Dr. Annette. Yeah. Very nice talk on cystic, or is it cavitary pineal gland? Are they truly lined by epithelium? And maybe a pathologist can tell us, because with retinoblastoma, we see only cavitary. We don't see cystic retinoblastoma. And I was just wondering, what's the true term?
I hope that Pim de Graaf does agree with me because he knows everything from MRIs. Cystic is cystic, so it's only a very thin line. And he also told me that it is common in the normal population. So you have to see the difference with a suspicious cystic pineal gland, which is thicker and a little bit bumpy and things like that. So I think cystic is cystic, only a cyst.
Okay, and your current protocol for doing MRIs in germline mutation patients, do you go MRI twice a year until 4 years or until 5 years?
Now that's the difference, I think, a little bit with Europe or probably the Netherlands and probably the United States. I think screening you have to do if it makes sense, but this is only our opinion, and it's it was a prospective study by the ERIC group, the European radiologists with all retinoblastoma centers. And then with screening, you don't know the interval, and what you find by screening are probably the more benign one, and the real tough ones, aggressive ones, come in between with symptoms. Dus it's really difficult to save lives with screening. So the message of this study is, and it was also published, that suspicious pineal glands for trilateral, you have to follow up. And a lot of the non-pineal trilaterals are already found a diagnosis. So when you have eye disease, you have, of course, also scanned the brain, and then you find the non-pineal trilaterals.
Thank you.
Is there data to support that screening improves survival?
That's a good question.
Well, that's the question.
I'm just saying that's a wonderful question. I mean, you need to look at cost versus benefit. You're talking about series of MRI that you're going to do to see this pineal gland tumor. So in India, countries like India, it's very, very different. MRI is the most expensive investigation.
And to Dr. Reddy or Dr. Annette, has the prevalence of pinealoblastoma decreased since we're now all using systemic chemotherapy and not external radiotherapy?
I'm not sure Didi Fabium is in the audience. We like to analyze it in the Netherlands, and one of our PhD students is busy with it, but we only a small country with a long follow-up. But I understand that in the RBNet study from 2025, 24, which is coming, they also include the incidence of trilateral. So probably we know more. And you know the discussion in the literature between us, if it is because of the systemic chemotherapy that you probably see less trilateral, or is it because of we do not irradiate very young patients because of familiar retinoblastoma? But we know the discussion, I suppose. So that's a question.
I'm in this field for the last 3 decades. So the incidence, certainly I know we need to evaluate, we need to look at the data. But 2 decades back, we used to see quite often trilateral retinoblastomas. Of late, they have been very, very less. I would ask Dr. Swati and Dr. Santosh to consolidate my statement.
Same in the States. We hardly see it.
Yes.
We hardly see trilateral.
I think maybe because that the usage of chemotherapy is more in advanced retinoblastomas.
And in the 70s and the 80s, there were a lot of trilaterals, familiar retinoblastoma, diagnosed and treated very early, from 1 week old, with external beam. But now systemic. We will see.
Is Dr. Rita around? Right. So if I may ask you, that's a wonderful paper that you presented about retinopathy, radiation-induced retinopathy. So, in a case of a retinoblastoma, we include the entire retina as of now in the treatment field. But for the lesions, localized lesions like localized lymphoma, lacrimal gland carcinoma, or a solitary fibrous tumor, if the child requires radiation, which part of the retina is very, very sensitive? Because the doses that we deliver are quite high, and invariably that part of the retina is going to get seriously affected.
So, yeah, as I presented that the risk would be higher in depending on the location of the radiation. The more posterior the irradiated area, then the higher the risk of the radiation retinopathy. Yeah, and also the larger the irradiated dose, irradiated area, then the higher the risk of RR. I don't know in other cases, but that my experience in retinoblastoma.
See, as a radiation oncologist, I would be more interested in saving the life, controlling the tumor. So probably part of the retina we would like to sacrifice by delivering 6,600 centigrade with the new technology presently available. So I was discussing with Dr. Santosh the other day. He was saying, don't bother about retinopathy, you do your job. So I really wonder, the vision is also equally important. How much is that, part of the retina? Let's assume we are treating lacrimal gland carcinoma. We go up to 6,600 centigrade to 7,000 centigrade. So part of the retina we include in the treatment field. We invariably gets into the field. So what's your opinion on it, Dr. Karol?
So when we do radiation, I'm not a radiation oncologist, but when we do external radiation, which we rarely do, back in the day, we used to give 4,000 centigrade.
That's for the retinoblastoma. I'm talking about lacrimal gland carcinoma.
Yeah, we would go up to 60 grade.
Yeah, in that regard, definitely retina cannot tolerate that kind of a dose. So
Yeah.
what's happening with your patients?
So we don't give external beam radiotherapy, but we do use plaque radiotherapy for recurrences, and we go up to 35 to 40 gray with plaque radiotherapy. But the closer you are to the optic disc, the more likely you are to get optic disc swelling, central vein occlusion, neovascular glaucoma, vitreous hemorrhage, And I would say the same thing to you as a radiation oncologist. Do your job, because our goal here is to save the child's life.
Dr. Reddy, since we have a radiation oncologist in the panel, we are lucky here today. So do you think giving an intensive IMRT and gamma knife, does it make a difference in causing damage to the surrounding tissue?
Yeah, certainly with stereotactic radiation treatment, we have 0.1 millimeter accuracy of the lesion. So certainly it made a huge difference. If you look at the data two decades back and the last decade and the present, invariably the tumor control rate is much, much higher. I'm talking about other than retinoblastoma.
Yes,
so
sir.
most of the tumors,
I'm talking about orbit.
Optic nerve meningiomas, optic nerve gliomas, optic nerve sheath meningiomas, and solitary fibrous tumors, rhabdomyosarcoma. In all these conditions, we do higher dose of radiation. And with this technology of stereotactic radiotherapy and stereotactic radiosurgery, we are able to deliver higher doses with less morbidity.
So that would be the choice of
Yes,
radiotherapy
obviously.
that you would. Yeah. Thank you.
Ashwin, I think it's you.
Yeah, sorry, I just had a clarification to one of the statements.
Can you
that
speak
was said.
louder, please?
Sure, yeah. I just had a clarification about one of the statements that was made, and I didn't want there to be any confusion, so I just want to read out that the CT4A definition and CT4B definition doesn't really differentiate between the optic nerve and the orbital tissues. The intention of the definition of CT4A, which reads radiological evidence of retrobulbar optic nerve involvement or thickening of the optic nerve or involvement of the orbital tissues, is only to describe minimal extraocular disease versus overt extraocular disease, and that was the only intent. CT4A does not define optic nerve disease alone, and CT4B is not orbital disease alone. It's more just about what is radiologically apparent versus what is clinically or overt in some way. That's all. Thank you.
Can I just make a comment, Dr. Carol? Yeah. Thank you, Ashwin, for the clarification. We already had 50 messages to the presentation. So because as in T4A, where there is, so I think there is a little bit of a, modification that is required in probably the wording. It was not the intent. So the T4A says the radiological evidence of optic nerve thickening, or optic nerve extension. And then T4B states extraocular tumor clinically evident with proptosis or an orbital mass. And we all agree to the point that as far as prognosis is concerned, optic nerve, you agree, optic nerve has a bad prognosis. So probably T4A can be clinical or radiological evidence of extension, orbital extension of the mass, and T4B can be either clinical or radiological evidence of orbital extension and optic nerve extension. So prognosis-wise, we have T4A, which is just the orbit having a better prognosis, and T4B with an optic nerve involvement has a worse prognosis. And we have not mentioned about millimeters or whatever, we don't have any studies mentioning 1 millimeter is risky, 2 millimeter is risky, or 10 millimeters is risky. But whenever there is an optic nerve involvement and thickening, I think the prognosis is worse. Maybe it's just the modification of the words. Maybe it's not the intent.
Yeah.
Thank you.
Well, thanks for that, and I think we should sit and talk about what could be there in the future. It needs to be evidence-based, so thank you.
Okay, Ellen? Yeah?
Yes, I have a question for Dr. Mieke. Thank you, that was an excellent
Can you
talk.
speak loud?
Yes, sorry about that. Could you tell us what was the PROM measurement tool that you used? And also, could you comment on the composition of the study population in terms of race or other social variables?
Yes. Thank you very much. I will adjust my microphone this time. For the for the verbal comprehension, we used the WISC and the WISE. It's a global-wide intellectual test used in a lot of countries. And we used the Berry, so that's also, it's to assess visual motor integration skills. When we set our neuropsychological tests, we used tests that are usually wide, nationwide, globally. So we can compare with other studies. It's not that much done in retinoblastoma survivors, but it is done in other cancer survivors, so we have a good comparison. At this moment, since verbal comprehension is that high, we are very careful by interpreting the results, and it could be a bias. On the other side, there has been studies previous that indicate that intellectual functioning is high in retinoblastoma survivors. So we have to see in the whole population. We have a lot of patients who are still, we are still assessing whether that stands and what the chances of the changes are in the future. At this moment, we see just a normal population. When we look at the socioeconomic status, it's just a normal representative of the Dutch population. So, so we are very cautious because it's very premature in our study, but we will see. Thank you.
Thank you. Andrei?
Thank you. A few words concerning stereotactic radiosurgery. In Moscow, we have an experience of 22 eyes treated with stereotactic radiosurgery as a salvage treatment in heavily pretreated eyes, and 70% of those eyes were saved. And it is a very very rare situations for those treatment, and we have 22 eyes within 9 years only. But it is a suitable approach, and we use about 20 grade to 50% marginal isodose. Thank you.
May I ask you, what are the indications for its ocular radiotherapy, right? What are
Microphone.
the indications for this?
Please, microphone.
No, I was curious to know what are the indications that you have for ocular radiotherapy for retinoblastoma nowadays.
I underline that is stereotactic radiosurgery. It's not convenient radiotherapy, and the main indication is no potential for traditional treatment, and first of all, vitreal retinoblastoma, vitreal seeding, without answer to intravitreal chemotherapy.
Okay, thank you.
Can I ask a quick question of Dr. Lombruso? Could you expand a bit on the cohort that were treated with intraarterial chemotherapy and died? Were these patients that probably had such advanced disease that probably shouldn't have had intraarterial in the first place, or these patients that refused enucleation? And then as a quick follow-up, the nature of the death, was it 4A, was it 4B, was it CNS? Was there any pattern from that perspective?
Yes, thanks. That's a very good question. No, these were patients with intraocular morphine. That's one of our centers, so I can tell you it's not very advanced. It wasn't usual intubation. One was lost to follow-up and came back with extended extraocular disease. And other patients had group 3 or E, but not really very advanced disease. And they developed, for some of them, metastasis 1 year after the completion of eye treatment. It was doing well. So I think there's something to look into these cases, because this is very rare patients. We are pulling all together. That's why maybe it takes up this high salvage and then with intraarterial. All of the bilateral cases.
So likely subtherapeutically treated high-risk histopathology that wasn't addressed with intraarterial.
It wasn't due to poor follow-up?
Just one.
Just one.
Okay, great. Thank you for contributing to the discussion. I think it's time now to give you the top 3 presentations. So the winner is Annette Moll. Annette Moll, please. I ask all the awardees to come to the podium. So the second is Ferouz. Please come to the podium. Congratulations. And the third is Dr. Yazer. Please come to the podium.
I request the moderator and the panelists to join the chair and the winners for a photograph. And we've come to the end of our scientific sessions for today. Next we have our Travel Grant Awards, and for this I call on to stage Dr. Dan Gombos, Dr. Jessie Perry, Dr. Victoria Dai, Dr. Santosh Honavar and Dr. Ferouz Manjandabida.
Don't forget your stuff. can say that. I can't. I saw. So we'll call up the members of the Travel Award Committee.
Where should we sit? Where should I sit
all the delegates, I have an announcement for the gala dinner tonight. I would request all of you to assemble in the lobby, and we have a gala dinner in the lawns of Taj Heritage, and we will be starting by 7 p.m. So if you can come in a comfortable, semi-formal, casual dress. It's an outdoor, it's a seaside sunset view at 7 p.m. at the lobby. We have a vehicle, a coach will be taking you, which is just 3 minutes drive from Taj Convention. So see you all at 7 p.m. at the lobby for the gala dinner. Welcome. Thank you.
As soon as we have that, then we'll go. Hello, everyone. Thank you all for being here for our travel grant ceremony. We have to move quickly so that we can get to the dinner. So what's going to happen is I'm going to read your name. If you can come off, we are not taking pictures one by one. We are going to take a picture in a group, okay? And so we're going to start with this group first, please. And Dr. Gambos will give you your award. Dr. Cezinos for the Victoria Cohen Travel Grant, please. And next person, Vicki, just take the next one, please. Dr. Garg, the Victoria Cohen Travel Grant. Okay. Dr. Senner, the Lynn Murphy Travel Grant. These are our special named grants this year. Thank you so much. Dr. Ushakova, the Judith Kingston ISO Travel Grant. Again, these are 4 newly named travel grants this year. This is quite an honor to be selected. Dr. Manquez, the Hungerford Travel Grant. And Dr. Aikut, the Ellsworth Travel Grant. We're going to take a picture with this group, please. The next group that we're going to go through are the Knights Templar. So if you know that you have Knights Templar, if you want to come to the front once we have a picture with this team. Yeah, I'll just say it and just hand it off, okay? So Knights Templar supports ISO every 2 years with travel grants for countries where there is a Knights Templar presence. Dr. Zurowski Dr. Yeager. Someone take this, please, and hand this to Dr. Yeager. Dr. Yelapantula. Dr. Michael Yu. Dr. Basil Williams. Dr. Ritesh Verma. Thank you so much. Dr. Tagami. Thank you guys for understanding we cannot do solo pictures with all of you, but we love you. And we gave you money. Dr. Sargenti. Dr. Samir Farouk Sai, Knights Templar awardee.
Just line up, please.
Dr. Suzuki, please line up because we need a picture for all of you for the travel grant. Dr. Suzuki. Dr. Sato. Please continue to line up.
We do need a picture.
Dr. Ramasubramanian.
Please come up on the stage.
Dr. Drishti, Miss Drishti to be Dr. Pandya. Dr. Sapna Patel. Drishti. Dr. Aguro. Dr. Zachary Oki. I think he's not here. Dr. Scott Oliver. Dr. Daniel Ortiz Morales. Dr. Vinit Mahajan. He's not here. He left already. Dr. David Anacona Lazama, please. Dr. Lanza. Good job, you guys. Crystal Law. Dr. Kettler. Mr. Kase, Soturo Kase. Dr. Kakasari, thank you guys so much. Dr. Carol Karp. Dr. Herwig Carl. Dr. Mora Di Nicola. Dr. Nanjia. Dan Gambos. Dr. Forrester. Dr. Frauchis, Dr. Maya Iger Moskovich, Dr. Lauren Dalvin, Dr. Cernicero Espinosa, Dr. Chow. Photographers, be ready, we're almost there. That one, thank you. Dr. Belfort. Dr. Priscilla Balalai and Brianne Brown. Okay, these are our Knights Templar awardees. If we can please take a picture for the crew.
We are so grateful for Knights Templar. They have provided an enormous number of travel scholarships, and we appreciate all of their support. We know it makes a difference.
All right, Knights Templar. Someone, oh, we need to be in this. Okay, you guys, good job, Knights Templar.
We need to thank Dr. Jessie for arranging this fund. Here.
It's fine. I'm so delighted that everyone gets to benefit from the wonderful support of Knights Templar. And the next will be the Eye Cancer Foundation. The Eye Cancer Foundation has also provided generous travel support with a focus on trainees and doctors in low and middle income countries. Will be the same thing, please. I will announce your name. Come on up and please do not leave until we take a picture for the team. Dr. Yazir, thanks you guys so much. Dr. Verma, Dr. Unadkat, I'm really sorry if I butcher your name. It's not intentional. Dr. Telukunta, Dr. Thinlas, Dr. Shakyevich, Dr. Sachdeva, Dr. Shrivastava, Dr. Pershad, Dr. Laba, Dr. Farhina Kulsum, Dr. Kavita, Dr. Joshi, Dr. Hiridia, Dr. Heror, Dr. Anuruddha Heror, Dr. Shirali Gokuro. Thank you guys so much. Dr. Shagani, Dr. Cheda, Dr. Bagchadani, Dr. Rolika Bansal, Dr. Balichandran, Dr. Aurora,
Please come up.
Dr. Atasef, Dr. Amobi, Dr. Ayushi Agarwal, Dr. Ashwita Alva. There was just an Ayusha. I just handed it to someone. Dr. Ayeshwara Agarwal and Dr. Ifioma.
Dr. Ifioma. So we just want to thank again the Eye Cancer Foundation. They have now provided funding for multiple years, and their focus has been on low and middle income countries. They've done a wonderful job in supporting us. We thank them, and we thank Paul Finger, who's really led this endeavor and continued to provide support.
If you're just come on up for the picture, please. Evandro is not Eye Cancer Foundation. Crystal, can you help me, please? They might be in here, but just come on up right now. Great, come on up. She didn't have a thing. No, it's a long story. She can take a picture. That's St. Jude. Wait, should we be up there?
Do we?
We'll figure it out.
For the second year in a
Something we'll
row,
figure it out.
St. Jude Global has provided an enormous amount of funding and support for this meeting. We want to acknowledge again all the support they gave in ISO Africa and here again in Goa, India. So now we're going to go through our support from St. Jude Global Retinoblastoma Program. Thank you.
Good.
We can have our awardees step down. We're going to have our St. Jude colleagues come up.
Yes, thank you again to the Eye Cancer Foundation.
Over $100,000 awarded this year to trainees, mostly from low and middle income countries, and we could not have done it without the support of our donors. Thank you so much. When you hear your name, please come up.
All right, these are St. Jude Global. Dr. Geeta Naidu. Dr. Yaqub Youssef, is he St. Jude Global? Dr. Kudrat. Dr. Rah Martani. Dr. Purnima Stapit. Dr. Afori Ajay. Dr. Rita C. Torres.
Please stay up on the stage.
Dr. Jason Koh, Dr. Vera Essuman, Dr. May Delendo, Dr. Elena Cristina Nitulescu, Dr. Kahaki Kamani, Dr. Gary Mercado, Dr. Arpita Bhattacharya, Dr. Dupe Aremola Populo, Dr. Alcazabas, and Dr. Al-Haddad.
We're going to ask Dr. Verma also to come up on stage. Thank you. Aman Verma.
Dr. Aman Verma, there you go.
Congratulations.
Is this, we got the St. Jude Global team? Okay. Come, Santosh, go. Take photos, please.
The
Vicky.
Travel Awards
Haha.
Committee
Go.
really did an amazing job going through all the applicants and making sure that we met the criteria and the guidelines provided to our donors. We thank them so much for the significant amount of work that they provided. So please give them a round of applause as well.
Great. But I called her, she didn't come up. She didn't come up.
Okay, we're moving
I called
on.
her. Is she here? I called her. That's okay. We'll still take. Is she here? We'll take photos. Okay, and then presumably the final group, although if I called you or I didn't call you and you need a certificate, we'll figure it out. Just come find us, please. With the funds that are generated from the meeting, we then aim to make sure that, again, our members from low and middle income countries have support and that we support our trainees. This year, we supported 100% of trainees that presented at this conference. Okay, ISO Travel Grants. Dr. Andrea Yaraboy. Vicky. Dr. Thagard. Dr. Sundar, Dr. Soto, Dr. Susantri, Dr. Noha Soliman, thank you guys so much, you're being so helpful, Dr. Stapit, Dr. Sainani, Dr. Dwangnate, Rojanaporn, Dr. Popelin, Dr. Othman, Dr. Nasaripur. He's the one who gave it for, yeah. He wonderfully donated his grant for another person. Dr. Nurli Bekova. So thank you for that, Dr. Nasaripur, if you're still here. Dr. Mershahi, Dr. Mulholland, Dr. Lutfi, Dr. Henry, Dr. Gallo, Dr. Maria de Nicola Gianninito, Dr. Gentili, thank you. Dr. Fung, Dr. Chow, Dr. Selanglu, I'm sure that's not right, I'm sorry. Dr. Borselli, Dr. Alarcon, and Dr. Abu Kirova.
Thank you. Our ISO Travel Awards. We want to point out and we want to thank Martine Yeager, as many of these funds came from a surplus from the Leiden meeting. And so those of you that were part of the Leiden organizing meeting, this is a tribute to you that the funds that you came with helped to support trainees. We also want to again note that this is the first year we had 4 ISO named awards in honor and memory of pioneers in our field, John Hungerford, Judith Kingston, Bob Ellsworth, and Lynn Murphy, and that will go on in perpetuity. Ladies and gentlemen, our ISO Travel Award winners, if we can please take a picture. So please, thank you so much. It's now on to dinner. You must change and be in the lobby by 7 o'clock.
Wait, aren't we? Yeah, it's a walk. You walk to the
Well,
restaurant, right?
yeah, we have coaches which will take you. You can walk, and please bring your tickets with you so that you can be part of it. Yeah, thanks.
Bring your tickets. Did you hear that? Please bring your tickets. 7 o'clock. Coaches are waiting. This concludes the Travel Awards ceremony. Okay, I gotta go change.
So if for some reason you do not have a certificate, please come up and let us know your name so that we can have it printed for you.
If we can have the Grants Committee on the stage for a picture, please. The Grants Committee. Or a selfie like they do at the Academy Awards. There's always a variance. Here, wait, I have this. Garbage. Al-Haddad, that name sounds familiar. Christine Al-Haddad. She was the one from Lebanon. That was a St. George.
Non, on cache nos sacs. Ouais, c'est ça, voilà, exactement. Ouais, c'est ça surtout.